Proptosis may again mimic proptosis. We need to assess the position of the upper eyelid in relation to the superior limbus. Contralateral enophthalmos or microphthalmos can also give the false impression of proptosis. In cases of shallow orbit, like in Cruzon, where the bony orbit is small, pseudoproptosis can be there. So once we have understood that it is not pseudoproptosis and it's a true case of proptosis, there can be varied presentation of our patients. So when these patients walks into your clinic, one size doesn't fit all. So we will have to look into different clinical clues to come to an appropriate etiological diagnosis so that we can manage appropriately. So this lady, 52-year-old diabetic lady, had a history of fever, malaise. You can see a yellow fluctuant tender lower lid swelling, which was warm on touch. Further on a CT scan, you can see there is a sinus involvement adjoining area along with a medial subperiosteal abscess. So this is a typical orbital cellulitis with sinusitis with eyelid and orbital abscess, which completely recovered on incision drainage and IV antibiotics. But the case is not that simple every time. So all the cases that I will be presenting from now, they were all referred to us as orbital cellulitis with proptosis. But you will see how all orbital cellulitis are not treated the same way. So the second pearl is orbital cellulitis is just a sign. Look for other clues for specific diagnosis. So this gentleman, 43-year-old gentleman, was again referred to us with orbital cellulitis as he had the varying combination of pain, redness, swelling in the periocular region. He was also incision drainage was done elsewhere. We ordered for an orbital imaging, and what do we see here? We see a trigonal mass there which is causing bone destruction in the trigonal area. So we did a incision biopsy from the mass, and this was a case of orbital metastasis from proptosis. So you can understand what devastating consequences misdiagnosis can have in these cases. So the third pearl that I will like you to take back is that in orbital cellulitis, orbital imaging is a must to rule out any underlying tumor. Next, think of this mnemonic vein, VEIIN. It comes very handy whenever you are evaluating a patient with proptosis in your clinic. So V stands for vascular. It can be arterial like a carotid-cavernous fistula or venolymphatic malformation. E stands for endocrine, or the most common cause of proptosis that we come across in our clinic from thyroid eye disease. It can be infective orbital cellulitis. It can be inflammation, which majority of the cases are non-specific orbital inflammation, but it can also be specific inflammation like sarcoid or Adam-Chester disease or a vaginous granulomatosis. Or it can be neoplastic, both benign and malignant. So if we keep this vein mnemonic in mind, we will have a systematic approach in our clinic and evaluate a patient and come to a conclusive etiological diagnosis. Moving on to our next patient. This patient had a history of trauma. You can also see that there is an excavation of the left side of the skull. The patient had undergone multiple settings of tarsorrhaphy with no relief when he was referred to us. So corkscrew, he had pulsatile proptosis, chemosis, bruit, corkscrew episcleral vessel, and dancing Myers on applanation tonometry. All these are pointers towards carotido-cavernous fistula. So we can further go ahead and do orbital imaging. A simple ultrasound B scan can do the job. You can see the dilated superior ophthalmic vein, or here you can see the dilated superior ophthalmic vein on the CT scan here as well, and on that side the extraocular muscles are thickened. All these are signs of carotido-cavernous fistula. So for the definitive treatment, we need to take help from our interventional radiologist friends. for an endovascular embolization. This is the patient post endovascular embolization. As an ophthalmologist, our role is to manage surface exposure and secondary glaucoma. So a triad of chemosis, pulsatile proptosis, and bruit. Please think of carotido-cavernous fistula and manage appropriately. Moving on to the next case, this 12-year-old girl came to us with this acute left eye. So he also gave a history of swelling of his left eye whenever she had an attack of upper respiratory tract infection. So this history is very typical of a veno-lymphatic malformation or a lymphangioma. So on CT scan orbit, a very typical picture, ill-defined multiple cystic masses. There can be microcyst or macrocyst. They are usually transcompartmental. Transcompartmental means a part of it is intraconal and a part extraconal with air fluid levels. So this is a typical picture, and the patient completely recovered on bleomycin sclerotherapy. So the take home point there is sudden intraorbital hemorrhage in a child. Think of veno-lymphatic malformation. This 62-year-old gentleman came to us with bilateral chemosis. You can see there is bilateral eyelid retraction with temporal flare. So these eyelid signs are clenches for thyroid eye disease. Further, he also had a CT scan. You can see the typical tendon sparing muscle enlargement there. So he was an active case of thyroid eye disease. We treated him with IV methylprednisolone. So look for eyelid signs to diagnose a case of thyroid eye disease. All proptosis don't require a thyroid function test. Whenever you see the eyelid signs, you need to go ahead and do a thyroid function test. Moving on to the next case, this gentleman came to us with persistent orbital cellulitis like picture in his left eye. You can see there is redness, there was extraocular motility limitation. He had a history of fall on a stack of sticks 5 days back. Ever since then, he has been diagnosed as orbital cellulitis and been treated with IV antibiotics elsewhere. But what was missed was this episcleral nodule. There was subtenon fluid on B scan indicating that there was something underlying. So we went ahead and did a CT scan orbit, and you can see the typical air on CT scan appearance of wooden orbital foreign body. So we did an orbitotomy and removed the wooden orbital foreign body. So any orbital cellulitis which is unresponsive to conventional treatment, we need to rule out a retained intraorbital foreign body. The history is extremely helpful in such cases. Moving on to this child, a 5-year-old male. He was again treated as a case of orbital cellulitis. What was missed here is the other eye white reflex which was there. So he also had a CT scan with him which showed intraocular tumor with calcification. So this was a case of bilateral retinoblastoma. Retinoblastoma, which is an intraocular tumor, can undergo tumor necrosis and cause a clinical picture mimicking orbital cellulitis. IV antibiotics don't help in these cases. We need to treat them with IV steroids. So the inflammation came down with IV steroids. Then we did the definitive management for retinoblastoma. So the learning point here is orbital or ocular imaging is a mandate whenever we can't do a fundus evaluation. We can't just start treatment without having a look at the fundus. If we can't see the fundus, we need to go ahead and do a imaging. Moving on to the last case, 4-year-old boy presented with a very acute onset bilateral proptosis with subconjunctival hemorrhage. So on CT scan, he had bilateral homogeneous soft tissue density. This is extremely typical of granulocytic sarcoma. So we need to rule out underlying leukemia. So any rapid onset proptosis with bilateral soft tissue homogeneous lesion, rule out granulocytic sarcoma. We need to ask for a peripheral blood smear. Even if the peripheral blood smear comes negative, we need to go ahead with flow cytometry and a bone marrow biopsy too for a definitive diagnosis in such cases. Thus, to summarize the learnings, rule out pseudoproptosis. Whenever a patient with proptosis walks into your clinic, think of the pneumonic vein, vascular, endocrine, infective, inflammation, neoplastic for a systematic diagnosis. Orbital cellulitis is not a diagnosis in itself, it is just a sign. We need to observe carefully for other clinical clues to arrive at a specific diagnosis. Orbital imaging is a mandate in all cases of orbital cellulitis to clinch the diagnosis. Thyroid eye disease, you will have the eyelid signs. For carotidocavernous fistula, there will be pulsatile proptosis, corkscrew vessels, chemosis, and bruit. Intraocular tumor, fundus check is the key there. Granulocytic sarcoma, acute onset proptosis with bilateral homogeneous soft tissue density. Any orbital cellulitis unresponsive to treatment, you need to rule out a retained intraorbital foreign body. Thank you everyone for a patient listening. So with this, I will hand over the stage to our next speaker, the enthusiastic Priyanka Valvekar from LV Prasad Eye Institute, Visakhapatnam. Priyanka will be talking on her top 10 pearls in approaching a case of contracted socket. Over to you, Priyanka.
Thank you, Dr. Anusua. Are my slides visible?
Yes.
And am I audible?
Yes, clear and loud. Go ahead, Priyanka.
Yeah. So good morning, everyone. At the outset, I would like to thank the organizing committee at APOSEYECON 2021 for this opportunity. So today, one second. Yeah. So the informed consent for full face photographs and photographs have been taken. Today, I will be discussing a few learning points related to the evaluation of contracted socket. So let us all first understand what an anophthalmic socket means. So the term anophthalmic socket is defined as an orbital socket, which is characterized by the absence of an eyeball or a globe of the eye, but it includes orbital soft tissues and eyelid structures. So this, as we all know, can be congenital or acquired to secondary conditions like orbital surgery, such as evisceration, enucleation, amongst others. So when we talk about an anophthalmic socket, what are the features that are associated with an ideal anophthalmic socket? So it is the one which usually has a well-centered, appropriately sized orbital implant. 2, a healthy overlying conjunctival tissue. 3, there is adequate depth of the fornices. 4, the socket is able to hold an appropriately sized conformer and later a prosthesis that mimics the appearance of the contralateral eye and has an eyelid in position and symmetric in appearance to the contralateral eye, providing complete eye closure and enabling uniform wetting of the ocular surface and prosthesis. So if this is an anophthalmic socket, then what is a contracted socket? So a contracted socket is the one which is defined as shrinkage or shortening of all or part of the orbital tissue, leading to a decrease in the depth. Leading to a decrease in the depth of the fornices and or orbital volume, which ultimately leads to a condition where the prosthesis cannot be retained. So simply put, there is inadequate space as well as tissue loss. So now what causes socket contractions? So for the ease, let us divide these causes into 3. Preoperative causes, which includes trauma, any chronic infection, any cicatrizing conjunctival disease like Stevens-Johnson syndrome or a pemphigoid, into inoperative, intraoperative conditions such as excessive tissue manipulation and handling during the surgeries, an inappropriate size of the implant that has been used during the surgery, excessive tissue sacrifice, use of excessive cautery, amongst others, during the operative period. Now, the third important factor that can cause socket contraction are post-operative causes, which can be subdivided into those that are associated with chronic inflammation and those sockets that remain chronically inflamed in the post-operative period, those which are associated with poor hygiene and excessive handling of the prosthesis, which can also contribute to contracted socket. So now let us try to understand what is the different grades of contracted socket. So Gopal Krishna classification has, as we all know, has divided the soft tissue sockets into the following grades. So I'll just read them out so that we're aware of this. So in grade 0, or the normal socket, is the one which is lined with healthy conjunctiva and has deep and well-formed fornices as shown in this picture here. So in grade 1, there is shallow lower fornix, that is inferior fornix, or shelving as we can make out. In grade 2, there is loss of both upper as well as lower fornices. In grade 3, there's loss of upper, lower, medial as well as lateral. In grade 4, there's loss of all the fornices, upper, lower, medial, lateral, as well as reduction in the palpebral aperture in both the horizontal as well as the vertical dimension. And in grade 5, the recurrence of contraction with the socket even after repeated trials of reconstruction. So to just make it more easy, it is always important to grade a socket with that of an ideal socket, as we just mentioned, so that the assessment can be proper. So now to make it more simple, let us remember this mnemonic, which is IVF Gynac Research. So let me go through the grades again with all of you. So grade 0 is that which is lined by healthy conjunctiva, having deep and well-formed fornices. Grade 1, which is can be remembered with I, is the one where the inferior fornix is shallow or there is shelving of the inferior fornix. Grade 2 with the mnemonic V, as that where there is loss of upper and lower. So we can remember it as loss of vertical fornices. Grade 3, which stands with the mnemonic F for all 4 fornices, upper, lower, medial, and lateral. Grade 4 for G, that is global loss. Just to remember that there is shortening of all 4 fornices as well as shortening of the horizontal as well as the vertical palpebral apertures. And grade 5 for R, where there is recurrent contracted socket even after repeated trials of reconstructions. Yes. So now coming on to the fourth pearl, where once we have a contracted socket, what are the main pointers that we need to assess in this socket evaluation? So this involves assessment of the volume, assessment of the surface, as well as assessment of the prosthesis. So examination of the prosthesis in place gives us the volume. The examination of the socket after removal of the prosthesis gives us the surface assessment, and then the examination of the prosthesis as well, just so that appropriate modification, if required, can be done. So now let us try to understand how each of these can be assessed, and also identifying any predisposing factors for the contracture from history. That is, what was the primary indication of the surgery, history of any chemical injuries need to be elicited so that appropriate management can be given. So with this, let us start with how to assess the socket. So socket assessment, which involves the assessment of the volume. So as we know that volume analysis can be done by first placing a wire speculum as shown here and distracting the eyelids from the globe. So then saline is injected and the volume is quantified as the amount that can be contained within the socket till the very first drop falls out of the socket. So once you start injecting and fill up the socket, the first droplet that falls out, that is taken as the upper limit of the volume quantification. So for the assessment of the surface, there are 2 main pointers that need to be examined. One is the horizontal palpebral fissure as shown here, and 2 is the depth of the fornices. So horizontal palpebral fissure is calculated by the distance between the canthi as shown here between the medial and the lateral canthus. And for the depth, after placing the lacrimal probe in the desired fornix as shown in this external clinical photograph, the depth of it is measured at the level of the lid margin by marking the point over the probe. So basically 3 readings are taken, 3 in the upper, which includes the medial, central and lateral, and the similar corresponding regions from the lower lid is also calculated for the ease of determining the depth of the furnace. So now the assessment of the prosthesis as well remains of utmost importance, because clinical photographs with and without prosthesis in place helps us determine the plan of management, and also photographic documentation of these helps us as it allows for proper assessment. So while assessing the prosthesis, the weight, the height and the volume should be assessed. And the volume is usually assessed by the amount of water that is displaced by the container while placing it in a calibrated tube as shown here. So once the prosthesis has been placed, the amount of water it is displacing is assessed as the volume of the prosthesis. So depending on how it is appearing and what is the final assessment of the socket, one has to take a decision of whether the prosthesis modification itself will help for a better cosmetic outcome. So now how would you correct the volume deficit in case of a contracted socket? So this can be divided into primary and those with residual. Residual would be a little bit more complicated. And so first it would be important to look for what are the options for primary correction of volume deficit. So this can be done by replacing the existing implant with a secondary implant, or by placing an implant in cases where there is no implant. Second, implant exchange, like I just discussed, if the implant that is placed is not very adequate and not providing the volume that is required, then it has to be replaced. And thirdly, in cases which is associated with frequent migration and those sockets which are associated with any sort of a fracture where trauma was the primary condition, then a dermis fat graft would be sufficient to help us to recover the volume deficit. So once we have addressed the volume, it would also be important to assess and address the surface loss. So for correction of the surface loss, we usually divide the socket contraction into 3 different varieties: mild, moderate, and severe. In mild, it would mostly be conservative management, where if there is an inflammation, we usually treat it with anti-inflammatory agents and topical medications. And like I discussed, prosthesis modification. And if there is any shelving of the inferior fornix, as we already saw, it can be managed with a fornix formation suture. And for moderate grades, usually an amniotic membrane grafting can be done, or a mucous membrane graft, which is usually harvested from the buccal mucosa or even labial mucosa, with or without a fornix formation suture. And when there is severe contracted socket, that would require an extensive MMG, and also as reconstructive options need to be considered here with specialized conformers, like now more recently introduced a wrapped conformer. And finally, in a case where there is a severely contracted socket, there is still scope, there is still hope, and everything is not lost. So here it can be managed with a combination of socket 5-fluorouracil and steroid injections, as well as mechanical conformer trials, which can cause the expansion, which would ultimately aid prosthesis wear. So this can be a management option when there is grade 5 severely contracted sockets. So these are my references, and thank you very much for the opportunity.
Thank you, Priyanka. Thank you, Priyanka. Thank you, Priyanka, for an illustrious presentation on contracted socket. Next, I will invite Dr. Saujanya Yera from the young enthusiastic oculoplastic surgeon from Shankara Eye Hospital, Guntur. She will be talking on her top 10 pearls in management of lacrimal duct obstruction. Over to you, Saujanya.
Thank you, Dr. Anasuya. Am I audible? thank APOS organizing committee to give this opportunity. Uh, I'm going to speak on top 10 pearls in managing a case of lacrimal duct obstruction. A detailed history provides a clue to appropriate diagnosis, especially it's important in children where the diagnostic modalities like syringing is not possible. Epiphora in CNLDO usually presents a few days after birth, shortly after birth, mostly constant associated with mucoid or mucopurulent discharge. So epiphora which presents a few months after birth should rule out other causes of watering. If there are symptoms of photophobia, should rule out corneal irritation or ocular surface disorders. Or congenital glaucoma, and you should rule out history of trauma to adnexa or nose, naso-orbitoethmoidal fractures, or history of any nasal or sinus surgeries should be ruled out to rule out secondary acquired nasolacrimal duct obstruction. Usually mucocele reveals a swelling below the level of medial canthus. So any swelling above the level of the canthus should raise the suspicion either a malignant sac swelling or any mass arising from the surrounding structures like ethmoidal sinus, nasal cavity or cranial cavity. As you can see in the first patient, there is a swelling at the medial canthus with watering. A CT scan suggestive of a mass lesion in the maxillary sinus extending into right nasal cavity, ethmoidal sinus and extending into the orbit. It was a sinonasal malignancy proven as squamous cell carcinoma. In the second picture, a young child with unilateral telecanthus on right side with history of watering, showing a mass in ethmoidal sinus extending into the nasal cavity, causing secondary nasolacrimal duct obstruction. Plus applying pressure on the lacrimal sac area in lacrimal fossa in a slightly backward and upward direction. Plus positive is indicative of a chronic dactylosis status with NLD obstruction, and no further diagnostic modalities are necessary. If there is clear mucoid or mucopurulent regurgitation suggestive of NLD obstruction, regurgitation is positive with blood-tinged fluid suggestive of either dacryoolith or lacrimal sac tumor. There is no regurgitation on pressure with distended sac, and the sac remains dilated suggestive of an encysted mucocele. There is no regurgitation of fluid through the punctum while pressing over a distended sac, but the sac empties into the nose suggestive of an atonic sac or internal fistula. Congenital nasolacrimal duct obstruction, 96% of the patients will resolve by 1 year of age group with conservative management. The conservative management is a Krigler's massage. The aim is to increase intraluminal hydrostatic pressure and direct it downwards to rupture the membrane at the lower end of the nasolacrimal duct. So we should demonstrate to the parents, and we should encourage the parents to do it under supervision to increase the correct technique of sac compression. Pressure should be applied directly over the lacrimal sac area, just inside of anterior lacrimal crust below the medial canthus. 10 times per session, 4 to 5 times are needed. So the factors which help in increasing the success with the conservative management are starting an early massage, correct technique of sac compression and compliance is needed. We can wait for 9 to 12 months with conservative management. If there is no if the symptoms doesn't resolve by 12 months of age, we can go for probing. Probing is usually performed under general anesthesia. A nettle chip punctum dilator is used to dilate the upper punctum, and appropriate sized Bowman's probe is gently passed through the upper punctum, first towards through vertical canaliculus and horizontal canaliculus, and then bending it gently and along the horizontal canaliculus with simultaneous outward stretching of the upper lid. Once probe enters the sac and touches the medial wall, a hard stop is felt. Just retract for 1 mm and gently turn it 90 degrees to lie flat on the forehead in line with trochlea, and the probe is advanced into the sac and NLD. Downwards, backwards and laterally. Membranous obstruction can be overcome with a very gentle giveaway of resistance, and patency can be checked with a fluorescent stained saline. In few conditions, early probing may be indicated, as you can see in mucocele or dacryocele, especially bilateral dacryocele. The child may have a respiratory compromise, and in cases of acute dacryocystitis and in association with other comorbidities like congenital glaucoma. Failed probing is considered as when there are recurrence of symptoms within 6 weeks of the primary probing. All cases of failed probing should have a careful nasal endoscopic evaluation to rule out other nasal causes and rule out other causes of watering as well. They may need a repeat probing with intubation or balloon catheter dilatation. So any primary acquired NLDO or secondary acquired NLDO will go for either external dacryocysterinostomy or endoscopic dacryocysterinostomy. The aim is to make a big ostium into the nasal cavity and to have a mucosal lined anastomosis. A good preoperative assessment to rule out bleeding diathesis, a use of adrenaline or oxymetazoline in patties, nasal decongestion with 10% lignocaine spray and nasal packing with 4% lignocaine and 0.5% xylometazoline, and using a well-powered suction, raising the head end of table, avoid known blood vessels and judicious use of cautery helps in achieving a good hemostasis. Coming to incisions, most commonly used incision is a curvilinear incision, that is 3 mm from the medial canthus of 10 to 15 mm along the anterior lacrimal crest. Other are modified Lynch incision or subciliary incision. To prevent any web scar, the incision should not cross the level of medial canthus and the wound should be closed in layers. Ostium, the extent of ostium anteriorly till the punch cannot be inserted between the bone and nasal mucosa, posteriorly till removal of aerated ethmoid, superiorly till 5 mm above the common canaliculus, inferiorly till the nasolacrimal duct is deroofed. Extent of ostium should be long enough to allow opening of entire lacrimal sac from the fundus to junction with the nasolacrimal duct. While making sac flap, a Bowman's probe can be used to tent the sac or fluorescent stained viscoelastic can be used to inflate the sac. After making the flaps should be opposed edge to edge and you should avoid sagging of the flaps. Wound should be closed in layers and routine post-operative care is needed. Intraoperative use of mitomycin C most commonly will use 0.02 mg. It can use from 0.0 to 0.5 mg for duration of 2 to 30 minutes. So routinely we'll use a cotton tipped applicator soaked in 0.02 milligrams of MMC and applied below the nasal and sac flaps for 2 minutes. After that, copious irrigation with normal saline. Recent advance is circumostial MMC, which most commonly we can use in high risk cases or post-traumatic DCR. 0.02% of MMC is injected intramucosally at 4 sites along the ostium, edges of the ostium, 0.1 ml at each site. It proven a good success rate. You can use it in high risk cases like revision DCRs or post-traumatic DCR. Pearl number 8, intubation and DCR. Intubation should be limited to those cases with either preoperatively proven or intraoperatively proven canalicular disorders or in the presence of high risk factors for failure such as revision surgeries, small sacs, poor mucosal flap formation, previous history of recurrent dacryocystitis and excessive intraoperative hemorrhage. How many days should we leave the intubation tube? Say 4 weeks to 6 months, but recent evidence is building upon the shorter duration, that is 4 to 6 weeks, because multiple studies have shown that ostium size changes most in the 4 weeks and subsequently doesn't change much, and development of biofilms and subsequent biomass buildup. Biofilms have the potential to encourage inflammatory response, which has a negative influence on size of the ostium. Imaging modalities, their CT-DCG helps in delineating bony structures. We can use dye installation or cannulation. It's mostly indicated in case of mid-phase trauma, where if we want the localization of trauma or location of plates or screws, and previous lacrimal surgery failed DCR to know the patency of the ostium on medial canthal masses and anatomical variations. And there is no gold standard in radiological investigation. Whatever investigation we'll order, we need to have a discussion with the radiologist in view of symptoms and what do we need, we'll get a good information. Failed DCR, performing a proper preoperative evaluation and meticulous primary surgery with primary intention healing prevents failure. The causes of failure or cicatricial closure of ostium, inadequately sized ostium, inadequate sac opening, common canalicular obstructions, intervening ethmoids, inappropriately placed ostium with respect to sac, which leads to some syndrome and turbinoceptal synechia and inappropriate granulation tissue. So all cases of failed primary external DCR, we can do either endoscopically or externally, so which helps in increasing success rate or intranasal endoscopic anatomy for the location and extent of sac, complete excision of cicatrix, efficient bone removal to achieve complete exposure of sac, complete incision and marsupialization of the sac, and use of adjunctives as MMC and intubation tube. Last is dactylocystectomy. The absolute indication for dactylocystectomy is a malignant sac tumor. The aim is complete excision of sac along with NLD without leaving any remnants, and to have a clear plane of sac excision and avoid periorbital injury. So take home message is proper preoperative evaluation and meticulous primary surgery, and whenever you need any adjunctives as MMC or intubation tube can be used to prevent failed DCRs. Thank you.
Thank you, Saujanya, for that excellent talk. Next, I will like to invite Dr. Kavya Madhuri from LV Prasad Institute, Vijayawada, to deliver her talk on ocular adnexal trauma pearls. Over to you, Kavya.
Thank you, Dr. Ansuya, for introducing me. Good morning, all. I'm Dr. Kavya Bajanki from LV Prasad Eye Institute. Thank you, organizing committee, for giving me this opportunity. Periorbital trauma can often be associated with intracranial trauma or other systemic problems. So always it is important to ensure patient survival and tackle any other life-threatening complications before addressing the periorbital trauma. Now, financial disclosure. Coming to my first pearl, superficial or deep eyelid lacerations, 3 things to be noted while wound closure. If no wound tension, simple closure of wound with interrupted sutures is sufficient. If the wound is under tension, undermine the edges and close. If wound defects are circular in shape, convert it into elliptical defect before suturing to avoid dog ears. For lacerations involving the eyelid margin, exact repair of the lid margin is critical to avoid lid notching or margin discontinuity, which can cause functional and cosmetic problems. The first step is to identify the lid margin landmarks, the gray line, the meibomian gland orifices, and the lash line. Assess the wound tension by pulling the edges of the wound together, and if the wound is tight, canthotomy or cantholysis is done to decrease the tension on the wound edges, and the margin is sutured by triple suture technique. First, align the lid margin by passing a suture through the meibomian gland orifice on both edges of the cut 2 mm from the edge and look for the alignment. If the alignment and wound tension is adequate, pass a vertical mattress suture. Align the tarsal plate by passing the suture through 90% thickness of the tarsal plate, and the knot should come on the anterior side. Avoid full thickness tarsal sutures as it can erode the conch to cause suture keratopathy. Complete the lid margin suturing by taking sutures along the gray line and lash line. The gray line suture can be an optional. Make sure that the wound edges should be everted to prevent the postoperative lid notch. Trauma to the canthal tendons. It is usually the result of horizontal traction on the eyelid, leading to avulsion at the weakest part, either medial or lateral canthus. Laceration near medial canthus is associated with canalicular and lacrimal sac injury in most of the cases. Palpate tendon insertion, then assess the integrity of medial and lateral canthal tendon by grasping and tugging the lid away from the injury. And in medial canthal tendon injuries, there will be rounding of the medial canthus, lateral displacement of the punctum, and acquired telecanthus. Whereas the sharp contour of the lateral canthal angle will be lost or distorted in lateral canthal injuries. Depending on the extent of tendon injury, the further management is done. If the cut ends of the tendons are identified, direct suture in a horizontal mattress fashion can be done. If the proximal part is not identified, suture the ends to the periorbita. If the entire tendon is avulsed, it should be wired to small drill holes in posterior lacrimal crust. If associated with fracture, transnasal wiring or plating is recommended. Levator injury is suspected when patient presents with ptosis or fat in the wound post-trauma. If fat is present, it means the septum is injured and there is a potential chance of injury to the levator which needs to be repaired. In case of traumatic ptosis alone without any external injuries, observation for 6 to 12 months is recommended as spontaneous resolution can occur in this period. Any eyelid trauma medial to punctum, always rule out canalicular laceration. The driving principle behind managing canalicular lacerations is that wound healing by primary repair is always better than secondary intention or late repair. And the most important step in canalicular repair is locating the medial end of the severed canaliculus. Therefore, canalicular laceration should be repaired within 24 to 48 hours after injuries because the medial cut edge of canaliculus becomes progressively more difficult to identify as fibrin and granulation deposition occurs. The medial cut edge of canaliculus is identified by direct inspection as white mucosal tissue with wall and lumens called calamary ring sign. If discovery of the lumen remains difficult, we can inject air or fluorescent stain through the intact canaliculus. Mono or bicanalicular intubation, depending on the surgeon's choice, can be done, followed by pericanalicular suturing and wound closure. Any transdermal dog bites or scratches on face are classified as category 3 dog bite and warrants both local treatment of the wound and complete post-exposure prophylaxis measures, including the immunoglobulin and vaccination. The recommended dosage is 20 international units per cage around the wound site. Pediatric orbital bones may not break completely and are thus able to return to their original position, causing entrapment of herniated orbital muscle and fat. In these cases, the extraocular muscles not identified intraorbitally and sometimes referred to as missing rectus, and the classical teardrop sign may not be seen if associated with hemorrhage in sinus. If surgical procedures to release the tissues are not performed within 24 hours of these trapdoor fractures, retention of entrapped extraocular muscle may occur and cause irreversible damage due to congestion and lack of blood flow from venous occlusion. So this patient was met with an accident, consulted local ophthalmologist, imaging was done, diagnosed and treated as orbital cellulitis. As the symptoms worsened, patient was referred to us. What is this? The diagnosis is often missed in these cases. Always rule out intraorbital foreign body if the patient presents with post-traumatic proptosis along with entry wound. CT scan can determine exact location of foreign body as well as any associated orbital wall fracture. But CT may fail to delineate wounded foreign bodies since its radiodensity is similar to orbital tissue. An organic foreign body, especially wood, should be suspected if there is air on the scan, especially in a linear configuration, which happened in this patient. Serious orbital emphysema may result from a small fracture site or when orbital tissues fall back to the defect, acting as a one-way wall. Subsequent pressure rise within the orbit results in an orbital compartment syndrome. So when to treat this orbital emphysema? For mild cases without raise in orbital pressure, conservative treatment with close monitoring may suffice. For severe cases with clinically tight orbit, prompt lateral canthotomy and cantholysis should be done to reduce the orbital pressure. Patient may need even decompression if symptoms persist. Any globe subluxation should be managed as an emergency. In patients with globe subluxation, immediate repositioning of the globe back into the orbit is of paramount importance, not only to alleviate patients' anxiety and pain, but to prevent permanent vision loss due to optic nerve compression. Rarely, when the globe gets dislocated into the sinuses, utmost care should be taken while manipulating the globe to avoid scleral perforation, demanding a gentle pushing and pulling maneuver. So, reposting a traumatically avulsed globe into the orbit can provide a good psychological and cosmetic satisfaction to the patient, even if the function is lost. To conclude, first, prevent further damage to the patient's eye, and second, restore the structures of the eye and periocular region as soon as possible. Thank you all.
Thank you, Kavya, for the great presentations. So now it's my honor and privilege to invite Dr. Santosh Honabur. He needs no introduction. He's the Director, Ocular Oncology and Oculoplasty Center for Sight, Hyderabad. He's one of those pioneers in oculoplasty, probably without whom oculoplasty wouldn't have been a subspecialty today. So over to you, Dr. Honavar, for your keynote lecture on your top 20 pearls in on tumors of the eyelid.
Thank you so much, Ansuha, for the kind introduction. I'll be talking about tumors of the eyelid. If there is time of it, I have 12 minutes. So let me see how much I can complete in the next 12 minutes. If this is for mainly postgraduates and practicing ophthalmologists, they generally see a lot of patients in their clinic, and sometimes it is confusing. It's very difficult to differentiate what is good, what is bad, and what is ugly. You may have seen this popular movie, but it is very difficult to say when you look at this slide who is good, who is bad, and who is ugly. But they all come with a signature. And if you identify that particular signature, then it may be easier for you to recognize a malignant tumor from a benign one. For example, we all know that this is a squamous papilloma. There's no doubt about the diagnosis at all clinically. But if there is any change in color, vascularity, or induration of the base, it indicates malignancy. Like this patient always had a squamous papilloma, and suddenly it started ulcerating. There was excessive vascularity, and you can see that the base has become wider and it is fixed to underlying structures. So pre-existing squamous papilloma can turn into squamous cell carcinoma. So these are the warning signs. If there is change in vascularity, change in color, when there is a keratin on top of a pre-existing squamous papilloma, that generally indicates chronicity and the benign nature. Here is an example of a patient where there is sudden change in color. You can see all these are uniformly brown, but the apex has suddenly become pinkish. And if you look at it on slit lamp, there is increased vascularity and it is multifocal. This patient was immunocompromised because she had had a renal transplantation and was on iatrogenic immunosuppression. Age was more than 60. So this patient had immunosuppression as the background, and she had HPV virus infection, periocular squamous papillomas, so one of which turned malignant, and it was proven on X-ray. Now, if you have a patient with multiple squamous papillomas, always look at the conjunctiva as well, because they may have conjunctival squamous cell carcinoma or ocular surface squamous neoplasia. So first pearl is that change in color, vascularity, size, new onset induration, and base fixity in a papilloma are ominous, and it may indicate malignant transformation. Now, we know that seborrheic keratosis is benign proliferation of the basiloid cells. But if a patient has a sudden crop of multiple seborrheic keratitis, it is called sign of lesser toilette. It indicates a systemic malignancy. It is a paraneoplastic syndrome. So if a patient has one or two seborrheic keratosis, obviously it may be a cosmetic concern, but sudden crop of multiple lesions may herald a systemic disease. Now, if you have a patient with an eyelid lesion with a central necrosis or umbilication. So for example, if this is a nodular lesion, the center part of which becomes umbilicated, that's because of the necrosis. That's very, very characteristic of or keratoacanthoma. So a rapidly growing lesion which outpaces its vascularity with central necrosis is very typical of keratoacanthoma. Although clinically it may look like a malignant tumor, this is not a malignant tumor, although there might be some pathological confusion about it. It's a benign tumor, but because of its sheer size and the functional problem that it produces, it deserves excision. The next is that if you have a dry lesion, this is an absolutely dry looking lesion. It has very minimal vascularity and it has taken years to grow to this size. The patient is not really worried about it initially, but generally when it becomes larger or when they need cataract surgery, they come. I mean, it's basically it's over several years, 5, 6, 7, even 10, 15 years. That is a basal cell carcinoma. So basal cell carcinoma is uniformly relatively avascular. It does not cause destruction of lashes too much, although it is lying very close to lashes. You can see lashes intact. The large lesions, yet the lashes are intact, and that is basal cell carcinoma. So dry appearing nodular or nodular ulcerative lesions are suggestive of basal cell carcinomas. And as you have seen here, basal cell carcinomas in Asian Indians are often pigmented. So pigmented lesions which are nodular or nodular ulcerative, we may not diagnose clinically as malignant melanoma because basal cell carcinomas in Asian Indians like ours are often pigmented. Now, if you have a similar lesion with or without pigmentation, but with ectropion, but a flatter lesion like this with minimal or no elevation, if it is as subtly elevated as this, not elevated like that, then it is a different variant of basal cell carcinoma called the morphiform variant. These patients often come with ectropion. If it is not pigmented, especially, then the only manifestation you will see is some kind of erythematous eyelid with desmoplasia. If they give a history of trauma, you may actually confuse it as a case of cicatricial ectropion. That subtle it may be, but it is morphiform basal cell carcinoma. The next pearl is that if a patient has multiple basal cell carcinomas on the face, if the patient is a younger individual and also gives a history of premature falling off of teeth for no reason, and when you look at the palm and sole, you find pits in the palm and calcification of the falx cerebri, then that is a cancer predisposition or Golin-Gott syndrome. So multiple basal cell carcinomas in the young suggest a syndromic variant called Golin-Gott syndrome. Now coming to wet vascular lesions, we also dry vascular lesions, pigmented, are basal cell carcinomas predominantly involving the skin. Of course, they may extend to eyelid margin and conjunctiva if they are delayed manifestations. But a lesion which predominantly involves the skin also involves the eyelid margin and conjunctiva as it advances, but it is wet and vascular with erythematous indurated base. That is squamous cell carcinoma, but it has a higher predisposition to get into the orbit. So you see that in basal cell carcinoma, orbital involvement occurs very, very late. Periosteal involvement occurs first, and orbital involvement is very rare. Whereas in squamous cell carcinoma, orbital involvement can occur early on, especially if it is an aggressive variant. So squamous cell carcinoma is latent vascular, ulcerative or nodular ulcerative, with predominant skin involvement. Eyelid margin is involved early on in squamous cell carcinoma, whereas in basal cell carcinoma, that's a delayed manifestation. Now, coming on to something that is very important to our situation, India and Asia. If a patient has a nodular tarsal-based lesion, now there are two ladies of similar age group, both of which have a nodular tarsal-based lesion. Now, if you were to present in front of me, I would actually point to you and ask you to tell me which one of this is a chalazion. Difficult to say sometimes unless you look at them very carefully. My guide is that if a patient is in an atypical age, in say beyond 40, 50 age group, and has a lesion which is confined to the tarsus, you can still consider this as a chalazion. But as the lesion increases beyond the upper edge of the tarsus, then definitely that warrants more investigation. Like this, both these ladies have a lesion higher than the level of tarsus. That is one part. Second is that you should not conclude unless you evert the lid. Now, once you evert the lid, the diagnosis is very obvious. Both of them have sebaceous gland carcinoma. There is absolutely no doubt at all. But what if this patient were not to have this tarsal conjunctival lesion? Suppose the patient has still a tarsal-based lesion, which is not evident on the conjunctival side. would you still be able to suspect sebaceous gland carcinoma? Then you have to look at the other subtle tips. Other subtle tips are that you can see everything in this slide. This is my favorite slide. You can see that the eyelid margin here is so thick. Now, when you come to the area of the lesion, eyelid margin is nearly doubled in thickness. So thickening of the eyelid margin is one subtle sign that indicates that the patient may be having sebaceous gland carcinoma. Second is meibomian gland orifices. You can see nice and round meibomian gland orifices, but as you approach the lesion, they're suddenly lost. If it's lesion or some meibomian gland-based inflammation, you'd actually see large pouting meibomian gland orifices, excluding secretions. Whereas in sebaceous gland carcinoma, they get blocked and because it's an infiltrative lesion. That is the second part. Third is vascularity of the eyelid margin itself. The lymphatic vessels in the eyelid margin indicates that it could be a sebaceous gland carcinoma. Fourth is that the sharp eyelid margin is lost in the area of involvement. It becomes rounded. So if you have all these accompanying features, even in the absence of an evident conjunctival, tarsal conjunctival lesion, you can still diagnose it as an early sebaceous gland carcinoma. So a nodular tarsal-based lesion with thickened rounded eyelid margin, loss of flashes and meibomian gland orifices is diagnostic of sebaceous gland carcinoma. And this is a dictum actually, nodular type metastasis lesion. Any recurrent or atypical lesion warrants biopsy. Atypical in terms of size, location, pace of growth, age of the patient, loss of flashes, and all the other features that I just mentioned definitely warrants a biopsy. You may biopsy it in the sense that I don't say that every patient who has a suspicion of sebaceous gland carcinoma, but a younger age group, you have to do an excision of the lid. No, that's not what I'm telling you. But even if there is a little bit of suspicion, it's always a good idea to send the excised specimen for a pathology evaluation just to confirm if it is sebaceous gland carcinoma. And if it is indeed so, you can go back and excise with the protocol-based technique. Now, this is inflammation. You can see meibomian gland orifices exuding a lot of material. This is definitely inflammation, whereas this is sebaceous gland carcinoma. This is a small sebaceous gland carcinoma which somebody had curated, after which it recurred within 3 weeks. Definitely sebaceous gland carcinoma. It can be nodular, it can be nodulo-ulcerative, it can be purely ulcerative, it can be very subtle, sometimes with destruction of the eyelid margin. From a special variant of sebaceous gland carcinoma, we know that it mostly arises from the meibomian gland. So it is a tarsal-based lesion. It appears like that, then it gets into the tarsal conjunctiva, and as it grows bigger, it comes onto the eyelid surface on the skin and also the eyelid margin. That is how it presents. Now, we know that there are sebaceous glands in the glands of Zeiss as well. They are also a special type of sebaceous glands which are associated with eyelashes. So if a patient has a Zeiss gland, sebaceous gland carcinoma, then lashes would be lost first, and it presents as a placoid yellow eyelid margin lesion. It doesn't present like a nodular lesion. So eyelid margin placoid yellow-white lesions with sparse lashes indicate sebaceous gland carcinoma from the Zeiss gland. Now, this is about a patient who has unilateral blepharoconjunctivitis, which is not responding to conventional management modalities. If you look at it closely, you find that there is some kind of loss of limbal architecture and a placoid vascular lesion covering the limbus and the cornea. But when you evert the lid, you find all the signs I mentioned about a sebaceous gland carcinoma. You can find that the eyelid margin is thickened. This is the normal thickness of the eyelid. Posterior lid margin is all rounded. Meibomian gland orifices are not seen at all, and lashes are sparse. But the nodule is missing. There is no nodule or there is no ulcerative lesion. So sometimes it is easy for a beginner to get confused. This is a very classic manifestation of vegetoid sebaceous gland carcinoma, which presents with unilateral blepharoconjunctivitis, exactly like this. It can be as subtle as this. You can see that this patient has just this bit of vascularity at the lid margin, which is of course carrying on to the tarsal conjunctiva just a little bit. Looks very much like inflammation. Lashes are still intact, but it was proven to be a case of intraepithelial sebaceous gland carcinoma arising from the Zeiss gland. Now we have a classification for intraepithelial sebaceous gland carcinoma, which was proposed by Jacobiak, but now it is used in pathological description. It is vegetoid, bovinoid, and papillary. This is the typical vegetoid variant, which we are very familiar with. Papillary is this, where there is papillary thickening of the bulbar conjunctiva of the parcel of palpebral conjunctiva. And the bovinoid one actually manifests like squamous cell carcinoma with keratin. You can see predominant keratin here. This was a contact lens user with unilateral contact lens intolerance, and that was a intraepithelial sebaceous gland carcinoma. So chronic unilateral blepharoconjunctivitis, which does not respond to conventional treatment for a finite period of time, is suggestive of sebaceous gland carcinoma and warrants MAM biopsy. So I could only finish 10 pearls in 12 minutes. So sorry about that. More pearls next time. Thank you so much.
Thank you, Dr. Honavar, for those crisp, excellent pearls. So we also have Professor Subramaniam with us. Professor Subramaniam, if you have anything for our audience.
Am I audible?
Yes, yes, you are audible.
Okay, thank you.
Go ahead, sir.
Thank you. And excellent presentations by everyone. Of course, Santosh is very great. That's normal as it goes on. One thing just I would like to add with the pulse for ptosis erratica is that you never try to completely correct or overcorrect ptosis, especially in elderly people. It can lead to dryness problems. And the rest of that's the only thing I would like to tell. And for the ophthalmologists with congenital ptosis, please look for amblyopia. It can occur in nearly a third of the patients of congenital ptosis. These two things are the ones I would like to add. Rest of it is an excellent session. Thank you.
Thank you, Professor Subramaniam. Any questions, anyone? We have 3 more minutes. Any questions from the audience or any of our audience virtually connected?
Hi, Santosh.
Hi, Gopal. Thank you so much for having me.
Sir, namaste, sir. Subramanian, sir. Namaste.
Namaste, namaste.
Thank you, sir. Thank you so much.
Thank you.
Thank you so much.
Thanks for inviting us and making a part of it.
Right, sir.
Beyond the border. Thank you so much.
Okay, bye-bye. Thank you, Ansuva. Carry on.
So if there are no further questions, we would like to close our session. Heartfelt thanks to all the participants, the audience, the speakers, our chairs, Professor Subramaniam and Dr. Honavar. Thank you, Dr. Gopal Raju and the entire team of Andhra Pradesh Ophthalmic Society for giving us this opportunity to present this oculoplasty symposium. Thank you, everyone.
సెషన్లో నేను మాట్లాడాలి మాట ఇప్పుడు ఎవరు రెడీ అనిపించింది రెడీగా రెడీగా ఉండు దానికోసం కలిపాను అయ్యో ఎందుకు పర్లేదు పర్లేదే బా థ్యాంక్ యూ. ఏంటి విశేషాలు? అంత బాగున్నారా?
అది డౌన్లోడ్ చేసావా స్టూడియో?
లేదు లేదు లేదు, ఇది ఏదో స్టేట్ కాన్ఫరెన్స్ అవుతుంది, అందులో నేను కొంచెం బిజీగా ఉన్నాను.
అయ్యో సారీ.
అయిపోయింది నా సెషన్ అయిపోయింది.
Hello. Hello. My audible? Good morning. Good morning. Good morning to all of you. The first will be Professor K. Vengal Garu, Best Paper Session. And the participants are KV Sachinana, Dr. Ashok, Dr. Arvind, and Ranjit Kumar, Anamika, Shishweta, and Padmini. I hope all of you are present. The first presenter is Dr. KV Sachinana. Are you there, sir? Hello?
Hello, good morning. The Professor K. Vengalrao Best Paper Presentation. First one is Dr. KVV Sachinaran Garu. Hello. Yeah.
Please play Dr. KV Sachinana.
Madam, Serena, madam. Yeah. Okay. Hello. Dr. Ashok.
Doctor, first you introduce yourself. Who are you? I mean, what is your present position? I mean, where are you working, your designation?
You kindly introduce 1 minute and start your topic.
Introduce yourself and start your talk.
Sir, I'm Dr. Ashok K, working as a vitreoretinal surgeon at Shankara Hospital, Guntur. Today, my topic for Dr. Vengal free competitive paper session is COVID-19 vascular associated events. So, sir, I have the PowerPoint loaded there. Yeah, next slide, please. Next slide. It's the recorded one. Yeah, you can. Yeah, please click on that and go to slideshow.
COVID-19 vaccine associated retinal.
No. The next slide. The next slide. That's recorded. Yeah. Go back. Go back. To the title slide. Go back. Yeah. It starts from. Sir, with your permission, can I start, sir? Yes, sir. I would like to thank APOS for the opportunity given. So I'll be speaking about COVID-19 vaccine associated retinal adverse events, that is vascular occlusions. Next. Next. Can I get the, at least to change slides? I don't have anything right. I can change slides. Yeah, sorry for the interruption. Yeah, despite the large number of doses of, sorry for the, despite the large number of doses of vaccine having been administered worldwide, its adverse systemic events remain uncertain. So what about COVID-19 vaccination in the retina? There have been anecdotal cases of adverse retinal ischemic events presented at conferences and undoubtedly awaiting publication. Post-adenovirus vector vaccination, patients can have potentially life-threatening cerebral venous sinus thrombosis. In contrast to all other vaccines, the coding sequence of SARS-CoV-2 immunogen in the AstraZeneca vaccine has not been modified to stabilize and mitigate shedding of the expressed S protein. So thus, it is possible that this expressed S protein in the circulation after AstraZeneca vaccination can induce a pro-inflammatory, pro-coagulant response or direct disturbance of the endothelial cell integrity. So the purpose is to describe retinal vascular events after receiving COVID-19 vaccination. So it is an observational case series. The study was conducted at Shankara Hospital, Guntur from April 2021 to September 2021. Patients who presented with ocular adverse events within 2 months post-vaccination were analyzed. 6 eyes of 6 patients presenting with retinal complaints were included in the study. All of the patients received Covishield vaccine. The age of the patients ranged from 45 to 70. Visual acuity ranged from 612 to CF 1 meter. 4 patients had branch retinal vein occlusion, 2 patients had central retinal vein occlusion. One of the patients did not have either diabetes or hypertension. Rest of the patients had either of them. Coming to case 1. Case 1 is a 52-year-old female, recently diagnosed diabetic and hypertensive, received Covishield vaccine 3 days back. The BCVA in the right eye was 618 parts, in the left eye was 612. On examination, the anterior segment was within normal limits. Posterior segment examination of the right eye was within normal limits. Left eye showed CRVO with BRAO. She was advised blood investigations which were within normal limits. She was started on Vislon as she did not have macular edema. Case 2 is a 58-year-old male presented with complaints of defective vision in the left eye since 5 days. He's received COVID-19 vaccine 10 days back. The patient is a known diabetic since 3 years. BCVA in the right eye is 69 parts, left eye is 624 parts. Anterior segment was within normal limit. Posterior segment examination of the left eye showed macular BRVO with macular edema. Right eye was within normal limits. The patient was again advised blood investigations and was treated with left eye intravitreal Avastin. Coming to case 3 is a 58-year-old male presented with complaints of defective vision in the right eye since 10 days. He's received COVID-19 vaccine 2 months back. He's a known diabetic and hypertensive since 1 year. Coming to the BCVA, the right eye had 1/60, left eye had 6/6. Anterior segment showed cortical cataract. Posterior segment examination showed STBRVO with macular edema. Left eye was within normal limits. The patient was again advised Avastin in the right eye. Case 4 was a 45-year-old male presented with complaints of defective vision in the left eye since 5 days. She is not a known diabetic or hypertensive. She has received COVID-19 vaccine 1 month back. BCVA in the right eye was 6/6, left eye was CF 2 meters. Anterior segment was within normal limits. Posterior segment examination of the left eye showed papillophlebitis with CRVO, and right eye was within normal limits. The patient was advised blood investigation, and the patient was started on Visalone as he did not have macular edema. Rest of the cases could not be presented as the data could not be retrieved and the images. The establishment of a causal relationship between the vaccine and an observed pathology will remain challenging and should be guided by scientific medical principles of assessing whether the observation is definitely, probably, possibly unlikely or not related. If unique aspects such as age, sex, systemic findings, eye findings, and other morbidities of the adverse events are not noted, then causation should then be suspected. If the pathophysiology of the vaccine response fits with the pathology, causation can also be then suspected. So why did we suspect COVID-19 vaccine as the probable cause in these cases? So we had an incidence of vascular occlusions of around 80 to 100 in over 6 months. But in the study period of 6 months, we saw a spike of vascular occlusions which has presented to about 15 to 20% more. This phase also correlated with the majority of the vaccines being administered in the country. So it was that correlation. Though we had more number of vascular occlusions in that period, why did we think or why did we choose these cases was its association with the COVID-19 vaccine first. And the presence of peculiar retinal features such as retinal whitening along with vein occlusions. There are multiple vein occlusions along with arterial occlusions as well. And lack of predisposing factors such as systemic factors which overtly tell us that it is because of those which could directly correlate to the vascular events. To conclude, in this case series, the occurrence of retinal vascular complications post-COVID-19 vaccination was supported by presence of atypical presentation and a history of COVID-19 vaccination. There is literature evidence that mRNA vaccines can result in vascular events. Hence, when a patient with a history of COVID-19 vaccination comes for an eye checkup, we should always remember that if there is an adverse event, we have to dilate and look at the fundus as well. And most importantly, a causal relationship cannot be established from the study telling that the vaccine is the cause for vein occlusion. Thank you. If there are any questions, I would like to.
Vaccine, do you think that it is causing more Covaxin or Covishield?
Sir, Covishield, because they told that the immunogen, SARS-2 immunogen in the vaccine has not been modified so that it doesn't cause anything, sir. Sir, this is all a learning phase. When we go back and try to see articles, sir, there's not much literature behind vaccines and vein occlusions. But we also initially thought that this might not be because of this. When the phases of initial starting 2 months when the vaccination was being done and we were seeing vein occlusions, we didn't have a thought. But as and when we started seeing things and not having systemic factors like overtly diabetic or hypertensive since a long time, we were not seeing that for a long time. And those typical retinal features, wherein we were not seeing a typical vein occlusion, it was presenting along with the retinal whitening, which we didn't see commonly. Then when we tried to search literature, nothing was there because it was all learning phase. So the point of the presentation was, we should not neglect that when a vascular occlusion comes, it might not be definitely related to vaccine, but we should definitely take history of vaccination into consideration, telling that this also can result in a vascular event. And nowadays, sir, at least in the past month, and even recently 2-3 days back, we have been coming up about literature telling that even mRNA vaccines cause pericarditis and a lot of other symptoms coming into picture, sir, of late. So based on all this, the intention is we should just keep this in the back of the mind. And this is an evolving thing going on in COVID, vaccination at least.
What's your final inference?
That when a COVID vaccination comes with an ocular complaint, please dilate and have a look at the fundus. And if there is a vein occlusion, we should always take a past history of COVID-19 or COVID-19 vaccination.
Okay, you have taken the history and they have taken the vaccines, the co-vaccine, something like that.
Yes, sir.
How can you attribute it, or how can you say it may be or it might be?
That's what, sir. Actually, sir, there is not enough literature evidence everywhere, sir. Anywhere in the literature. It's just part of the learning what we have seen. The intention was to alert the ophthalmic fraternity that these can happen with the AstraZeneca vaccines. And there have been anecdotal reports, sir, to corroborate with our theory.
Nice.
Time interval between the vaccination and the manifestation of this?
Sir, we have taken that 2 months period, sir, because majority of the first dose and second dose are administered by that second month, even for all the vaccines, especially Covishield.
You think the second dose is most common cause for vaccination?
No, sir. Even after the first dose, after 3 days to 5 days to 10 days, we had different presentation even after the first dose, sir.
Did you check for COVID positivity in those individuals?
Yes, sir. In these 6 cases, we didn't have.
Vaccination is a very small dose of COVID.
Yes, sir. That's what, sir. What they are telling is those immunogen in some vaccines, it's been not very well polished. That itself can result in a occlusion thing, sir. It's been, there is an anecdotal report in literature, sir, published in AJO in September, sir.
Does it associated with vascular occlusions of other organs?
Other
Organs.
that
Because it is generalized.
yes, ma'am. Yes, ma'am. But till now we have not. Yes, sir. Yes, sir. But other, I don't have much idea about the other vascular occlusions in other parts of the body, ma'am.
Okay. What are the other features? What are the other features by which you identify? You said some atypical findings in the retina.
Yes, sir. Yes, sir.
Whitening.
Yes, sir.
Apart from that, any other findings to suspect this sort of cases? And what should be the minimum time interval? Is it following the first dose or following the second dose also?
Yes, sir. So the initial period, what we have taken was in the vaccines, which because the schedule for the second dose is up to 2 months in all the vaccines. So we put 2 months as the deadline because even after the second dose, if they present immediately, we were including those cases also. The timeline was 2 months, sir, in our study. Because to be frank, sir, we didn't know till what we can extend the study. We thought because it was an adverse event. Why we were suspecting it to COVID? Because after the vaccination, we could get an event like this. If it is not an acute event, we might not attribute it to the COVID-19 vaccine. It can happen with other systemic causes also. So the acuteness of the event when associated it with the vaccine was what was suspected, sir. And as you rightly said, sir, those are typical, sir. Sometimes you are getting papillophabilitis with CRVO with branch retinal vein occlusion. It's a combination of multiple factors which we saw in these cases, sir. Very peculiar.
Combination of more findings and other atypical findings.
And association with the COVID-19 vaccines. And some patients didn't have either any of the systemic diseases, sir, like hypertension or diabetes, or they had just recently diagnosed, which overtly, that means if they were there for some time, we would generally suspect, sir. But these are cases where it was not there for a long time. Though they can also present like that, but the event which the COVID-19 vaccine was there was more correlating with this. And that we found out over time, sir. Over the 6 months when we followed up, initially we didn't suspect. But over the time when we were thinking and when we started going back to the literature, when they started evolving with the literature, then we could.
Both the hypertension, diabetes were under control at the time of your diagnosis, or they are under
They were in control, sir. That specifically we asked because then the attribution changes a lot.
What about the antibody levels at the time of your diagnosis with regard to this coronavirus?
Sir, those antibody levels we didn't check, sir. We checked for other D-dimer and other things, sir. Antibody in one case are less we checked, but we couldn't correlate that with all the cases, sir.
Both the things you had to do. Otherwise, how can you say that it is due to only coronavirus?
No, sir. That's what, sir. It's not a casual thing. We can just blindly tell it's because of COVID-19 vaccine. The intention of the trial was to tell that this also can result. We should, at the back of the mind, because of the evolving literature we are seeing, we should always keep that in the back of the mind along with these.
Atypical findings.
Yes, sir. Yes, sir.
Sir, good morning, sir.
Thank you, sir. Yes.
Good morning,
sir. Sir.
Why it unilateral?
Sir, I didn't.
Why it is unilateral?
Sir, good morning. Chebbasu.
Good morning. Why it is unilateral, sir? Presentation.
So the sir is asking
sir,
why.
Even yes, sir. Nice, sir. Even in vein occlusion, sir, even in systemic conditions, though it should affect bilaterally, majority of the vein occlusions we see are unilateral, sir.
Systemic conditions are different from vaccine related.
Sir, we saw 6 cases of such Covishield related associated events, sir. We did see a lot number of vein occlusions with artery occlusions in that period, sir. So around 115 to 120 in the 6-month period. But why we narrowed down on those 6 was, as I said, because of the acuteness of the COVID-19 vaccine, that is 3 days, 5 days, 10 days, and the systemic features not being that overtly conducive to tell that it is because of that. And one more thing is, the atypical features of the retina, sir. As I told, a combination of 2 or 3 events in the retina which prompted us to think about this cause, sir.
Anything from audience? Anything online? Thank you.
Thank you, sir. Thanks a lot.
Next, Dr. KVV Satyanarayana is on the line, please. Yeah, please.
Yeah.
Satyanarayana sir, good morning, sir. You are welcome, sir.
Morning, sir. Morning, sir. Good morning, all of you.
Good morning, sir.
Good morning, sir.
KVV Satyanarayana.
Good afternoon. I am Dr. KVV Satyanarayana, Associate Professor, Getam Institute of Medical Sciences and Research, Visakhapatnam. No financial disclosures. Glaucoma is a group of diseases with progressive optic neuropathy. The incidence of glaucoma in 2020 is about 80 millions, whereas in 2040 it may increase up to 120 millions. The incidence is alarming. Glaucoma is the second most common cause for the blindness. It adds 12% of the total blindness. There are 4.5 million blind globally because of the glaucoma. 90% of this blinding are from the underdeveloped countries. The prevalence of angle-closed glaucoma from open-angle glaucoma is different from the Asia when it compared to the Western countries. In Asia, the prevalence of angle-closed glaucoma is more because of several factors. International Society of Geographic and Epidemiological Ophthalmology Society classified angle-closed glaucoma into primary angle closure suspect, primary angle closure, and primary angle closure glaucoma depends upon the visibility of the posttrabecular meshwork and intraocular pressure and involvement of the optic nerve head. Schaffer graded the angle closure glaucoma by the view of the gonioscopy, visibility of angle in degrees. Though the gonioscopy is the gold standard to evaluate the antechamber angle, it provides the semi-quantitative assessment of the angle width. OCT introduced by Adolf Fischer in early 80s, and it is the subjective and quantitative tool for the precise measurement of the angle and the antechamber angle documentation. Anterior segment OCT reveals several parameters of the anterior segment, including the anterior chamber depth, angle opening distance, trabecular iris angle, and lens vault, which are very important in the diagnosis of the angle closure glaucoma. Iridotomy is the treatment for the primary angle closure disease, which is introduced by 1856 by Van Graffe. Later, it is replaced by the laser peripheral iridotomy, is a promising treatment for the primary angle closure diseases. Soon after the laser peripheral iridotomy procedure, the angle opens to a certain extent. Laser peripheral iridotomy is performed by the ND-AG laser that indicated in a primary angle closure disease, which reveals the relative pupillary mechanism and increases the angle depth and also antechamber depth. According to the Foster study, increase the rate of the laser peripheral iridotomy in the UK, it drastically falls the acute angle closure rates. Tin Nong, in his paper, he stressed that laser peripheral iridotomy is the treatment for the angle closure diseases. He documented his cases pre and post laser with the anti-segment OCT, and which revealed that after the laser procedure, the angle of the trabecular meshwork opened. The aim of the present study is to quantitative measurement of the antechamber angle following the pre and post laser peripheral iridotomy in primary angle closure suspects and primary angle closure. The angle is measured after these procedures with anti-segment OCT. The inclusion criteria are the primary angle closure suspects and primary angle closure. The exclusion criteria are the primary angle closure glaucoma, acute angle closure glaucoma, plateau iris, and secondary glaucomas. 25 eyes are selected for this study. Out of 20 eyes of primary angle closure suspects, of the 10 patients, 8 are the female patients and 2 are the male patients between the ages of 40 to 50 years. And in 5 eyes, that primary angle closure of the 3 patients belongs to the female category between the ages of 35 to 50 years. Patients with PSES and PSC are treated with laser peripheral iridotomy. Angle dimensions are measured with anti-segment OCT scans. Temporal and nasal cuts are measured before and after the laser procedures. After laser peripheral iridotomy, success is defined as one and more angles changed from closed to open. Angle measurements were taken with the anti-segment OCT before and after the laser procedures. Our results after this procedure revealed there is a significant improvement in the trabeculo-iris angle, angle opening distance, anterior chamber depth in all the 20 eyes. Marked drop in the intraocular pressure is also noted after the laser peripheral iridotomy. This chart reveals the angle depth in primary angle closure suspects. Out of 20 eyes, 18 eyes reveal that angle is dramatically open after the procedure, and the angle width is open almost from 20 degrees to 40 degrees. 2 eyes, there is no significant improvement in the angle depth. This chart reveals the angle depth of primary angle closures. Out of 5 eyes, 3 eyes reveal that there is an improvement in the angle degree up to 40 degrees, and remaining 2 eyes reveal there is no significant improvement in the angle degree. This is a case of primary angle closure suspect. The pre-laser angle is 18 degrees, is widely open up to 40 degrees after the laser procedure. This is a case of primary angle closure, and pre-laser there is shallow AC documented with the biomicroscopy, and after the laser by slit lamp examination the angle depth has increased, and this has been documented by OCT also, that angles are open from 16 to 13 degrees after the laser procedure, which can be documented with the anti-segment OCT. My conclusions are: anterior-segment OCT is a trustworthy tool for the quantitative measurement of the anterior segment parameters like trabecular iris angle, angle opening distance, anterior chamber depth. The angle opening distance is more increased in primary angle closure suspects than the primary angle closure. IOP is dropped dramatically after the laser procedure in almost all the cases. Thank you for
Very
your
nice
attention.
presentation, sir. Any questions from audience, offline or online, to Dr. K.V. Satyanarayana garu? Any questions from audience, either online or offline? Thank you, sir. Thank you for your presentation. Thank you, sir.
Thank you.
Next, I would like to call Dr. Aravind. Share your presentation.
शेयर कर देंगे तो डेस्कटॉप खोलिए। नहीं वहाँ नहीं, अच्छा मुझे खोल के रखना है ना, 1 मिनट मैं प्रेजेंटेशन को ओपन कर देता हूँ, उसके बाद इसको एक लाइन फिर 5 मिनट पूछना। पेयर्स में भी कौन सा नहीं अभी मैं ना ये ओपन कर देता हूँ ओपन करे तो आपको इजी होता है ये करना फुल सिंपल यही है हाँ फर्स्ट प्रेजेंटेशन हाँ फुल स्क्रीन
There's a time limit for all the presentations, about 7.
Time limit for this.
7 minutes. Sir.
7 minutes, huh?
Yes, sir.
Yeah, you introduce yourself and start the topic. Dr. Arvind is presenting.
So, good morning to all. I hope my slides are visible and I am audible. So, I would like to thank the organizing committee and the scientific committee chair of Andhra Pradesh Ophthalmology Society for the opportunity to present our work on microbial keratitis on this forum. I am Aravind Roy. I am a cornea faculty at LV Prasad Eye Institute at Vijayawada. And today we shall be discussing the challenges that we face in managing microbial keratitis during the COVID-19 pandemic and the nationwide lockdown that ensued in 2020. We do not have any disclosures or we do not have any conflicts of interest. Corneal ulceration is a silent pandemic in the Southeast Asian region, especially in India. An earlier paper by Witcher and Srinivasan reported that 840,000 new cases of corneal ulcers occur annually in India. And if you look at the demographics from both India, Nepal, Myanmar, they are 10 times more than what we see in the United States. This makes microbial keratitis a very serious ocular emergency that needs to be handled by all ophthalmologists and not just by the cornea surgeon. Similar to the trends that we have seen prior to the pandemic, when we studied the types of emergencies that came to the ophthalmology clinic during the pandemic, again, the microbial keratitis was the number one etiology, followed by ocular trauma or corneal trauma. So the pandemic brought about a lot of changes, a lot of social order changes that completely changed the way we interacted with patients, the way we treated and gave care as physicians. And the purpose of our study was to understand what are the challenges in managing microbial keratitis during the COVID-19 pandemic and assess the outcomes in a cornea referral service. The study was conducted at 4 tertiary care centers of LV Prasad Eye Institute. It was a retrospective, non-comparative study. It was approved by the Institutional Review Board and conformed to the Declaration of Helsinki. Microbial keratitis that presented to us during 2 months of April and May during the nationwide lockdown phase 1 were studied. Male gender was the predominant in the series, and most of them were in the paying socioeconomic cohort. Since we are a referral service, most of the patients presented from districts which were outside where the tertiary center was located, as opposed to a minority of patients who came from the district where they were residing. Almost overwhelmingly 2/3 of the patients were already on treatment from a local ophthalmologist or a local physician. And they were also on prior medications for microbial keratitis. The corneal scraping yielded fungus as the predominant organism on smear reports. And culture again showed that a lot of samples were negative. This could be that they were already on treatment which could have reduced the yield of the microorganism. And the samples that started growth, again fungus was the predominant species, of which Fusarium and Aspergillus, as is common in this part of the country, were the common organisms. Both surgical and medical intervention were needed in 61% of the patients. whereas 39% of the patients resolved only on medical intervention. The type of drugs that were administered chiefly comprised of antibiotics and antifungals, though some amount of antiparasitic or mixed infections were also needed, which required treatment. Amongst the type of surgical interventions that we performed, tissue adhesives and bandage contact lens was the commonly done procedure. And therapeutic PK was planned in 48 eyes. But the pandemic had also led to a severe consequence on almost complete cessation of eye banking services across the entire nation. And corneas were not available at this time. So therapeutic PK was deferred in 14 because of lack of availability of cornea. And in this time, the eye banking community in India also led to a new change where we also used glycerol preserved cornea. This was a fallback technique from the 60s when glycerol preserved corneas were used for emergency therapeutic PKs. And this was a fallback technique which I believe helped colleagues across the country use this technique to do a therapeutic PK. Glycerol preserved cornea was used in 9 patients and regular fresh corneal tissues were used in 25 patients. At the last follow-up of 32 days, 115 eyes out of 330 eyes that we studied resolved. There was loss to follow-up in 139 eyes, in 139 patients, and 76 were on active treatment. The reasons for non-compliance were, number 1 was travel restrictions. Number 2 was the lack of availability of medications, and in very rare cases, there was a lack of a caregiver for treatment. Therefore, abnormal social circumstances may lead to abnormal difficult measures, and the COVID pandemic related lockdown is one such thing that we will all remember throughout our lives. And there were impediments in access to healthcare, impediments to travel, and affected the compliance to treatment of ocular emergencies. Thank you very much for your patient here.
Thank you, Dr. Arvind. Dr. Arvind, I'm very thankful to you because you came to Guntur to give a lecture to the PGs. I'm very thankful to you for your help from LV Prasad. Any questions from audience, online or offline? Dr. Arvind, the corneal specialist in Vijayawada place, LV Prasad Institute. Any questions? Online, offline? Sir, you said there's a glycerol preserved cornea. What is your reference or inference, and what is your expectations of the transplantation?
So the glycerol preserved cornea is a useful technique when corneas is not available, and in dire emergencies such as the lockdown, when eye banking had completely collapsed across the country. Glycerol preservation is something as simple as placing a corneal tissue in a vial of glycerol. They can be preserved at room temperature, even in the freezer compartment of a normal refrigerator, or in an eye bank refrigerator at -80 degrees. And the tissue stays indefinitely in all 3 conditions.
How is the outcome, sir?
The outcomes are that it provides good tectonic support. The side effect of that is that epithelialization is very slow. So if that is the case, the graft will start to melt. So regular follow-up is needed, and if there is a melting and persistent epithelial defect, then we should place either a simple thing as simple as a tarsorrhaphy can be done to promote epithelialization. And if we have access to availability of amniotic membrane, even placing amniotic membrane is also suitable in re-epithelializing the glycerol preserved cornea. But in our experience, something as simple, as basic as a lateral paramedian tarsorrhaphy helps in reducing the epithelial defect and promoting the health of the surface.
So what are your observations when compared to this microbial keratitis that are during non-COVID time?
Sir, the patterns are essentially the same. That even in the non-COVID time, in a cornea referral service, most of the scrapings are negative. This is because of 2 reasons. Number 1 is that the patient may already be on several medications. So the organism that is on the surface of the cornea is now in the deeper layers from where we do not get the scraping. So organism is there. Eye is still having infection, but microbiology is negative. The second thing that we see is that the fungus is a very common organism in our scenario. So that again is the trends of seeing fungus are again very similar to what we are seeing before the pandemic also. So again, because fungus migrates very much into the deeper layers, they may be negative, but it may be smoldering inside in the deeper layers of stroma, leading to poorer outcomes.
Is there any decrease in incidence due to hand sanitization and staying at home?
Yes, hand sanitization, if that is not properly followed, often there is a risk of actually transmission of COVID in these patients. Now, when COVID transmission occurs, there is a chance that the neural sensations of the cornea are lost. So the chance of healing again decreases in such cases. So possibility is certainly there.
Thank you, Dr. Arvind. Very good presentation. Now I welcome Dr. Ranjit Kumar.
Thank you very much.
The famous surgeon of Vijayawada, for a good presentation for the safeguard of all the ophthalmologists. Slit lamp, which is the instrument all the doctors have to see, and their exposure.
Sure, sir. मेरा लैपटॉप प्रेजेंटेशन सेटिंग्स में जाना है कल भी ऐसा आया ओ सेटिंग्स इसमें कुछ चेंज करना नाम तो क्लियर इवेंट है हाँ स्क्रीन शेयर చేంజ్ అయిపోతుంది ఏం సెట్టింగ్ వెయిట్ సార్ అది వస్తుంది కదా నిన్న ఇదే आपका बाय डिफॉल्ट क्यों नहीं आ रहा हाँ बच्चे स्क्रीन స్క్రీను ఎల్ఆర్జీ అయిపోయింది ఇట్లాగా రిజర్వేషన్ తక్కువ కదండి ఏం చెప్పండి రిజర్వేషన్ వేరే ఉంది కాదమ్మా నిన్న చేశారు ఇది ఇదే లేదు ఇప్పుడు మా ఇది కూడా అలాగే ఉంది మరి ముందే కరెక్ట్ చేసి చూసుకోవచ్చు కదా సరే ఓకే జూమ్లోనా వైఫై
Zoom ఉంది పైన వీడియో
The delay will go for the next speaker, Sherry.
मैडम सर नेक्स्ट करते
Ready?
आप కూర్చోండి నేను చేస్తాను జూమ్ పెడతావా
Sir, you adjust. Meanwhile, you adjust, sir. Yeah. The next speaker, Anamika.
Yes, sir. May I share my screen, sir?
Sweta.
Sir, Dr. Anamika here. May I share the screen or we are moving to Shweta?
Okay, Sweta, what about you? You want to present her? Please, please. Anamika, requested to wait. Requested to wait.
Okay. Okay.
Shweta, they can now go. Shweta, they can now go.
Good morning, respected one. Good morning, respected one. Good morning, fellow seniors. Good morning, fellow seniors. Good morning, my co-PGs. Good morning, my co-PGs. Hello? Hello? Good morning, respected ones. Good morning, respected ones. I'm Dr. Sri Shweta. Good morning, respected ones. Good morning, respected ones. I'm Dr. Sri Shweta. Today I'll be presenting a paper on a study. Today I'll be presenting a paper on a study on the rise of the placid fungus, rhino-orbital cerebral mucormycosis, and its sequelae in SARS-CoV-2. A multidisciplinary approach to curb the diabetic doom. I have no financial interest, and I thank APOS for giving me this opportunity. ROCM is a rare angioinvasive. Coming to ROCM, ROCM is a rare angioinvasive, life-threatening fungal infection resulting from the zygomycete of the order Mucorales. We present a study on 100 patients diagnosed with mucor. The mean age was 49.82 plus or minus 11.9. 70% were males and 81% recovered from COVID. 93% were diabetics. 13% and 4% of the patients had diabetic ketoacidosis and renal failure respectively. 91% of the species isolated were mucus species, followed by 4% of Aspergillus species, 3% of Rhizopus species, and 2% of Candida species. Coming to the clinical features, we had a variety of clinical features. So, ranging from defective vision, in the patients, there was a defective vision ranging from 660 to PL negative, and proptosis, ptosis, exposure keratitis, orbital cellulitis, multiple discharging sinuses, ophthalmoplegia, and visual field defects. Coming to the ROCM staging. So, we staged all our patients based upon a very simple and an effective system of the proposed staging system, which is simple and follows the general anatomical progression of ROCM from the point of entry, that is, the nasal mucosa onto the paranasal sinuses, orbit and brain, and severity in each of these anatomical locations. So, coming to the stages, we have 4 stages. Stage 1 is involvement of nasal mucosa. Stage 2 is involvement of paranasal sinuses. Stage 3 is involvement of orbit. And stage 4 is involvement of CNS. Now, this is a study that I've done. And as you can see, majority of the patients, they came up in All stage the 3. patients underwent RT-PCR, routine blood investigations. Patients MRI, underwent RT-PCR, routine blood investigations, MRI, CT, nasal mucosal endoscopy, and histopathological examination. After confirmed with fungal elements, the patients were started on retrobulbar or systemic amphotericin B and posaconazole without any delay. PES was done for all and exenteration was done for cases with a poor prognosis. As we can see over here, radiological investigations have played a very important role in staging all the patients and in my study. Coming to T1 and T2 imaging, as we can see over here, there's a hyperintensity noted in the subcutaneous plane of the entire face, in which the right part of the face is involved more compared to the left the right frontal convexity, part. which says that And there's a leptomeningeal enhancement noted along the right frontal convexity, which says that signs of meningitis were injection evident. liposomal amphotericin Coming to the B, treatment, so all the patients were treated with injection liposomal amphotericin B, 3.5 milligram, along with 1 cc of 2% xylocaine. It was given in the retrobulbar space on alternative days for 10 days. Tap posaconazole of 300 milligram BD stat and OT for 7 days, or injection posaconazole of 300 milligrams in 150 ml of 5% dextrose, or IV liposomal amphotericin B 300 milligrams per day, or till disease subsided. We've used drops like HPMC eye drops, Timolol eye drops, IV antibiotics like metronidazole, oral hypoglycemic drugs, and insulin was given based on the patient's sugar levels. So this was a very interesting case in which the patient had rhino-orbital cerebral mucormycosis along with lacrimal tuberculosis as well. And this patient was given liposomal amphotericin B, and we can see the enormous amount of improvement. 18% of my study, the cases in my study underwent 18% of my the cases in my study underwent exenteration after we explained the poor prognosis to the patient and we took the consent. Other 82% did not undergo. So this is a picture which is depicting the eyelid sparing exenteration procedure, and this is a post-operative picture following nasal ouching. The wound gaping was present in this patient. Had presented with ophthalmoplegia. Coming to the results, majority had presented with ophthalmoplegia, and an 83% presented with exposure keratitis, and 69% of the patients had cerebral injury. High risk of developing. All the patients who recovered had a very high risk of developing meningitis with a p-value of 0.004 due to Matyr. Patients with cavernous sinus thrombosis with a p-value of 0.008 and cerebral abscess with a p-value of 0.007 should be treated early because they worsened at later stages and they required exenteration. Factors like age, gender, COVID status, diabetic status not influence the stage of the presentation, and that was statistically proven. It shows all the So coming to this very interesting chart that I put up, it shows all the complications in my study. As we can see over here, this is exposure keratitis, cerebral abscess, meningitis, field defects, optic neuritis, ophthalmoplegia, cavernous sinus thrombosis, reattachment, intraretinal artery occlusion, orbital cellulitis, pulmonary muca, and scleral abscess. Which is depicting all the interesting cases in my study. This is another interesting slide which is depicting all the interesting cases in my study. So this was a 50-year-old gentleman who had come with severe conjunctival chemosis with dilated pupil, not reacting to light, and on posterior segment examination, this person had retinal detachment. And this was another 67-year-old male who had come up with a severe exposure keratitis. This was mucormycosis in a 7-year-old male child. This is APOSEYECON with multiple sinuses, and as we can see over here, lower lid abscess. This was APOSEYECON, intracerebral fungal granuloma. And this was ROCM with plexiform fibroma. This was ROCM along with herpes zoster ophthalmicus. we've come to a So knowledge this is a that very we've come to knowledge that we had to obviously use every other department to help us curb this sudden epidemic, and it was a multidisciplinary approach. So once the patient got admitted, so regarding we first took his COVID status, if it was COVID positive or if he was post-COVID, and any patient who was with clinical suspicion, so we admitted him. We just got all the investigations, PCR, RFTs, LFTs, blood sugars, CBP were done. They were referred to the general for nasal mucosal had any elevated sugars. Then later they were sent for nasal mucosal endoscopy for fungal elements. Afterwards, we had immediately begun retrobulbar LAM and posaconazole without any delay. They were referred to radiologists because, as I told you, we have used the classification system based upon Dr. Santoshi Hunavar et al. We had to classify and 4, and we would understand the patients with good prognosis or bad prognosis, and stages into stage 1, 2, and 4, and we would understand that the patient had worsened after admitted drugs to the medical management. If we were seeing in our daily rounds that the patient had worsened, then we referred him. Motivated the patient for exenteration, and we referred to the Department of Neurosurgery. Diagnostic nasal endoscopy and direct microscopy. Coming to the discussion, a high index of clinical suspicion, early diagnosis by diagnostic nasal endoscopy and direct microscopy of the high nasal swab, or an endoscopically guided nasal swab supported by an MRI or CT scan. Medications post-surgical management and continues down oral antifungals until clinical and radiologically monitored. As India is a diabetic capital and there's a high risk of ROCM in diabetics, prophylactic control of blood sugars along with an appropriate multidisciplinary approach, we can curb this diabetic doom. The sudden epidemic of ROCM and its variety of presentations led to a curiosity to study about it, learn about it, and that we can be cautious for the next epidemic waves of ROCM.
Congratulate Dr. Revati Dhanraj for guiding you.
These are my references. Thank you. Thank you, APOS, for giving me this opportunity.
And congratulate Dr. Revati Dhanraj for guiding you. Any questions to Shweta from online or offline from audience?
Presentation of
What
the
do you think
patient.
that
Your initial presentation of this type of.
You and before
What is the first
or
presentation?
it came directly to you or from the physician?
Presentation of the patient to the
How is your
doctor.
protocol of
Yes,
the
sir.
complaint with what complaint symptoms the patient has come to you?
So,
And before
majority
to
of my
you, he
patients,
went to
they
ENT or
came
he came
in
directly
stage
to you or
three,
from the
which means
physician you were referred
right
to you?
after they
And
had
how is
come
your
with
protocol of
defective vision.
management?
So
SAS
they
question.
had a very common complaint. So majority of my patients, they came up in stage 3, which means that right after they had come with defective vision, sir. So they had a very common complaint. They said that we had vision till yesterday, and day before yesterday we were all COVID positive. So they gave a proper history that they were post-COVID patients, and they said that we have been taking oxygen, and based upon the history and on examination we could see that there was a defective vision. So it ranged again right from CF, it ranged to PL negative, and after even defective vision on clinical examination also we could see that they were completely having either ptosis.
Eyelid or conjunctival congestion not responding, or any of the external affairs like mild proptosis, etc.
So the patient was bothered by these clinical
You said
features.
it is because of follow-up vision they have presented to you.
Were there any other complaints with which the patients have come? Is it only just because there is a defective vision they came? Or there were any other presentations like this is like water, etc.
Yes, sir. Yes, sir. There was proptosis and
Patients came with the complaint of defective vision only. See, there are so many other complaints which the patients might have come or attended to your department. So what is the reason for this diabetic doom? You are saying.
yes, sir.
That means these cases have occurred in the patients who are non-diabetics, or the diabetes could be due to?
Sir, patients who have all, a lot of, like 83% of my cases, they were all diabetics. Majority of them were diabetics, sir. And these people were already in a state of immunosuppression. Along with that, these people, they had a history of COVID-19. And they gave us a history that they had been taking steroids or they were put on oxygen. So we came to a conclusion that already the patient was in a state of immunosuppression. And henceforth, the fungus could have flared up.
Not only The severity was because the patients were already known diabetics. At the same time, because of the steroid treatments, the patients who were non-diabetic earlier to the COVID infection have turned to be diabetics. So that is the sole reason for this infection. Okay.
Yes, sir.
So that also we should understand.
Yes, sir.
Well done.
Thank you, sir.
Any questions from?
So thank you, sir. Thank you.
Ranjit, you're ready? The next speaker is Ranjit Kumar.
Good morning, respected dignitaries, teachers, professors, and audience. Today, I am presenting a paper on how to get protected from SARS-CoV-like viruses during slit lamp examination. I have nothing to disclose financially. Ophthalmologist, ENT surgeon, and dentist need to go very close to the patient during examination. There is a more risk of getting exposure to aerosol-borne viruses. During slit lamp examination, ophthalmologists go very close to the patient every time. We need to take utmost possible precautions to prevent getting exposure from corona-like viruses, for which no definitive treatment is available and life-threatening also. Ask patients for any history of fever, dry cough, loss of smell and taste, cold, etc. The surgeon should wear a gown covering the entire body, wear cap, mask, protective glasses, gloves and shoes. The surgeon should wear a PP kit, either disposable or reusable, to cut down the expenses. The patient should use a disposable gown, cap, mask, leggings. Staff also must wear an apron or gown, gloves, mask, with or without face shield. Here the patient is wearing the gown, disposable gown, cap and leggings. The staff are wearing the aprons, masks and gloves. And this is a small arrangement made with a transparent curtain in the form of L shape, separating the patient chair from the slit lamp and examiner chair. And the height is up to 7 feet. And there is a door, external opening for the outdoor ventilation, for the cross ventilation. Though the air condition is there, but still the door should be opened. And this is how it looks when you see from a side, when the examiner is sitting in front of the slit lamp. And there is a slit in front of the slit lamp, which is overlapping. In front of the slit lamp, which is overlapping transparent curtain. It opens in this form to allow the patient to keep his chin on the chin rest. And also there is an additional shield in front of the eyepiece of the slit lamp, as you see, that will protect while examining the patient directly. This is the view from the patient side to allow him to keep his chin on the slit lamp. This is a small video showing how to place the patient on the chair and examine how it works. Here the chair is rotated outwards. Ask the patient to sit, then turn the chair towards the slit lamp. Then move your slit lamp towards the patient and ask him to place his chin after opening the curtain. Then the examiner examines the anterior segment, and also he can use the 90D also comfortably without any obstruction. And after examination, when the patient removes the chin, automatically the curtain collapses with the overlapping flaps. And the patient can directly see you, and also you can interact with the patient without any hesitation. And this is also another video which is viewing from a side. Ask the patient to sit and then rotate the chair towards the examiner, and the examiner can examine anterior segment and 90D also. Because in this COVID-like pandemics, though we have to protect ourselves. Nobody will come and rescue. So this is a simple thought of arrangement, at least because every day we have to see the patient. We cannot stop our practices. So at least some care, at least give some protection. This is a 90-day examination. This ensures good protection for the examiner, especially when there is a more patient load, also when there are repeated waves of pandemic. Thank you.
Any questions, online or offline from audience? Thank you, Dr. Ranjit, for the safeguarding the ophthalmologists. Now I request who is ready? Dr. Padmini?
Yes,
Dr.
sir.
Anamika?
Sir, Anamika here. Shall I share the screen?
There are two more left in the Professor K. Vengalrao best free paper. Dr. Anamika and Dr. Padmini. Is it online? Yeah, please.
Is my screen visible to everyone? Sir, can you hear me? Am I audible?
Hello.
Hello?
Ma'am, voice వస్తుందా మ్యామ్ ఇది?
Okay. May I start, Andy?
Ma'am, can you talk louder?
Sir, can you hear me now?
Yes, ma'am.
Okay. Thank you, Scientific Committee, for giving me the opportunity to speak about our work. So today I'm going to be speaking about ocular toxoplasmosis of optic nerve head, the clinical features, management, and visual outcomes. I'm Anamika. I'm a medical retina and a uveitis consultant at LVPI Institute GMRV campus, Vizag. And these are my co-authors. So optic nerve toxoplasmosis is one of the rarest infestation of optic disc toxoplasmosis that one gets to see. The most commonest infectious retinitis in the posterior pole is toxoplasmosis. So we were seeing quite a lot of cases which were affecting the optic disc, and that's when we thought that let's look into the literature that how is the optic nerve affliction seen in rest of the world. So to our surprise, we came across only two studies, which one is from Brazil and another one is from Turkey, where they have observed the changes in the optic nerve in ocular toxoplasmosis. So this brought us to the very purpose of our study, to study the clinical features, management, visual outcomes of the ocular toxoplasmosis of optic nerve head in the Asian Indian patients who presented in the southern India. So it's a retrospective study done between January 2006 to January 2021, where we have studied various involvement of optic nerve head. All the cases of toxoretinitis were included in the study, which involved the disc. Second was when the lesion was at the juxtapapillary, what you can see here, or when the secondary nerve involvement was seen when a retinitis was within 1 disc diameter from the disc. All of our patients received the antimicrobial therapy, which was trimethoprim, which is 160 milligram, along with the sulfamethoxazole 800 milligram for 6 weeks. A total of 40 eyes we have seen. They all had a unilateral presentation. Interestingly, the male and female ratio were equal. All the patients complained with the very most common complaint was the blurred vision for 2 weeks. And amongst the set of these 40 eyes, 4 patients turned out to be immunocompromised. So the three manifestation that we have seen in our case study is presentation of the infiltration of the disc, which was group 1. About 25% of the patient presented in that manner. Another presentation was a juxtapapillary, where the retinitis was on either aspect of the disc, which was about 35%. And then we saw a secondary optic nerve involvement, where the retinitis was within 1 disc diameter and the disc was edematous. This was one of the most commonest presentation that we have seen in our optic nerve toxo study. Amongst the imaging features, the 12 cases in which we could do the fluorescein angiography, optic nerve head was found to be hot, where we saw the presence of the hyperfluorescence. The most another striking finding that we have seen on the swept source OCT was the presence of a sticky vitreous adhesions that you can see, and a presence of these hyperreflective dot. This was seen in about 50% of our patients. So moving on to the next set of results, because the resolution was seen within 8 weeks, that is about 2 months, and about 75% of the patients achieved the visual acuity between 2025 to 2050. So if you ask me what's new in our study, it's really great to share our experience that though the Brazilians have studied 51 eyes, but in their study, the distant lesion was seen in 43.1% of the eyes. That means the lesion was at the peripheral of the retina, whereas in Turkey study, the lesions were seen as the juxtapapillary in the 17 eyes. What we have found in our study is ours is the first study to comment on the OCT features of these lesions. And we have seen about 40% of the secondary nerve involvement, which is within 1 disc diameter of the disc. And we have come to the conclusion that these eyes resolve within 6 to 8 weeks. So I would like to conclude that toxoplasmosis, when it involves the optic nerve head, it can either present with a papillary, juxtapapillary, or a secondary optic nerve involvement. And they all have a favorable outcome with the antimicrobial therapy. Thank you for the patient listening. Thank you.
Right. Any questions from audience or online?
Is there any specific reason that the optic nerve is involved?
So it's an atypical presentation.
Toxoplasmosis.
Yes, sir. So it's an atypical presentation. That's the reason why we get to see that. And it's one of the most commonest presentation next to the macular presentation.
Okay.
Thank you.
How do you say that it is due to toxoplasmosis only? What is the other DD? You must have thought about it.
That's a very good question, sir. So it is based on the OCT features that we have found. Is it based on the IgG and IgM levels based on the serology? And if someone has a confusion regarding it, they can also do a PCR to understand if they are dealing with the toxo or not. But in all our patients, the IgG level were very raised and they were immunocompetent. Only 4 patients were immunocompromised. And they showed a very good response within 3 or 4 days when you first start seeing the resolution after the starting of the antimicrobial therapy.
There are no questions. We will proceed to the next speaker. Padmini.
Yes,
Ready?
sir. Yes, sir.
Okay.
You can hear me, sir?
Yeah, you can come. Start.
Okay, sir.
Offline, is it?
Yes, sir.
You please pay the Padmini's
You can see my slides, sir.
slides, please. Yeah, now you can start.
Okay. Good morning, everyone. My name is Dr. Padmini, working as a cornea consultant from Vishaka Eye Hospital. Today, I'm going to present about the posterior corneal astigmatism distribution who presented to our hospital. So the main purpose of the study was to provide the description of posterior corneal astigmatism in relation to the orientation of anterior corneal astigmatism as measured by IOL Master 700 in phakic eyes who presented to our hospital during the period of March 2020 to February 2021. So IOL Master 700 measurements were analyzed to provide both the magnitude and the orientation of steep and flat axis of anterior as well as posterior corneal astigmatism. Further, we did a subgroup analysis to assess the correlation of the posterior corneal astigmatism characteristics to the anterior corneal astigmatism. Then we also tried to describe the distribution of posterior corneal astigmatism with age. So these are my demographics of study population. We collected a patients of around 1154 eyes. All of them were single eye from each patient. In an age group, on an average, we found that our age group was 62 years. with equal male and females, and right and left eye also were almost equal, with an anterior corneal astigmatism in the range of 0.06 to 6 diopters and posterior corneal astigmatism at a range of 0 to 0.7 diopters. We categorized our steep axis as vertical as 60 to 120 degrees, oblique as 31 to 59, 121 to 149 as oblique, and horizontal as 0 to 30 degrees or 150 to 180. So these are our distribution of orientation of steep axis on the anterior and posterior corneal astigmatism, where we found that only 20% of our cases had anterior corneal astigmatism vertical, whereas 63% of our cases we had anterior corneal astigmatism as horizontal. Very few cases, that is 15%, were oblique. Whereas when coming to the posterior corneal astigmatism alignment, 87% of our cases had vertical alignment on the posterior surface, and only 3 and 9% respectively of the horizontal and oblique astigmatism. So this is a graphical representation, a scatter plot of orientation of steep axis of anterior and posterior corneal astigmatism. If we see on the horizontal axis, the anterior corneal astigmatism, most of the cases were distributed at 0 and 180. And on the y-axis, that is the posterior corneal astigmatism, most of them were distributed at 80 to 120. So we further analyze them subgrouping the steep axis of anterior and posterior relation. We found that when the anterior cornea was vertical, the posterior cornea was vertical in 98% of the cases. So we have to remember that with the rule, most of the time the posterior cornea is also vertical. Whereas in the case of anterior corneal astigmatism, when it was horizontal, only 80% of them were vertical, whereas 5 and 12% respectively were horizontal and oblique. Even in the oblique astigmatism, 90% of the cases, the posterior cornea was vertical. So this is the age-wise distribution of average astigmatic power, both of the anterior and posterior corneal surface, where in the age group of 20 to 29, the anterior corneal astigmatism on average was 1.4, whereas the posterior power was 0.37. So we found that most of our cases were in the age group of 60 to 69. This is a bar diagram showing the anterior corneal astigmatism by age group. So as the age increases, the vertical astigmatism also decreases and horizontal astigmatism increases. Whereas for the posterior corneal astigmatism, even as the age increases, the posterior corneal astigmatism remains vertical. So this shows that the posterior corneal surface remains same throughout the age. This is a scatter plot showing the correlation between the anterior and posterior corneal astigmatism magnitude for all the orientations of anterior cornea. So we found a weak and statistically significant correlation between anterior corneal astigmatism magnitude and posterior corneal astigmatism magnitude, where we find that as the magnitude of anterior corneal astigmatism increases, the posterior corneal astigmatism has only a slight increase, that is, it doesn't have a steep rise. Whereas when the anterior cornea was vertical, as the magnitude of anterior corneal astigmatism increases, even the posterior corneal astigmatism magnitude increases. If we see, the trend line is increasing as the magnitude increases. So this is very important in young individuals, that it has a nullifying effect that overall total corneal astigmatism decreases in young individuals. This is to show when the posterior corneal astigmatism was horizontal, there was no significant correlation between the anterior cornea and posterior cornea. That is, as the magnitude of anterior corneal astigmatism increased, the posterior corneal astigmatism magnitude did not increase. So our results show that the mean posterior corneal astigmatism was only around 0.2 diopters and posterior corneal astigmatism of 0.2 diopters or less. So we found that 62.5% of our measurements, the posterior cornea was only 0.25 diopters. And the steep axis of posterior cornea was vertical in 87% of our measurements. So there is a correlation between the magnitude of anterior and posterior corneal astigmatism was greatest when the steep axis was vertical. Vertical orientation of steep axis of anterior corneal astigmatism became less common as age increased, whereas for posterior corneal astigmatism, it remained the far most common orientation. We tried comparing our results with that of the recent studies, where we found that our magnitude of posterior corneal astigmatism was less when compared to the other studies. The reason behind this is most of our cases, that is 63% of our cases, were horizontal astigmatism, whereas in the other studies, the more than 50% of their cases were vertical astigmatism. But if we find the percentage of posterior corneal steep axis, our percentage was similar to the other studies. So to conclude, IL Master 700 appears capable of providing enhanced biometric measurements for individualized surgical planning, and we don't need a secondary tomographic device or a lens calculation formula that merely estimates the impact of posterior corneal astigmatism. There was clinically important variability in the magnitude of posterior corneal astigmatism, and the data also indicates that only way to accurately assess the magnitude or the optical impact is to measure it directly. These are my references, and thank you.
Well done. Any questions?
How can you measure posterior corneal astigmatism?
Ma'am, this is Swepso's OCT, ma'am, where it directly measures the posterior surface, ma'am. IL Master 700 has a principle of measuring the posterior corneal surface using Swepso's OCT, where multiple images are taken from the anterior corneal surface up to the fovea, ma'am. So directly the posterior corneal surface is measured. Along with the pachymetry and with the anterior corneal surface by telecentric keratometry, we get the total keratometric reading.
Any relation between anterior corneal astigmatism and posterior corneal astigmatism according to age?
Yes, ma'am. As age increases, we found that with the rule becomes horizontal in cases as age increases, as the recent previous studies say. So the posterior corneal astigmatism is high in the case of with the rule patients, and in against the rule, it is very less. So in with the rule patients, when we are going for any toric IOLs, we should definitely undercorrect them as well. In the cases with against the rule, the posterior corneal astigmatism has an additive effect. So we should overcorrect them. The posterior corneal surface acts as a concave lens, whereas anterior corneal surface is a convex lens. So this negative lens, when comes onto the surface of the anterior, it becomes a negative effect, ma'am. Suppose if we take 2 diopters of with the rule, when we get a posterior corneal astigmatism of 0.5 diopters, when it comes on the anterior surface, it becomes against the rule. So it has a negative effect. So we have to minus the 0.5 from the 2.5 diopters. So correcting the toric lens is only for 2 diopters. So we should keep this in mind. So only when we know the magnitude of astigmatism on the posterior surface, we can correct properly for the toric IOLs, ma'am. This gives a refractive results for toric IOLs.
Is it necessary to measure posterior corneal astigmatism before cataract surgery?
Not always, ma'am. Not always, especially for premium IOLs and toric IOLs, we need to know the posterior corneal astigmatism magnitude. But in Indian scenario, we found that 80% of our cases are against the rule. And we found in our study in 1100, we found that posterior corneal astigmatism on an average is only 0.2 diopters, where it does not have an account. So if it is against the rule, most of the time it has given good results even when we do not measure the posterior cornea. But with the rule patients, we found that even with the 3 diopters of anterior cornea, we had an astigmatism of the posterior surface even up to 0.8 and 1 diopter. So definitely it has to be measured in cases of with the rule, and when we are especially doing toric IOLs, it needs to be calculated.
Patni, I think you must have studied without this posterior corneal astigmatism and without the estimation also you have done
yes,
some
sir.
of the toric IOLs.
Yes, sir.
So
we are doing a study on
how much
toric
difference did
IOLs.
you find? Is it that it's so mandatory that you have to do it with such kind of small
Yes, sir. Yes, sir. We found definitely a drastic, significant role by measuring posterior corneal astigmatism.
It's okay, there is a role, but how
Sir,
significant?
it was giving an overcorrection of 1 series more, sir, in some of the cases. So, yes, sir. 1 series 1, like we have T1, T2, T3. When we were measuring with the without taking a posterior corneal astigmatism and just assuming it as according to Koch's principle as 0.3 to 0.5. We were getting a series of toric IOL as more additive, like T4, T5. Whereas when we took the measured posterior corneal astigmatism, the toric cylinder was only T3 series. So when we placed these with T3, we had good results when compared. We were overcorrecting them.
So, Dr. Padmini, what is your final inference?
We need to measure posterior corneal astigmatism directly in cases of toric IOLs if we are going for a toric IOL implantation. And in our scenario, we found that more than 80% of cases are against the rule. The posterior corneal astigmatism is very less. Whereas in anterior corneal astigmatism, it is high.
Any questions from audience, either online or offline? Right. Now we go for the next one, Professor V. Raghavachari, best paper. Thank you, Padmini. This second session.
you for the minutes.
Professor V.
Thank you,
Raghavachari, best free paper. I hope all the participants are ready. First one. Absent. Dr. Venkat Prabhakar Guduru.
Yes, sir. I am there, sir.
Yeah, please. Welcome.
So can you see my presentation?
Present.
Good morning, everyone. My presentation is on PCO ring, a novel device to prevent posterior capsular opacity and enhance toric IOL stability. No financial interests. So it has been 2000 years since the first ever cataract surgery was performed. Since then, there has been a lot of evolution. Starting with heraldry release lenses, then we moved on to the Kelman's phacoemulsification. Now we are standing at trifocal lenses, which use all three ranges of vision. But there are few factors which prevents the cataract surgery to reach its zenith, that is posterior capsular opacity. So even with so many advances, we are still stuck at 12% of incidence at 5 years. And most of these PCOs need AC capsulotomy, which may end up as retinal detachments and cystoid macular edemas. So our idea was, why not completely eliminate this PCO? Coming to the pathology of this PCO, what happens is after the intraocular lens implantation, the anterior epithelial cells starts proliferating, then they move on to the equator and then onto the posterior capsule to form posterior capsular opacity. So the main culprits here are the gap between the optic and posterior capsule, so that lens cells can proliferate, and the space over the equator through which they pass on to the posterior capsule. So our idea was to develop a device which acts as a robust barrier to prevent epithelial cell migration, and something that completely eliminates the gap between the optic and posterior capsule, so that these cells cannot move there and proliferate. So there is no space, no cells. So our device was made up of hydrophobic material with 6.5 mm inner diameter and 9 mm outer diameter with 0.4 mm of thickness, and it comes with 4 dialing holes, and it has to be implanted after a regular IOL implantation. So this is a small animation showing how this works. So this is our PCO ring. It is loaded onto the cartridge just like any other intraocular lens. So here we can see an intraocular lens is already placed, and as you inject our PCO ring, it opens up, and this does two things. Here we can see there is a gap between posterior capsule and optic. So once this is implanted, it pushes the optic against the posterior capsule, thus eliminating the space for cells to proliferate. So there is no cells, no space, no cells, and no PCO. And the second thing that this does is, once it's implanted into the capsular bag, it opens and sits right in front of the equator, acting as a barrier so that anterior epithelial cells doesn't move on to the equator. And this is an intro video where we can see the lens is already implanted. This is our device, PCO ring, a simple device made up of hydrophobic material with 4 dialing holes. And it is loaded into the cartridge, regular cartridge, just like any other intraocular lens. So as being made up of hydrophobic material, it gives ample time for us to insert into the capsular bag. You can see that it is slowly unfolding, and it all needs a single nudge with the help of the dialing hole into the capsular bag, and it goes into the capsular bag, and it has to be concentrically arranged around the optic, as we can see here. Here we are deliberately forming AC tight so that we can show the correlation between optic and PCO ring. Here we can see how beautifully they are sitting concentric to each other, and we can see 4 dialing holes also. And this is one of the 3 years postoperative picture where we can see a crystal clear posterior capsule as transparent as a cellophane tape. And in the second picture, we can see the bunch of epithelial cells that are struck right in front of the PCO ring. That's how it acts as a barrier. Here it is an interesting OCT picture where we can see the optic here, and here we can see the PCO ring, how it is stuck to the anterior capsule. And here we can see that there is no gap between posterior capsule and optic. And this wavy thing we can see is anterior hyaloid phase. So we are getting very good results. So we did a study where we included 50 patients with bilateral NS2 grade cataract. Both eyes phacoemulsification was done 1 week apart by the same surgeon. One eye was implanted with PCO ring, and other eye was not implanted with PCO ring. At 3 years, PCO was evaluated. So the results are only one eye with PCO ring developed PCO, whereas 11 eyes without PCO ring developed PCO. And since it is made up of hydrophobic material, we thought it gives stability to toric lenses also. So we did a small study on this. Here we can see a toric lens is already implanted and aligned to the markings. Here we are implanting the PCO ring. So once the PCO ring is implanted, here we can see, even if you try to rotate the lens, it doesn't rotate. It just snaps back into its own position. Here we can see that. Highlighting the stability of toric lenses with PCO ring. So we did similar study on rotation of toric lenses postoperatively, and it was as low as 2.85 degrees. And whereas in the group where PCO ring was not implanted, it was around 5 plus or minus 1 degrees. So to conclude, PCO ring is a simple and cost-effective device, gives superior outcomes, especially in premium IOLs, multifocals, and definitely toric lenses. And definitely it's a boon in high-risk cases of retinal detachments and one-eyed patients and high myopes, where you should totally avoid capsulotomy, where there are high chances of retinal detachments. Thank you, sir.
Right, Dr. Prabhakar, very nice presentation. And where we can get this one? How many cases you have done and what is your inference?
This study we included 50 cases, sir, because we had proper 3 years follow-up.
How long you have conducted the study?
3 years, sir, 3 years.
3 years. How is the outcome from the third year case to the latest, the last 6 months case?
Definitely, sir. None of them are having PCOs. Only one case we had, it was a high myope. It was more than 26 axial length. So for those cases, we are thinking of developing a thicker ones. This one is 0.4 mm thickness. Since the capsular bag is big, maybe we are planning for thicker PCO ring. Other cases, no incidence of PCO, sir. Crystal clear posterior capsule.
So you need to suggest all the cases to be done like this?
Sir, I can't hear you, sir.
Yeah, you mean to suggest for all the IOLs this device?
Definitely, sir. Because you can totally eliminate PCO and there is no chance of cap, and definitely takes cataract surgery a step ahead. Definitely we can implant. Right now we are implanting it for our multifocals and torics and high myopes.
What's the difference between CTRs and PCO rings?
CTR, so ma'am, it gives support to the capsule where it goes and sits in the equator, and it enhances the jugular support. This one doesn't go up to the equator, ma'am. It sits in the pre-equatorial area, and it gives barrier effect. And at the same time, it pushes the optic against the posterior capsule so that there is no gap. So both are totally different concepts.
Can this ring be used in a patient with the PC tear?
No, definitely not, sir. No.
Because there it can act as a support to the placement of the IOL. Similarly, why you are inserting this ring after the placement of the IOL?
Sir, we want the optic and posterior capsule to tightly adhere. So that is so for that we are implanting over the IOL so that it will push it against the posterior capsule.
What about the edge of the lenses? There are some IOLs which are having a square edge, which the purpose is to prevent the occurrence of the PCO. And the incidence of PCO is not that common, as you are saying. Since you are advising now itself that it should be inserted in every case. We have been following our own cases for the last 10 years or even more than 15 years. But most of them are not having any PCOs. If at all they occur, they may be occurring within 2 to 3 years. Not after that. But
It
after
happens
that,
in first 1 or 2 years, or maybe 3 years.
since PCO is absolutely almost nil.
Sir, but still
But why
we are
this?
doing
I mean,
capsulotomies. But still we are doing ACT capsulotomies. And every ACT capsulotomy, it is associated with CME or retinal detachments. So we wanted to totally eliminate that thing. Even with square edge dioils, there is an incidence of 13%, sir, at 3 years. There are many studies which say that. So our idea was to totally eliminate PCO.
Available in India?
Yes, sir. It's made in it's developed in Shankarai Hospital, Coimbatore, and it's very much available. It's not available commercially, but we have been using it from quite some time.
What will be the extra cost for insertion?
It's very cheap device, sir. Maybe it will cost around 200 to 250 rupees. That's it.
Oh yes, thank you.
It's a regular hydrophobic thing.
We can also study if it is that much.
Yes, sir.
Yeah, thank you. Thank you very much. Wonderful presentation.
Thank you.
What about next one? Ashok, is it ready? Bob? Yeah, Ashok.
Are you there? Go ahead.
Compared to study of early 6 weeks
Next
versus
slide,
conventional 12 weeks, silicone oil removal. Compared to study of early 6 weeks.
From that slide. From the second slide. Just come back. Good morning, respected judges, and thank you, APOS, for giving me the opportunity. Sir, can I start, sir? Yes, sir. So now I'll be presenting a comparative study of early, that is 6 weeks versus conventional, greater than 12 weeks silicone oil removal following rhegmatogenous retinal detachment. Next slide. So silicone oil was introduced by Sibis in 1960 as an intraocular tamponade prior to introduction of pars plana vitrectomy. The use of silicone oil in vitreoretinal surgery is not free of complications, few of which have been enlisted here, like silicone oil in anterior chamber, glaucoma formation, glaucoma, cataract formation, emulsification, and keratopathy. Next slide, please. Theoretically, chorioretinal adhesion would have formed certainly by 1 month. However, silicone oil is often retained longer than this. The rationale being that the presence of oil and the tamponade force might resist any traction caused by reproliferation. But actually, removal should be performed when silicone oil bubble has served its purpose, and when further retention may increase the risk of just complication than any redetachment rates. And there has been no defined timeline for appropriate silicone oil removal. Next slide, please. So the purpose of the present study aims to evaluate the safety and efficacy of early silicone oil removal at 4 to 6 weeks in patients undergoing vitrectomy for rhegmatogenous retinal detachments. Next slide, please. The study was a hospital-based prospective interventional study. The study was conducted in the Department of Vitreoretina, Shankarai Hospital, Guntur, over a period of 21 months from 1st January 2015 to 30th September 2016. The study included 50 eyes of 50 patients, which were divided into 2 groups based on duration of silicone oil removal. In first group, it was removed at 4 to 6 weeks. The other one went to 12 weeks. The inclusion criteria were primary rhegmatogenous retinal detachment up to grade C3 PVR. The exclusion were complicated retinal detachment cases. Next slide, please. So this was the procedure in which we removed the silicone oil. Next slide, please. 50 eyes of 50 patients were with RRD were operated. The mean age was 50 plus or minus 14. None of the subjects in the study groups had recurrent retinal detachment after removal of silicone oil. Next slide, please. So this is a table showing a comparison of percentage of individuals with raised IOP at different follow-up periods. I would like to point you to the last 3 months section, wherein the difference of the IOP from the group 1 to group 2 is only statistically significant in the 3 months period, but otherwise it is not statistically significant. This is the percentage of IOP raise. Coming to the next slide. The proportion of subjects with emulsification were not significant in both the groups. Next slide, please. Yeah, and no statistically significant differences were found in BCVA values between both the study groups. Next slide, please. So, silicone oil endotamponade combined with vitreoretinal surgery has become a standard technique that improves prognosis of complex retinal detachment. But the timing of SOR is still controversial and varies in reported series to as early as 6 weeks to as late as 22 months. In our prospective study, we did not find any difference in retinal redetachment between early SOR, that is at 6 weeks, to delayed removal, that is up to 12 weeks, over a period of 3 months post SOR. Next slide, please. In a prospective study by Jahangir et al. In 47 patients with intraocular silicone oil tamponade between 3 to 48 months, 14 eyes, that is 30%, developed recurrent retinal detachment, whereas 70% remained a retina attached in 6 months follow-up period after silicone oil removal. In our study, there were 0 redetachments, as we do not, which stresses upon the fact that in cases of uncomplicated regmatogenous retinal detachment, early SOR could be a viable option without the risk of redetachment. At 3 months post SOR, the proportion of subjects with raised IOP was 24% in group 1 as compared to 4% in group 2, which was statistically significant. But however, the rise in IOP in their respective group from the baseline when compared between the groups was not statistically significant. In a retrospective study by Falkner, with mean duration of silicone oil endotamponade of 13.3 months, 54 eyes out of 115 developed raised IOP after silicone oil injection. The proportion of subjects with emulsification were not significant in both the groups. No statistically significant differences were found in BCVA in both the groups. In our study, we did not observe corneal complication. So to stress upon this point, clinical examination plays a pivotal role to decide on early SOR. That is, when we see that the laser scars have taken up and the silicone oil and there is no evidence of PVR, one can proceed with silicone oil removal early, with a few exceptions such as one-eyed, wherein you have dense anterior hyaloid proliferation. If you remove oil early, the eyes can go into hypotony. So the main limitations of our study were it was a small sample size, a follow-up period after SOR was short. So why early SOR? Longer duration of silicone oil in the eye causes severe damage to the trabecular measure, resulting in permanent scarring, which may lead to prolonged IOPs even after SOR. So it has been postulated by Zillis that the improvement in visual acuity following SOR is due to a combination of factors. There is altered optics during SOI in the eye with improved refraction after SOR, and there is possible retinal toxicity along with optic nerve toxicity with improved function after SOR of the retinal function and optic nerve function. Next slide, please. To conclude, since early silicone oil removal, that is 4 to 6 weeks, did not affect the redetachment rate of the retina, silicone oil can be safely removed as early as 6 weeks in uncomplicated primary regmatogenous retinal detachments to prevent oil-related complications such as elevated IOP, emulsification of the oil in the angles. Thank you. Any questions?
You showed some studies where
yes, sir,
the detachment is a little bit more.
Yes, sir.
Your case study series has shown less.
Yes, sir. Sir, that
what
is,
must be the cause?
Yes, sir. We didn't take complicated cases, sir. We restricted the cases to fresh retinal detachments in which the PVR was not more than PVR grade C3. So other studies involved all cases. So what we wanted to do was, in SOR in uncomplicated retinal detachment surgeries, if we remove it early, is there any redetachment at 4 to 6 weeks? But if we prolong it to 12 weeks, is there any difference? If there is no difference, which we didn't find, then what is the point retaining it for so long? Because if once the retention happens, sir, sometimes we lose patients to follow up. When we tell 3 months, 4 months, we'll remove at that time, patients go back and they think everything is fine. They come back later at around 6 months to 12 months, wherein we see that it has been emulsified, the oil comes to AC. Sometimes we are seeing glaucomatous optic atrophy, and even IOPs rise after SOR also, sir. Because the long-term follow-up, we are missing such patients. So we wanted to highlight SOI is the most common indication in RRD, sir, which we routinely perform. So there's no point prolonging it in simple cases also for so long. So that was the idea of the study, sir.
You are sure that it won't get redetached?
Yes, sir, in simple cases. And again, one more point I would like to stress, sir, clinical examination at the time of SOR.
That's right.
If you find that the laser scars are very well taken up around the breaks.
That's important.
Yes, sir. That's why, sir, I highlighted that clinical examination at the time of SOR. While deciding an SOR, you should see that the breaks are very well secured with the laser. The laser scars have taken up. And one more important point is there is no PVR. If proliferative vitreoretinopathy has not developed at 4 to 6 weeks, it is very highly unlikely that it develops at 12 weeks, sir. So seeing that into point, we can go on with it.
Good, good. That means you are take care carefully.
Yes, sir.
Thank you.
Thank you, sir.
Any more questions from the audience?
Removal is same as for heavy silicone oil also.
Yes, ma'am. We are doing it like this only, ma'am. Remove heavy silicone oils also.
What about
But
the
heavy
macular-
silicone oils, ma'am, we are, because the indications are different. For heavy silicone oil, like we are doing it in redetachment surgeries, in cases where we need to remain it for a longer period. So in this study, we didn't include heavy silicone oils because these are cases where fresh cases we used low density silicone oils. Heavy silicone oils is basically for, as I told, redetachment one-eyed cases, wherein you have a lot of anterior hyaloid proliferation, wherein if you take off the silicone oil, there are chances of hypotony, phthisis. So those cases we use silicone oil, but the method of removal is the same, ma'am.
What about the macular thickness regarding to the duration, according to the duration of retention?
Ma'am, that variable we didn't, macular thickness was not the intention. This was basically, we were thinking that oil-induced complications, to lessen the oil-induced complications, we were wanting to, because always the convention was to take it at 3 months. But the point of 3 months doesn't hold good for every case. Thank you, sir.
Done. Thank you very much.
Next.
Good afternoon. I'm Dr. Sairani, pediatric ophthalmologist.
Sairani, is it? Please carry on.
Today, my topic is retrospective analysis of sixth nerve palsy and need of neuroimaging. Sixth nerve, abducens nerve arises. The nucleus was situated at the pons and the nerve enters. Nucleus nerve passes between, comes from the pons, pontomedullary junction to, it passes through the Dorellos canal, enters the cavernous sinus by piercing the dura, and enters the orbit through via superior orbital fissure and supplies the lateral rectus muscle. So any palsy along its pathway can produce limitation of the abduction, producing esotropia and sudden onset of diplopia. And lesion can be localized or non-localized. The isolated palsy can occur in diabetes, in multiple sclerosis and viral infections, and also bilateral nerve palsy can occur because of long intracranial course, producing stretching injury to the nerve, because of raised intracranial pressure, increased mass lesions in the brain, and also cellular and paracellular lesions and metastasis. Next slide. Next slide. No financial interest. It's a retrospective observational study of one or three cases, which was the cases were seen between the period of 2015 to 2021 in Shankaraya Hospital, Guntur. The males are 62 patients and females were 41 patients. The age group of 2 to 75 years, and the right eye was affected in 42 cases and left eye was affected in 58 cases. Bilateral is seen in 3 cases. In 3 means 2 cases were traumatic. The 1 case is benign intracranial hypertension, because bilateral sixth nerve palsy can occur usually because of stretching injury, because of raised ICT or any stretch of the nerves in the brain. The causes of sixth nerve palsy was analyzed. Vasculopathic, that is the patient may have either diabetes or hypertension or both. Idiopathic, where we cannot find any lesion in the neuroimaging. Traumatic, history of trauma will be there. Neoplastic, aneurysmal, the aneurysmal or vascular, because any vascular dilatation or cerebrovascular fistula are included in this. Benign intracranial hypertension, viral infections, Tolasa-Hunt syndrome, it's nothing but a non-specific inflammation of the orbit and up to the anterior cavernous sinus. Multiple sclerosis is nothing but a demyelinating diseases, mostly affecting in the younger age group. Stroke, it's a hemiplegia affecting the patient along with the sixth nerve palsy. These are all the etiological factors that we have found. Next slide. Our causes are distributed according to different ages. Between the age group of 51 to 75 years, 80%, that is 30 cases, Total of 47, 30 cases were idiopathic. Vasculopathic. Vasculopathic is most of the risk factors are seen. Vasculopathic cases usually we used to observe, but 20% of cases are other causes of sixth nerve palsies are there. So if you leave the patients for waiting for improvement, so you can miss the other causes of sixth nerve palsy. In between 19 to 15 years of age group, all varieties, all types of, all causes of sixth nerve palsies are seen. For our study, we got mostly idiopathic and vasculopathy. In younger age group, that is pediatric age group, also we got, but we got benign intracranial hypertension was the more cases were seen in pediatric age group, and also viral infections. Next slide, please. We have tabulated in our cases in a tabular form, etiology according to age distribution and follow-up. 54 cases was not followed. No follow-up was seen in 54 cases, but follow-up was present in 49, out of which 39 were improved in 1 month. Mostly, that also 90% of the cases were vasculopathic and idiopathic cases. No improvement was seen in neoplasm and aneurysmal cases, and BAH case also was improved very well. The other cases was not followed. Viral infections also improvement was seen, but follow-up was not there in this. Next slide, please. These are cases. This is a case of benign intracranial hypertension presented as sixth nerve palsy, and having bilateral papilledema in the fundus, and neuroimaging showing in idiopathic features of idiopathic intracranial hypertension. She was treated and she completely resolved. Next slide, please. Next. This is a case of patient came with sixth nerve palsy left side and also having mild pain in the left side of the face. On neuroimaging, she is having chondrosarcoma of the base of the skull extending into paracellular area, producing sixth nerve palsy. Next slide, please. This patient, old woman, came with sudden onset of sixth nerve palsy. On examination, nothing can be seen but except mild congestion in the right eye. Mostly mild dilated episcleral vessels. In doubt, we did neuroimaging. She has keratodermatous fistula because she is not at all having features of keratodermatous fistula, but you can diagnose if you do neuroimaging early in cases with sixth nerve palsy instead of waiting. We can in this case we can able to diagnose ECF by doing neuroimaging. Early diagnosis will be helpful in this type of cases to avoid any hemorrhages later. Next slide, please. Our study was comparable with SNAP studies done by Shankar Nethralaya, Chennai, which was published in IJO in 2014. Same 104 cases. We are also 103 cases. They are also retrospective analysis. They are also having vasculopathic is the main cause for sixth nerve palsy. Next slide, please. Next slide. Other studies, same, these are all Western studies, but the etiology was different in different studies. Patel study 137 cases. He got the causes of undetermined 26, hypertension alone 19 patients, and multiple sclerosis 7, because multiple sclerosis is so common in Western, not in our country. So he got more number of percentage. Jung EH and Kim SJ et al. Studied 486 cases. He got only vascular 56.6, idiopathic 27.2, and trauma at 4.9. So different studies showing different percentages of etiology. Next slide. Next. In conclusion, sixth nerve palsy is not uncommon in neuro-ophthalmic practice, affecting males, predominantly left eyes. Common etiology is vasculopathic in middle age. Improvement is seen in idiopathic, vasculopathic, benign intracranial hypertension, and inflammatory causes. Proper history and clinical evaluation can give a clue to advise early and specific neuroimaging instead of observing in elderly with risk factors and in poor follow-up cases.
Okay, it's a good study. It is a good study. Since you are saying it is a retrospective study,
yes, sir.
What is the minimum interval you have taken between the onset of the symptoms or the diagnosis and your imaging? And what is the longest duration?
Sir, most of the patients will come early, sir. They will come immediately to us. Immediately we will advise, because
immediately means see,
all
since you are
elderly
saying,
patients with vascular.
you are saying retrospective. Retrospective means how early? I want, and what is the longer duration. So these two groups I want.
Longer duration means one patient have 4 years history of surgery done also, sir, because tumors already they are having surgery with 6-node palsy, sir.
Okay, by the time once they operate on the tumor, then definitely there should have been some
No
improvement.
improvement, sir.
But by the time they will want to do surgery for the tumor, they might have done neuroimaging, you know. At that time itself, the diagnosis was
Already diagnosed, sir. Already diagnosed tumors.
Okay, but that is what I'm wanting. I mean, what I want is that, see, what is the earliest interval? Because it is a retrospective study. And what is the, the longer period of waiting for any
Early
such
interval
cases?
means if you suspect, you will do immediately, sir. If the patient is having vasculopathic factors, elderly patients, we will wait for 1 month, sir. Later, I will advise neuroimaging. If there is no improvement or any other features are there. If any other features are there, I will ask them to get a neuroimaging immediately. In this case, like CCF case, no, sir. I thought something is wrong in the brain because of some episcleral vessel congestion was there. So I asked her to get it to neuroimaging. She got it, sir. And in doubt only, I am advising early. Otherwise, I will advise after, I will observe for 15 days minimum. Then I will advise neuroimaging. For our practice, some of the patients are coming from the neurologist, sir. Already they will have neuroimaging, all treatment also sometimes, sir.
In case of benign intracranial hypertension, what was the treatment the patient received and what were the neuroimaging signs?
Neuroimaging usually normal, sir. Sometimes there is, you can see in this neuroimaging, you can see the retro of an optic nerve enlargement, sir.
The signs of papilledema will be there, but within the brain there will be narrowing of the ventricles, etc.
Yes, sir.
And
It's a late feature, sir. Early you cannot see anything in the brain, sir.
Age group what I have shown is seems to be little younger.
Younger is 4 years, sir. It was not diagnosed by me, sir. It was diagnosed by neurologist, sir.
But usual onset is between second and third decade, mostly in the females. I mean fatty and the people who are using oral contraceptives, etc.
Yes.
But the statistics what you have shown is different.
Yes,
and what was the treatment she was given? I mean the patients were given with regard to the benign intracranial hypertension.
There they have given a Dimax, sir, acetazolamide, and some patients also got furosemide also, sir.
Any neurological interventions were done?
Sir?
Neurological interventions. That means there can be what is called as optic nerve fenestrations, etc.
No, sir. No, sir.
Okay.
Thank you, sir.
Thank you. Maternal diabetes has an independent risk factor for retinopathy of prematurity in infants with the birth weight of okay. Sorry? Hello? I mean the name of the doctor here written as Uppaluru, maybe surname. Gautami. The study is maternal diabetes as an independent risk factor for retinopathy of prematurity in infants with a birth weight of 1500 grams or more. Doctor, are you ready? In that case, we'll go to the next paper. Sanjana, is she ready? Correlating LPS plus SR complex changes with the upper lid retraction on imaging in
Hello everyone, I'm
TED
Sanjana
patients.
from LV Prasad Eye Institute, Vijayawada. Today I'll be discussing on correlating LPS-SR complex changes with upper lid retraction on imaging in TED patients. Here are the following abbreviations I'll be using in my presentation. They are LPS for levator palpebrae superioris, SR for superior rectus, TED for thyroid eye disease, and UL for upper lid. As we all know, the normal position of the upper lid rests at the level of 2 mm below the upper limbus. The upper lid retraction can be classified as mild when there is no superior scleral show, moderate when there is less than 2 mm of scleral show, and severe when there is more than 2 mm of scleral show. There can be various causes of upper lid retraction such as neurogenic, myogenic, and mechanical. While the upper lid retraction causes in TED can be due to increased serum catecholamines, increased molars muscle tone, SR-LPS overaction from the tight ipsilateral inferior rectus, or anterior lamellar, molars muscle, or LPS inflammation. A study by Davis M.J. et al. On levator muscle enlargement in TED-related upper lid retraction. Here, the observers were blinded from the clinical photograph and were supposed to identify the retracted muscle on the imaging. In this clinical photo, we see there is right eye upper lid retraction, and on imaging, we see the LPS-SR complex area of the right eye to be more than the left eye. Thus, this study concludes that the upper eyelid retraction can be predicted from the CT scan appearance in over 85% of cases. This brings to our study correlating LPS-SR complex changes with upper lid retraction on imaging in TED patients. It is a retrospective observational study conducted at our Kode Venkatadri Chowdhury campus, LV Prasad Eye Institute. A total of 28 eyes, that is 14 patients, were recruited, and a general data on vision, color vision, ocular examination, inflammatory signs and scoring, grade of upper lid retraction at the first visit were noted. The patients underwent imaging at the first visit, and a CT scans of posterior mid-coronal cuts were assessed in images software where the LPS-SR complex changes were noted. The vertical dimensions was considered as LPS-SR complex thickness, and the horizontal dimension was considered as width. A total of 16 eyes were women and 12 men, and a mean age of 44 years. 64.2% were hyperthyroid, 21.4% euthyroid, and 16.6% hypothyroid. Most of the patients complained of proptosis, while watering and redness was seen in 4 eyes, and loss of vision in 6 eyes, and diplopia in 1 eye. Most of the patients had best corrected visual acuity of 20/20, except in 1 eye due to corneal exposure keratopathy and 4 eyes due to compressive optic neuropathy. On ocular examination, periorbital edema and chemosis was seen in 16.6%, while exposure keratopathy and extraocular motility restriction seen in 21.4%. 2 patients were with significant cast scoring, and 5 patients were active timeline-wise. Upper lid retraction, grade 1 was seen in 9 eyes, grade 2 in 11 eyes, and grade 3 in 8 eyes. And in other extraocular enlargement, inferior rectus was found to be enlarged of 39.2%, and medial rectus 14.2%, and lateral rectus 7.1%. Coming to the results, grade 1 of upper lid retraction, the thickness was found to be 4.4 and width 10.5. In grade 2, thickness 5.5 and width 10.5. And in grade 3, thickness was 8.8 and width 13.2. The normal LPS-SR thickness is 3.3, while the width is 7.78. As we see here in our study, the TED patients LPS-SR complex, the thickness and the width is more as compared to the normal LPS-SR complex thickness and width. And also with grade, as the grade increases, the thickness and the width also increases. Thus concluding that TED patients with upper lid retraction have enlargement of LPS-SR complex and the grade of upper lid retraction correlates with the LPS enlargement. Our limitations are that it is a small sample size and different activity levels were seen in patients. That is, 2 patients had significant CAS score and 5 patients were active timeline wise. And there was presence of enlargement of other extraocular muscles as well. Discussion, upper lid retraction in TED can be due to many causes. In our study, the lid retraction correlated with the LPS-SR complex enlargement. Inferior rectus muscle being the most common muscle to enlarge. LPS-SR complex enlargement was seen to correlate with the activity level. That is, 2 patients with significant CAS score had enlargement of all the muscle. Thank you.
So, doctor, you are answering the question?
Yes, sir.
So, which muscle is early to enlarge?
Inferior rectus.
Then in that case, why you are more bothered about the LPS and superior rectus? And among the two, which one is earliest to enlarge again? Is it the superior rectus or LPS?
Superior rectus, after that is LPS.
Then what is the purpose in taking this LPS and SR complex into consideration to know about the thyroid eye disease by doing CT scan?
Okay, because we can't differentiate between the LPS and SR clearly in the CT imaging. So that's why I have taken the complex as a whole.
Okay, that may be true, but you can take at the, if you take at the, midsection levels, you can know about the enlargement of the LPS separately from that of the SR. And before that, the inferior rectus itself is enlarging, other than that. And since you are getting a good information, inference, with the CT scan, what is the need of taking this LPS and SR into consideration?
Because because I want to correlate upper lid retraction, that's why, which is related to LPS-SR complex.
Okay, anyhow, there can be, what is the other reason for the retraction of the upper eyelid in a patient?
It can be due to Miller's muscle overaction also, but the retraction due to Miller's will be very less as compared with LPS.
But how do you know that the lid retraction is due to Miller's or is it due to only LPS and SR?
By correlating like how much amount of retraction, because Muller's will be less as compared to LPS. And sympathetic overactivity also we can
that also you should verify. In patient thyroid, the sympathetic activity will be more.
Yeah, so hyperthyroid patients were more like compared to the euthyroid, and in our study, hyperthyroid patients were more.
Thank you.
Okay.
Any questions? Dr. Arvind, you're welcome.
Shall I start? Okay. Good afternoon once again to all. Our study for Professor V. Raghavachari session is the spectrum of keratitis during post-COVID convalescence. We do not have any disclosures or conflicts of interest. The COVID virus typically enters the cell through 2 receptors. Number 1 is the ACE2 and the second one is the TMPRSS2. This leads to internalization of the virus followed by replication into the cell. So what is long COVID? What is the sequelae in post-COVID? Normally, the viremia peaks in the first 1 to 2 weeks, after which the viremia decreases. But as emerging studies and our understanding on COVID is evolving, the post-COVID sequelae tend to occur after 4 weeks, 3 to 4 weeks, and they involve multiple organ systems. The commonest of which is the whole body malaise or fatigue, followed by involvement of the lungs, brain, heart, and the arteries and kidney. So all of this comprise the long COVID syndrome. However, we haven't seen, or at least published literature is not showing a lot of documented evidence of what is happening to the eyes as post-COVID sequelae, and whether there is any actual causal association or it is just a temporal association that we are seeing as ophthalmologists. And this was the purpose of reporting what could be the clinical and demographic profile of keratitis in patients who present within 3 months of acute COVID-19 infection. We studied 18 eyes of 16 patients with microbial keratitis during COVID convalescence. All of them were diagnosed COVID or were in contact with COVID patients, and they were bilateral in 2 patients where there was bilateral microbial keratitis and unilateral in 14 eyes. And the presentation was between the first to 93 days post-COVID. The study had institutional approval, and when we studied the underlying risk factors for these patients, we found that in 4 and 5 patients there were diabetes and hypertension, and 9 patients were hospitalized, of which oxygen administration and systemic steroids were given in 5 and 3. Some patients had multiple risk factors, which is why the total actually will add up to more than 18. Now, this is a slide which is of considerable importance when we are trying to understand the pathology of keratitis and whether it is the same as that in any normal patient or whether COVID has any predisposition to keratitis. So during the discussion, madam, as I was discussing with you regarding whether there is any change in the keratitis that we are seeing, and we are discussing that question. This was a study which is recently published in British Journal, where a confocal based analysis of the corneal nerves showed that there is a dropout in the nerve branching, nerve endings, and the nerve density of the cornea, and there is an increase in the dendritic cells. So perhaps the COVID infection causes a change in the corneal sensations, which is why these corneas are more predisposed to some particular type of infection, or even if we get corneal ulcers, these ulcers tend to behave in a different way than in the normal human eye. And in our study also, corneal sensations were reduced in 10 out of 18 eyes. So when we studied the microbes that were causing the underlying cause of keratitis, fungus was the predominant organism, and so also was Microsporidia, followed by herpes zoster and pythium. Now fungus in a hot tropical climate is expected, but Microsporidia was something which was interesting, and we will also revisit a little bit of clinical details of those patients later on in the presentation. The patients resolved with 1 to 6 weeks of therapy. Medical management alone helped cure in 9 eyes, and therapeutic keratoplasty and TABCL was required in the remaining patients. So with this we come to the case scenarios where one was a 14-year-old female who had close contact with COVID in the same family 1 month back. She presented with irritation and blurring of vision in the right eye. The left eye was showing mild redness. So when we performed the fluorescein staining, we found that there are typical punctate dot-like opacities. This was very typical of Microsporidia. We did a scraping and the KOH wet mount showed that there were Microsporidia spores. We also sent the sample for PCR analysis and for adenovirus, because that can also have a very similar picture, but the PCR for adenovirus was negative. And this patient interestingly also had an anterior segment reaction, which led to a abnormal specular imaging. So these are pseudogatata on the specular imaging, but they are only transient and they were all resolved after 1 week of treatment. So the topical medications of lubricants and low potency fluoromethalone was administered 4 times a day. And when we reviewed the patient again after 2 weeks, they had completely recovered. But what was unusual about this microsporidia keratoconjunctivitis is that it also had concomitant anterior chamber reaction, which is not seen in microsporidia keratoconjunctivitis. So this was one of the unusual features in the post-COVID convalescence that we noted. The second one is the case of a microsporidia stromal keratitis. This was a 69-year-old patient from Nashik. He was denying all history of COVID, but he belonged to a very COVID hotspot area, and he had treatment done elsewhere for multiple multiple medications. So nobody was able to diagnose what his condition was. He was for 3 to 9 months. He was treated with antiviral, antibiotic, antifungal, and everything. So this was the presentation in the right eye, where there was a large epithelial defect and a mid-stromal opacity. And in the other eye, there were focal deep stromal corneal infiltrates. These are very, very suspicious, and considering the duration of the patient's history, was suspicious of microsporidia stromal keratitis with uveitis. A confocal imaging showed hyperreflective dots along the keratocytes, and a corneal biopsy was performed, which showed that the corneal stromal lamellae were opened up, and there were again microsporidia spores within the corneal lamella. So with this, there was a definitive diagnosis of microsporidia stromal keratitis. And he also, when we revisited his history, he also had a history of use of a herbal medication. He had dip in a river water, and there are COVID-like symptoms 2 to 4 weeks earlier to the ocular symptoms. So all this suggested that perhaps this atypical history was in some way connected to the COVID exposure that he had had, in addition to the other risk factors of the use of the herbal medications and also the exposure to contaminated river water. Therapeutic penetrating keratoplasty was required and was done first in the right eye and then in the left eye, which led to resolution of this condition. When we studied the histopathology of the corneal buttons, we found that again there were microsporidia spores in the deep corneal stroma. This was the post. There was again some amount of recurrence which occurred in 2 months after the therapeutic PK, and the patient was started on fumagillin topical and systemic preparations. This was another case of a herpes zoster ophthalmicus. So this was a 71-year-old male who had RT-PCR positive 3 weeks before ocular symptoms. The initial presenting pictures, clinical pictures, are unavailable, but there was severe excoriation of the lid margins. And when we started the treatment on herpes zoster, on prevalence of herpes zoster, this was a ophthalmic herpes, ophthalmic zoster sign herpes, meaning that there are no skin lesions, only there were ocular lesions. And we noted that there are pseudodendritic lesions on the cornea, for which antivirals and lubricants were given, and neuroleptic medications were given for pain relief. So this is the picture when the lid lesions resolved. The excoriations have now resolved well, and the corneal scarring is also there with re-epithelialization of the ocular surface. Fungal keratitis was the common scenario, and we saw several different types of fungal keratitis. This one was something I would say unusual and atypical, because this was just a plaque seen in a young patient. What is different about this patient from routine cases of fungal is that there was no history of any trauma, and the patient was also not very symptomatic. And when we scraped it off, this entire plaque came off as one single mass, which had plenty of fungal filaments, and the patient rapidly resolved. Again, if we look at this location of the lesion, this was in the interpalpebral area, where there is a chance of an exposure keratopathy. So this was different about the fungal keratitis. and the patient responded rapidly to treatment. But this is one end of the spectrum. The other is the 56-year-old male patient who again had COVID positivity in April and then was hospitalized elsewhere. And then he was diagnosed to have bilateral microbial keratitis and was diagnosed elsewhere as a herpetic keratitis. And he was placed on antibiotics and TA was applied for a perforation in the left eye. And we noted that if we can see both the lesions, they were again on the inferior portion of the cornea. There were areas of infiltrate which are in the mid to deep stroma, lot of vascularization, convex hypopyon and irregular margins. And the other eye already had TA application. So we repeat scraping yielded fungal filaments and there was significant growth of Aspergillus niger in the culture plates. So the patient was treated with natamycin and over a very slow and chronic course of 4 months, the patient healed and ultimately tarsorrhaphy and amniotic membrane transplant was done because there was a persistent PED. So this was another spectrum of fungal keratitis. This was a patient who was an agricultural worker and was on home quarantine. He was not hospitalized. But if we look at the lesion, there were tentacle dot-like infiltrates in this patient. This was suggestive of pythium. And when we did the scraping, we found that there were flat ribbon-like folds. This patient was given antipythium medications and it was healed. Again, all the lesions were in the interpalpebral area, all the lesions were on the inferior portion of the cornea. Corneal sensations were decreased. So causal association cannot be ascertained, but temporal association is certainly noteworthy. The subnormal corneal sensations are very common and COVID infection can often lead to altered host immune responses. And these may be responsible for the varied manifestations of keratitis that we see in the post-COVID convalescence. Thank you so much for your patient hearing and we wish you a good day ahead.
Very nice.
Thank you, sir.
Any questions from audience?
Is there any increase in virulence of the organism post-COVID convalescence?
So there are some patients who are younger patients. Those patients recovered well, but there are some who had been hospitalized or they had severe COVID requiring oxygenation, use of systemic steroids. In those patients, the clinical course is poor and they do not recover well and they may need surgery as well. So in the clinical series that we saw, like the 79-year-old, 69-year-old patient with bilateral stromal keratitis, there we required bilateral corneal transplants because of a corneal infection that lasted for 9 months post-infection. Whereas in the younger patients in the microsporidia keratoconjunctivitis or the younger patient with fungal keratitis, they resolved with only 2 weeks of treatment. And they were also in home quarantine. They were not in hospital. So perhaps the severity of the COVID affects the immune response, causing the different clinical picture that we see in these patients.
There is any change in spectrum of microbial keratitis?
Yes, what was unusual here was that we saw many patients of microsporidia with a history of COVID convalescence. Fungus is normal in our, we expect fungus in a hot tropical country, but microsporidia was unusual in this series. So microsporidia are ubiquitous organisms. So they are available, these organisms are available in soil, water, air, everywhere they are there. So there are no particular predisposing factors, but sometimes the loss in the immune or temporary decrease in the immunity of the body may predispose the host to have a microsporidia infection.
Okay, well, nice presentation. Thank you all the participants.
Thank you, sir.
And thank you all the audience offline and online. Thank you all. Yeah, welcome, ma'am.
Hello, Dr. Uppalur Gautami, are you available?
Yes, sir.
What is your topic?
Maternal diabetes as an
Hello?
independent risk factor. Sir, can you hear me, sir?
Sir. Yes,
Sir,
you
can
are
you hear
audible.
me?
Yes,
Sir,
you
maternal
are audible
diabetes
and
as
you are
an
seeing.
independent risk factor for ROP, sir.
Okay, you are going to present now?
Yes, sir.
What about slides? Slides, please. Slides, please.
Yes, sir.
Please start, ma'am.
Yes, doctor.
Sir.
Hello, doctor. Your audio is not audible. We are not getting audio. Hello.
Sir, just a minute, sir.
Hello.
Can you hear me, sir?
Hello.
Sir, can you hear me, sir?
Hello.
Sir, can you hear me, sir?
Yes. We're unable to hear you, doctor.
Madam, is it audible for you?
Please.
Yes, sir.
Now we can see your slides, but please check your audio from your side. Now,
Yes, sir.
okay, you start presenting.
We're audible to you?
Please share screen and select optimize. There is one option is there. Optimize in the bottom. Hello? Not here now, ma'am. In the share screen only. When you share the screen, no, there only. Please stop your screen.
Yes, doctor. Present your slides as well as start presenting. We are unable to hear you still.
Introduction. Retinopathy of prematurity is the source of substantial morbidity for premature babies all over the world. ROP and diabetic retinopathy are both retinal vascular diseases in which there is leakage and/or neovascularization from damaged retinal vessels on the basis of retinal ischemia. Infants born to diabetic mothers are the babies who are exposed to hyperglycemia in intrauterine life, and despite being larger babies, they may still be significantly premature, requiring oxygen therapy. Based on this information, it was hypothesized that ROP would be more common in infants born to diabetic mothers, and we aimed to investigate the between maternal diabetes and the development of ROP in infants of birth weight more than 1500 grams. Materials and methods. My aim is to investigate the relationship between maternal diabetes and development of ROP in infants with birth weight of more than 1500 grams. Duration of study is from December 2020 to October 2021. Sample size taken is 90 babies, of which 30 were the premature infants from diabetic mothers who were compared with the data of 60 controls. The babies who were referred for ROP examination by their attending neonatologist or pediatricians were included in this study. All the babies in the case and control groups were followed according to the same criteria. The criteria for ROP screening for the babies over 1500 grams birth weight was sepsis and/or requirement of cardiorespiratory support. Infants from diabetic mothers were defined as a case group. Neonates with congenital or chromosomal anomalies or major ocular abnormalities in one or both eyes and those who died or were lost to follow-up were excluded.
Examination performed using an eyelid speculum, scleral depressor, binocular indirect ophthalmoscope, and 20 diopter lens after pupillary dilatation. The results on comparison of gestational age, birth weight, rate of retinopathy of prematurity, and rate of type 1 retinopathy of prematurity between case and control group shows the birth weight, the rate of ROP, and type 1 ROP were found to be significantly higher in the case group. This table shows the clinically significant characteristics of ROP are maternal diabetes, sepsis, and mechanical ventilation. This table shows the significant clinical characteristics for type 1 ROP were maternal diabetes, sepsis, and mechanical ventilation. Coming to the discussion, according to the published ROP screening guidelines, it is recommended that all the premature infants of birth weight less than 1500 grams are to be screened. But these guidelines are not so clear for the babies whose birth weight is more than 1500 grams. ROP screening is advised for infants who are supposed to be at high risk for ROP. ROP and diabetic retinopathy are both retinal vascular diseases in which there is leakage and/or neovascularization from the damaged retinal vessels on the basis of retinal ischemia. In intrauterine life, the human fetus is nearly completely dependent on the maternal glucose passing through the placenta by facilitated diffusion. The negatory outcomes on the fetus and the mother increases linearly with the increasing maternal plasma glucose. Maternal hyperglycemia can give rise to fetal hyperglycemia and causes macrosomia, prematurity, and respiratory distress syndrome. In recent years, the studies on pathophysiology of ROP has been focused on the vascular endothelial growth factor, and it was reported that hyperglycemia increases VEGF production in retinal Muller cells in hypoxic culture conditions. So infants born to diabetic mothers are the babies who are exposed to hyperglycemia in the intrauterine life, and despite being larger babies, they may be still significant premature infants who require oxygen therapy. On conclusion, the presence of maternal diabetes is significantly associated with the development of ROP and type 1 ROP in the premature infants with a birth weight of more than 1500 grams. With a multiple logistic regression analysis, it is found that besides maternal diabetes, sepsis, and mechanical ventilation were significant risk factor for ROP and type 1 ROP. Limitations. This is a single center study. There is selection bias since not all the babies over 1500 grams were screened, but only the infants referred for ROP examination were included in this study. There might be a referral bias because there is a high probability that more sick babies are included in this study. These are my references. Thank you.
Hello. This is a good study, but this is the first time that we are hearing about this occurrence of ROP. That is usually we know that it in premature less weight, baby weight being less than 1500 will have ROP. Are there any studies of similar kind were conducted anywhere else, either within in our India or abroad?
Yes, sir. There were about 3 to 4 studies.
Have you verified the literature about for the incidents of the same case studies and results?
Yes, sir.
Yes? Yes or no?
Yes, sir.
Sorry?
Similar kind of results were shown in that study, sir.
Similar results?
Similar kind of results were shown in that study also, sir.
Where the study was conducted?
Eastern India.
You should have quoted that study. The name of the study and where it was conducted, what were their sample size, what were their results, etc. Then only you can say, or you can tell orally also. You should have quoted that example.
Okay.
Okay, doctor.
Thank you for participants for attending for Professor Vengal Rao best paper session, Dr. Raghavan. Thank you, one and all.
So I thank all our judges along with the team of audio visual team for this free paper session. Thank you one and all. Thank you.
మొత్తం ప్రైవేట్ ఫోల్డర్ అంతా కాపీ చేయాలా? ప్రైవేట్ ఫోల్డర్ క్లోజ్ చేయాలా? ఏందన్నా అది మీటింగ్ ఓపెన్ ఉండాలి. నా నీకు ఫోన్ చేయాలా? ఫోన్ చేయాలా? చేసి నీకు ఫోన్ చేసి నాకు ఫోన్ చేస్తే అక్కడ పోతాను దాని గురించి. ఫోన్ చేసినట్టు పోవాలా నేను? అక్కడ పోతా. ఏమైనా ఉంది కదా నేను అక్కడ 44 GB అంట. ఇది 1 hour ఆఫ్టర్ కదా ఇప్పుడే పోతా.
Would you like to start, Amma? Samira, would you like to start? Would you like to start? You only. We are here to listen to you. Judges are here. Huh?
Very good afternoon to all of you.
Just a minute, Dr. Samira. Just let me. So, how many presenters are there here? You are the only one, or what's your name, ma'am? Sravya. And any other presenter?
And there's Dr. Anamika.
So, you are going to present anti-segment paper or posterior segment?
Posterior segment, sir.
Posterior segment. I think better we have to start. So, on behalf of the APOS Scientific Committee, we all welcome you for the presenting, competitive paper. I hope it is competitive papers, posterior segment. So, we will start with Dr. Samira's presentation.
Go ahead.
Good afternoon. Systemic bacterial infection in hospitalized COVID-19 patients has been reported to be 7%, and this incidence increased to 14% in presence of ICU admission. Systemic fungal co-infection in hospitalized COVID-19 patients are also not uncommon. There are anecdotal reports on presumed intraocular infections such as endophthalmitis in hospitalized COVID patients. With this background, we did a study titled Sight-Threatening Intraocular Infection in COVID-19 Patients in India. The purpose was to describe the epidemiology and microbiological profile of intraocular infection in COVID-19 patients after their release from the hospital. It was a retrospective chart review of prospectively collected COVID-19 patients' data from April 2020 to January 2021 at L.V. Prasad Eye Institute, Hyderabad and Vijayawada. All laboratory confirmed SARS-CoV-2 infection and had reported to us for endophthalmitis management within 12 weeks of discharge from the hospital were included in this study. The data included age, gender, associated comorbidities, time to onset of COVID-19 symptoms, time to onset of ocular symptoms, history of admission to hospital, ICU, systemic comorbidities, detail of COVID care, blood biochemistry, including the inflammatory markers, the occurrence of sepsis, ventilator use, culture report of blood, urine, tissue biopsy, and oxygen therapy. A comprehensive eye examination was done for all the patients at presentation. Endogenous endophthalmitis management was done as per institute protocol. Undiluted vitreous biopsy was taken and it was subjected to gram stain as well as calcophore white mount. The vitreous biopsy was inoculated in different solid agar media, also into the different liquid media. The species identification was done using Vitek2 compact system. PCR for eubacteria, fan fungus, herpes virus type 1 and 2 were done whenever possible. Vitreous sample was also subjected to PCR for SARS-CoV-2 detection whenever possible. We included
Excuse me,
33
Dr.
eyes
Samira.
of 24 consecutive subjects.
Dr. Samira, 1 minute. You will be given only 6 minutes and you have to complete your paper and 1 minute for discussion. Because totally we are having only 19 minutes for 15 candidates.
We included 33 eyes of 24 consecutive subjects in this series. Cases of endogenous endophthalmitis coincided with the peak of COVID-19 in both the states, Andhra Pradesh and Telangana. All had a history of hospitalization, 16 had history of ICU admission, 2 had used ventilator during their COVID care. Mean interval of COVID-19 systemic symptoms to ophthalmic symptom was 15 days, ranging from 6 to 72 days. Mean age at presentation was 53.6 years. There were 17 males, 90% had systemic comorbidities, 9 had bilateral affection. Majority had anemia, thrombocytopenia, lymphopenia, and neutropenia with raised inflammatory biomarkers like C-reactive protein, IL-6, LDH, D-dimer, and serum ferritin. All had received broad-spectrum intraocular antibiotic.
Okay.
Which slide I will start?
You continue, Dr. Samira. Where you have stopped, there from you continue.
Okay, from this slide. From this slide. Majority had anemia, thrombocytopenia, lymphopenia, and neutropenia with raised inflammatory biomarkers like C-reactive protein, IL-6, LDH, D-dimer, and serum ferritin. All had received broad spectrum antibiotic. 21 out of 24 patients had received systemic corticosteroids in the form of intravenous methylprednisolone with or without oral corticosteroid. We included 32 eyes of endophthalmitis and 1 eye of panophthalmitis in this series. The ocular manifestations included preretinal and vitreous exudate to complete vitreous abscess with involvement of ocular cords and orbit. Mean presenting visual acuity was 0.0415. All had presented with pain, redness, blurring of vision at presentation. In vitreous biopsy, 11 had fungi, 2 had bacteria, and 1 had virus. 11 out of 21 subjects had systemic focus of infection, which included 5 candidemia, 3 bacteremia, 1 aspergillus species, and 1 had mucormycosis. At a median follow-up of 90 days, 5 patients deceased due to COVID-19 related complications and 19 patients recovered from the COVID. 22 eyes after receiving primary vitrectomy vitreous biopsy with systemic and intravitreal antibiotic. There is 6 eyes received silicone oil injection and 13 eyes received multiple culture adjusted intravitreal antibiotic or antifungal as additional treatment. At the end of last follow-up day, 13 eyes of 11 patients had severe visual impairment and 9 eyes of 8 patients had functionally improved vision. This is a 58-year gentleman with right eye involvement. You can see preretinal exudate here. The direct vitreous microscopy revealed thin filamentous fungi, the blood agar and chocolate agar showing growth, and the species was identified to be Candida tropicalis. This is another gentleman, 59-year-old with right eye involvement, the vitreous showing exudative retina detachment, vitreous exudate, and thickening of the ocular coat. Direct microscopy of vitreous biopsy revealed septate fungal filaments in gram staining as well as in chalcophore white mount and STS showing growth, and the species was identified to be Fusarium equisetae. Another gentleman, 65-year with bilateral involvement, vitreous is showing vitreous abscess. Direct microscopy of the vitreous sample revealed septate filamentous fungi in Gomori methylamine silver staining as well as in Giemsa staining, and PDA showed growth, and the species was identified to be Aspergillus flavus. The limitation of this study was tertiary care referral nature of our practice could have skewed some of the clinical presentation, and lack of denominator of total hospitalized COVID patients and their systemic comorbidities and interventions limit the conclusion drawn in our study. So, endophthalmitis is a rare but not uncommon occurrence in patients even after hospitalized care for COVID-19. This is associated with high mortality and blindness. Ocular infection is coincided with associated comorbidities, hospitalization, ICU admission, systemic therapy with broad-spectrum antibiotic, corticosteroid, IL-6 inhibitor, raised inflammatory markers, indwelling catheter. Candida species are the most common infecting organism. So we recommend the inclusion of a routine eye examination and estimation of vision as a part of standard of care for hospitalized patients with COVID-19. Thank you.
So it was a nice presentation, Dr. Samira. And because of lack of time, we'll go to the other presentations. And if anybody wants to ask questions, maybe for 1 minute we will allow regarding this presentation. Otherwise, we'll go with the next presenter. Dr. Ranjit, you want to present? Okay, please. Dr. Shavya, please.
May I start, sir?
So your paper is the anterior segment or posterior segment?
Posterior segment.
Yes. Please go ahead. Only 6 minutes presentation. Please stick on to your time.
Yes.
There are around 15 presenters here.
Yes, sir. Good afternoon. Title of my topic is Looking Beyond the Usual Suspects, OCT to the Rescue. There's no financial disclosure. Introduction. CSCR is a disease characterized by localized neurosensory detachment with or without pigment epithelial detachments and altered retinal pigment epithelium. Many clinical conditions, including inflammatory diseases like VKH, posterior scleritis, posterior uveitis, white dot syndromes can mimic CSCR in presentation. It is essential to differentiate between these conditions as the treatment differs. Multimodal imaging, OCT, B-scan, fundus fluorescent angiography, and IGCA can help in differentiating CSCR from other inflammatory diseases. There are 2 such cases which were misdiagnosed. This is the case 1. A 53-year-old male patient came to the OPD with complaint of blurring of vision in the right eye since 1 week. His best corrected visual acuity in right eye was 6.9 and his near vision was N8. Left eye 6.6 and near vision was N6. On examination, his anterior segment was within normal limits. Posterior segment showed neurosensory detachment. Posterior segment. Anterior segment was within normal limits. Posterior segment showed neurosensory detachment in the posterior pole. OCT was done. OCT showed subretinal fluid along with the choroidal elevation. He was diagnosed with CSCR and was started on dorzolamide and nepafenac eye drops 3 times per day. After 3 weeks review, he came with the presentation of redness and pain along with the blurring of vision. His right eye visual acuity was 6.9 and near vision was N8. On examination, his anterior segment showed conjunctival congestion. Posterior segment showed hard exudates with neurosensory detachment in the posterior pole. OCT was done. OCT showed subretinal fluid along with hyperreflective dots in the inner retinal layer. His convex elevation, which was present in the previous OCT, reverted to normal. These findings, we diagnosed him with posterior scleritis, which we missed on the first visit. Because of the busy OPD, we couldn't see the elevation. We couldn't recognize the elevation there of the choroid. So we diagnosed him with CSCR.
We started him with endomethacin 75 milligrams BD for 5 days. And then we asked him to come after 1 week for fundus fluorescent angiography and to start him on oral steroids. After 1 week, he has come to the OPD. He was symptomatically better. His visual acuity improved to 6/6 and his near vision was N6. On examination of posterior segment, there was no neurosensory detachment with only hard exudates there. OCT showed minimal amount of subretinal fluid. This was a case of posterior scleritis, which we misdiagnosed as CSCR, as pain was not the presenting symptom. Case 2, a 31-year-old female, known diabetic and hypertensive, came to the OPD with blurring of the vision and eye pain since 2 days. Her best corrected visual acuity was 6/18 and her near vision was N10. Left eye 6/6 and near vision was N6. On anterior segment examination, it was normal. Posterior segment showed neurosensory detachment with ILM folds, which are seen. OCT showed ILM folds, RPE undulations, and subretinal fluid. With these OCT findings, we diagnosed her as posterior scleritis because she was having pain, and we started her on indomethacin 75 milligrams BD, and she was asked to get routine blood investigations done. After 1 week, she came to the OPD with left eye blurring of the vision. Her routine blood investigation showed elevated ESR. Her best corrected visual acuity was 6/60 in both eyes. Anterior segment was within normal limits. Posterior segment showed neurosensory detachment with ILM folds and subretinal yellow dots. OCT was done. On OCT, we could see multiple neurosensory detachments with subretinal septae, RPE folds, and hyperreflective dots in the choroid. With these findings, we diagnosed her as VKH and started treating her on steroids. After 3 weeks review, she came for the follow-up. There were only ILM folds with significant reduction of subretinal fluid. There was no neurosensory detachment clinically. So all these 3 presentations occur almost in the same group. All these 3 things occurs in the same age group. They can present only with the neurosensory detachment without any other presenting feature. OCT can help us in differentiating between these 3 conditions. When pigment epithelial detachment, subretinal hyperreflective dots, double layer sign, elongated photoreceptors, and increase in the subfoveal choroidal thickness, we can suspect it as CSCR. OCT features of posterior scleritis are ILM folds, RPE undulations, choroidal elevation, and increase in choroidal thickness. VKH findings are subretinal septae, folds in the RPE, and ILM folds. Conclusion, take-home message, CSCR and inflammatory conditions with NSD can have similar presentations and can be easily misdiagnosed in the OPD. Proper history taking, looking for the signs of active and healed inflammation, observation of OCT from the ILM2 choroid, passing the scan through particular lesion if present, will help in arriving at a correct diagnosis. Thank you, sir.
Okay, you tried for a systemic examination, total systemic examination of these 3 patients.
Sir?
Systemic examination to find out the cause. You can use your mic.
First patient had no systemic illnesses, sir.
Oh.
Nothing significant in the systemic history was present, sir. Second patient was diabetic and hypertensive, sir. But systemic investigations did not relieve much, sir.
And how you diagnosed VKH?
VKH, the findings of VKH that we could see on OCT, sir, multiple NSDs.
No, systemic. Any other systemic patient?
Only ESR was elevated, sir, nothing else, sir. So with this OCT findings only with multiple neurosensory detachments, nothing like no systemic features.
Okay, we'll go with the other presentation.
Thank you, sir.
Thank you. You are presenting the anterior segment.
Anti-segments.
Okay, so we'll go. Because the candidates are very less, we'll go after
My
the
posterior segment presentation is pending, sir. Sir, can you hear me?
Yes.
Yes, please.
This is Anamika and my posterior segment paper is pending, sir. Could I present that?
Yeah, no problem. We'll call you. Don't worry. We are going appositely. Whether it is
Oh,
anterior
like
segment
that.
or
Okay.
posterior segment, we will give the points and don't worry. We will call you.
Okay.
Shall I share my screen?
Good afternoon. Good afternoon. I am Dr. Good afternoon. I am Dr. Ranjit Kumar. Today I am presenting a paper on anterior segment. This is phacoemulsification in canines, that is dogs. There is nothing to disclose financially, and the purpose of this study is what are the challenges in the surgery in while operating a cataract on a canines and how it differs from the humans. It is done for the first time in the state of Andhra Pradesh, and it is a second center in the South India. It is conducted as a part of training program for the veterinary surgeons to do phaco in dogs. It is done at Government Veterinary Hospital, Gannavaram. Evaluation: total 4 dogs were operated, 2 Labrador, 1 Pomeranian, 1 German Shepherd. And the pre-op evaluation, all were examined with a portable slit lamp, fundus with the direct ophthalmoscope, indirect ophthalmoscope, B scan, A scan were done, chest X-ray also done, IOP, RBS were done. In the examination, and all this done like.
For this examination, how the animal is going to cooperate?
Sir?
How the animal is going to cooperate for all these examinations, sir?
Yes, sir, that is what I am explaining.
No, yeah, right. Proceed.
It is a menace reflex, checking for a menace reflex in a Pomeranian dog, and this is a palpebral reflex in a Pomeranian. That is, when they touch the palpebral fissure, it closes, and it is a pupillar light reflex. And another one is a tracking reflex test in a Pomeranian. And this is a obstacle test, whether the patient is hitting the objects or not. And this is examination with the portable slit lamp. And this is a checking the fundus with a direct ophthalmoscope. B scan were done in all cases. And this is checking the IOP with a tonopen. The hospital has all the equipment. They procured all equipment with the, and also shimmers is not routinely done whenever required. And we did keratometry in a cooperative patients, and also A scan were done in all to calculate the IOL power. And on an average, the IOL power came as a 40 diopters. The surgery is done under general anesthesia with propofol and sevoflurane, IV and inhalation anesthesia given by a good team of anesthetists. And putting the eye drops in the patient and positioning for surgery is very challenging. And BSS is pulling in the palpebral fissure while operating. And this is giving IV propofol, and intubation was done. And this is the position for the patient. Bell's reflex is very strong, and putting superior rectus or stay suture near the limbus, avoiding the third eyelid. And the corneal diameter is noted as a 14 mm, and the anterior capsule is very, very thick. We need to cut with Vanna scissors to make the rexus. The cataract is spherical, ball-like, very big and very, very hard in mature cataracts. We implanted 40 diopters acrylic foldable IOL after calculating through A scan. Initially, the shaving was done around the eye, and then betadine painting and drape and superior rectus or stay suture near the limbus and the speculum. In one case, the pupil is small and need to stretch the pupil sphincter with the dialer and wide dialers. And iris is very, very fragile and sensitive, forming fibrous membrane on the table itself, and also bleeding if touched unnecessarily. All eye drops are used same as used in humans. And this is the trypan blue staining the anterior capsule. And there is a small video clip showing the couple of steps of procedure. But the cataract, the mature cataract is very, very hard, and it took very long time, almost 1 hour, 1 to 1.5 hours. And when I try to do the capsulotomy with the needle, it is very, very hard. So we have to cut with the Vanna scissors to make the anterior capsule opening. And then I used the Rexis forceps and did the phaco. After completing the thickness of the lens, it is almost like a spherical, sir, completely spherical, and yeah, lens actually we didn't measure lens separately.
Actually, we
sir.
don't know any anatomy of that, is it not? We know for human being, we don't know anything for the animals. It's a rare presentation, really speaking.
This is the
Did
last.
Did you present this in the veterinary doctors conference?
Sir?
Yes, you can
Veterinary
proceed.
doctors conference also you may present this, I think.
Yes, sir.
Yeah, fast.
This is the fundus glow after completing the cortex. The fundus glow is in one case yellow, one case it looks like a green. And implanted a foldable acrylic Renner haptic model. Though the corneal diameter is 14 mm, this 12 millimeter IOL is in the center visual axis without any decentration. And also we took a guidance from the doctors operating at Chennai, and what IOL power they are using, what material and all, we also took from help from them. We need to keep a tarsography for a week and also put a C collar post-operatively. And this is the bandage with the C collar, and the right eye got operated, left eye is a total cataract. Again, we need to operate the left eye also. The post-op outcome is excellent. With a good motivation to climb the learning curve, excellent results can be achieved with great job satisfaction. Post-operative management, same.
It is possible to put the drafts, and is it possible so easily for putting drafts?
Yes, sir, even pre-operatively also we put the dilatation, we did not. Same.
Yes, Dr. Ranjit, it is out of the way, but still I got a doubt. Being human surgeons, are we legally allowed to do surgery on the animals? I mean, veterinary.
Actually,
I think Dr. Murthy can tell about this. Legal. Are we legally allowed to do surgery on the cat animal? Yeah, even though it's out of way, I'm just asking. Legally.
Actually, we can do, but if you are ready that to accept all of your next patients will be animals only, not humans.
Ethical issues are all same in every place. That is called maleficence, non-maleficence, justice, and freedom. So here maleficence means what best you can do it. That is not at all very important. Non-maleficence is more important because not doing harm is more valid than doing benefit. So you are not doing harm because you know that the dog is not moving. You are trying to help with all the knowledge what you have acquired to help the animal. That's all. And the only thing is about the drops and all, they are putting all the collars and protecting not to scratch everything. They are doing it. That is fine. Only thing is we have to be very careful. We can't use the same instruments again in our own theater. We have to be very, very cautious, doubly sterilize it, and then only we can use it. That is the only precaution. Otherwise, ethically, it is not at all wrong. You should not do anything harm. That's called non-maleficent. As long as you don't do harm, it is good. Okay?
The basic idea is it is started as a to train the veterinary doctors to train their dogs for a cataract procedure, because it is not done there. They took my help, so I guided them. Even for me also, it is the first time.
Yeah,
So
we all appreciate your efforts anyway, and we have seen this in the papers. Congratulations.
It is a teamwork.
Yeah.
Sir, do you find any difficulty doing in dogs? What is the difference?
during procedure, it is very, very tough. It actually, in humans, it finished in 10 minutes, but it took almost 1 to 1.5 hours. The mature cataracts are very, very hard. They don't break. The energy, the parameters of our machine is not at all enough actually. In immature cataract, somewhat comfortable, I could finish it. In one phase, I thought I may stop in the middle also. But
He said that anterior capsule also.
anterior capsule is very, very thick. I have to cut with the vanus and remove it. I could not peel it off. It is 10 times thicker than 10 to 15 times thicker than the human eyes.
Fundal glow, it looks like yellow.
Yes, fundal glow is one.
You see the fundus after surgery? Fundus.
Madam, I could not hear.
Have you seen the fundus? She is asking. The fundus after surgery.
Yeah. We can see the fundus very easily with the indirect ophthalmoscopy. Indirect portable slit lamp, like they have a scan, B scan, everything they procured. Only thing is, they are not left with the skills. If we give them, then they will do miracles. That is a great thing.
What is your fundus observation?
Fundus, the background color is different. The dimensions are slightly more than the humans, like disc vessels, and the rest of the thing is
same.
And all patients are very cooperative.
Thank you, Dr. Ranjit, and we'll go to the other presenter.
Thank you.
The posterior segment surgeon just now is all asking. Yeah, please. Or can I call Dr. Anamika, no, sir? Yes, Vignita. Vignita is there? Any posterior segment presenters?
Yes, it's anterior segment.
Online.
Yes, sir.
Yes, please.
Anterior segment.
Can you tell about your paper and your name?
Sir, this Vignita, sir. Do I share the paper, sir?
Yes, please. You can go ahead.
Yes,
if you are
sir.
ready with your presentation. Vignita.
Yes, sir. Good afternoon, everybody. Today I'm going to talk about evaluation of visual outcomes, extent and depth of focus IOL. This is Dr. Vignita and my co-author is Dr. Vishnuvardan. Coming to the introduction. Cataract surgery, nowadays it's a must for all. It's a new way of easiness to strain-free vision by extent depth of focus IOLs. The study showed a better lifestyle with extent depth of IOL, whose mechanism slightly varies within the eyes. To evaluate the visual acuity in patients who have been implanted with the new generation AF lenses, which is in focus APOSEYECON IOLs, near, intermediate, and distance and contrast sensitivity, glare, and halos have been compared. The populations, it's a retrospective study, 50 eyes of 50 patients, both male and female, above the age of 40, fulfilling the inclusion criteria were a part of the study. The inclusion criteria were more than 40 years of age. Patients who were diagnosed with lens changes of any grade were included in the study. with a nil improvement with glasses, who had a history of halos and glares, who had already undergone cataract surgery in the other eye. And the exclusion criteria were age less than 40 years and any ocular trauma or ocular degenerations, any other previous ocular surgery other than cataract surgeries, and decreased vision due to any other causes like pathological causes other than cataract. These all patients underwent basic ophthalmic examinations, including visual acuity, intraocular pressure, slit lamp examination, dilated fundus, and examination preoperatively. Distance vision was calculated using Snellen chart. Near vision was also calculated using Snellen chart. Intermediate vision, and they were with the day-to-day work and contrast sensitivity, the Pelly Robinson chart. While the design of adoptions, in the peripheries, it was for the intermediate and distance vision, while in the middle, it was for the near vision. Coming to the explanation, it was phacosurgery, commonly known as sutureless surgery by the common people and well known for its early recovery. It is done under topical anesthesia as the procedure takes less than 10 minutes. Phacoemulsification surgery is mostly done with a foldable IOL implantation. Patients included in the study underwent phacoemulsification surgery with extended depth of focus IOLs, preferred in focus on IOLs. This is the most common eye procedure, but it is decided by the patient finally according to their affordability. The patient's review. This is from the patient, which was about the visual outcome postoperatively, concerning about the distance vision, near vision, and intermediate vision. It is about the glare and halos also. Postoperatively, distance vision at 3 months, 87% of patients with uncorrected visual acuity had 6.6 to 6.9, while 94% of patients had a best corrected visual acuity of 6/6. The patient's visual outcome review was 78% of patients had a very good visual outcome review, while 17% of patients had good, and 5% of patients were satisfied, while intermediate vision, 90% of patients had intermediate vision of between 6/6. They had 29% of patients had a good visual outcome, while 1% of patients had satisfied. In the post-op near vision for 3 months, 80% of patients had uncorrected visual acuity between N6 to N8, while 99% of patients had best corrected visual acuity of N6. 80% of patients had a visual outcome review of N6, while 22% of patients had good and 6% of patients gave a review of satisfactory. Coming on to the contrast sensitivity, 75% of patients had a contrast sensitivity of 1.86, while coming to their glare and halos, it was 1% of glare and 1% of halos, while other 98% of patients did not complain of anything. The limitations were sample size were not enough. Coming to the conclusion, newer generation Indian EDOF lenses is a good option, which can be considered less visual rehab time, corrects distance and intermediate and near vision. Contrast sensitivity is not compromised. It had minimal halos and lesser post-op complications. It's a better option as compared to multifocal IOLs. Lastly, it's our indigenous product. So it's better we use it because of the better means of availability and time consumption of ordering and everything. Thank you.
Okay, that's a good presentation. I would like to know how you are measuring the depth of the focus.
Depth of focus.
Do you have any idea regarding Panem's fusional area?
No, sir. Not yet, sir.
Is there an instrument to measure the depth of the focus? Anyway,
Okay.
thank you. Thank you, Bhumika.
Thank you, sir.
Presentation. Yeah, who is the next candidate? Dr. Anamika is there? Or any other presenter? Yeah, all are online. Somebody is ready, then we can go.
So can I present my topic?
What's your name, ma'am?
I'm Dr. Padmini, sir, for anterior segment.
Yeah, please go ahead. Dr. Padmini, you will be talking about comparison of mean and centroid of surgically
Yes, sir.
induced astigmatism.
Yes, sir.
Please, go ahead.
So can you see my screen, sir? Shall I start?
Yes, please.
Good afternoon, everyone. So my name is Dr. Padmini from Vishaka Eye Hospital. So I'm going to present on the comparison of mean and centroid of surgically induced astigmatism for standard keratometry as well as total keratometry for cataract surgery. As we know that modern cataract surgery does not induce any astigmatism due to 2 to 3 mm incision size. But still it is essential to accurately predict the surgical induced astigmatism to maximize the visual function as well as subsequent patient satisfaction, especially in toric IOL implanted eyes. As we know that the arithmetic mean is based on only the magnitude of astigmatism, but does not include the direction of astigmatism. Whereas the centroid of surgical induced astigmatism is determined by both magnitude and direction of astigmatism. Hence, the use of centroid is beneficial to grasp the overall surgical induced astigmatism trends of cataract surgery. So hence, we retrospectively examined 198 eyes of 198 patients who underwent phacoemulsification cataract surgery through a 2.2 temporal clear corneal incision by a single experienced surgeon, none other than Dr. Gopal Raju, sir. We quantitatively measured the magnitude and axis of corneal astigmatism, both for standard keratometry as well as for total keratometry, both preoperatively and at 1 month postoperatively using the IOL Master 700. We assessed the mean surgical induced astigmatism and centroid and the double angle plots for the display of individual SIAs by using the astigmatism double angle plot tool that is available on American Society of Cataract and Refractive Surgery website. So this is the tool that is available on ASCRS website, where we just need to enter the incision size, the location, whatever eyes we are taking, the cornea, flat, steep axis, and the postoperative readings. It automatically gives us the centroid astigmatism as well as the mean surgical induced astigmatism. So hence we tried comparing the arithmetic mean of surgical induced astigmatism and the centroid of surgical induced for both standard keratometry as well as total keratometry after a standard cataract surgery. We also tried evaluating whether the posterior corneal astigmatism has any influence on SIA. We also tried to assess the bilateral differences between the two eyes, that is where the right and left eye have different SIAs. These are our demographics. A mean age of our cases was around 60 with a male preponderance. We had taken equal right and left eyes for equal comparisons. And we had a flat keratometry on an average of 43 and a steep of 44. And a corneal astigmatism for around 1 diopter, whether it is a standard or total. And an axial length, we had taken mean axial length of 23 diopters. With a posterior corneal astigmatism in all cases account for about 0.21 diopters. So these are the double angle plots of centroid astigmatism for both standard keratometry as well as for total keratometry. If we see the centroid for the standard as well as the total is same, that is around 0.12 diopters at 79 degrees, that is always with the rule. Whereas the mean absolute is on 0.31 in case of standard keratometry and 0.35 with total keratometry. So when we tried comparing the standard and total keratometry using paired t-test, the preoperative astigmatism and for standard as well as total was same. P-value was not significant, as well as post-operative mean and centroid were almost significant. Graph showing the double angle plots of individual surgically induced astigmatism. This is the individual, that is for right eye and left eye separately. We found the centroid for right eye was around 0.17, whereas the centroid for left eye was around 0.13. This is a comparison for right eye and left eye separately using the standard keratometric readings. The preoperative values were same for both the right and left eye. Post-operative as well as the mean SIA was also same. So there was no difference in the p-values for the right and left eye. So when we use the total keratometric readings in that ASCRS tool, we also found that the centroid was almost similar to the standard. That is, the centroid was only 0.16 for both the right and the left eye. So this is using total keratometry, where we found no significant difference between the right and left eye for both preoperative, postoperative, as well as mean and centroid. So overall, if we see, the standard keratometry and total keratometry gave the same values of centroid as well as the mean astigmatism. So the results, the magnitude of corneal astigmatism did not change from 1 diopter, which was preoperatively, to 0.95 diopters postoperatively. The mean SIA in our study was 0.31 diopters, whereas on the other hand, the centroid was only 0.12 diopters at an axis of 79 degrees. Even the magnitude of total corneal astigmatism also did not change, that is from 1.1 diopter preoperatively to 1 diopter postoperatively. We also found no significant difference in the preoperative or postoperative astigmatism and mean SIA between the right and left eye. So we tried comparing our results with the previous studies. But Kamya and et al., where they have used autokeratometer with a 2.8 incision, they have shown the mean SIA of 0.5. Whereas the incision size was only 2.2, our mean SIA was 0.31. So it was very less when compared to the other studies. Even our centroid was only 0.12 diopters. So to conclude, the magnitude of centroid is largely decreased to approximately 40% of mean surgically induced astigmatism, and the direction is usually towards the with the rule. Hence should be noted that the mean was considerably different from centroid, especially when selecting appropriate toric IOL model and power. There was no difference in the centroid between standard keratometry and total keratometry. So my take-home message is, since modern cataract surgery is termed as the refractive surgery that aims to correct both spherical and cylindrical errors as much as possible, centroid SIA instead of mean SIA should be applied for entering the SIA data in manufacturer's toric IOL software during preoperative planning. These are my references, and thank you.
Dr. Padmini?
Yes, ma'am.
Am I audible?
Yes, ma'am, you're audible, ma'am.
So what do you mean by total keratometry?
Total keratometry includes both the standard, that is anterior keratometry, the corneal thickness, as well as the posterior corneal astigmatism.
Okay. So there is no difference in the posterior corneal astigmatism. Previously, you have presented one.
Yes, ma'am. Because our cases, most of the cases were against the rule. Our posterior astigmatism was only very less, 0.2. So it did not affect our readings when we considered both standard or total keratometry. But if it is with the rule, when the posterior corneal astigmatism is very high, it definitely affects us. So,
The incision size is
2.2 mm, ma'am.
Hello. Yes, Dr. Padmini, thank you for your presentation. We'll go on to the next candidate. Who is there on the line, please? Any other candidate ready for presentation? Dr. Anamika, are you there? Dr. Anamika. Dr. Prabjot. Dr. Megha. Dr. Raghava. Dr. Sai Sri. ఏమండి నెక్స్ట్ ఎవరైనా లైన్లో యూ వాంట్ టు ప్రజెంట్ వాట్స్ యువర్ నేమ్ డాక్టర్ వాట్స్ యువర్ నేమ్ యా యు ఆర్ ఏ మెంబర్ నో లైఫ్ మెంబర్ రాటిఫైడ్ Sri enter segment. Sir, can we allow him? Yeah. Yes, yes, definitely. Because it is a competitive paper. And they should be a ratified member of APOS. Dr. Veena, Dr. Jamila, Dr. Surya, whoever is on the line, please, can come forward and you can present your paper.
Sir, good afternoon, sir.
Yes, please. So what's your name, doctor?
I'm Surya, sir.
Surya, and you are presenting a anti-segment paper.
Yes, sir.
Comparison of automated versus manual keratometry.
Yes, sir.
Yeah, please go ahead. If you are ready with your slides.
Yes.
Tell me which is the better, automated or manual keratometry?
Sir, automated is slightly beneficial than the manual, sir.
Please share your
Present
screen.
your slides, please.
Yes, sir. Sir, is it visible, sir?
Yes, yes, it's visible.
We are seeing your slides. You can go ahead.
Sir. Sir, good afternoon, everyone. Today's my paper topic is comparison of automated versus manual keratometry for IOL power calculation and cataract surgery. Coming to introduction, in modern day cataract surgery is a refractive surgery aimed at providing excellent visual acuity to improve the patient's refractive status. It is estimated that in India, more than 5.1 million patients undergo cataract surgery every year. The important step in ocular biometry to obtain desired post-operative refractive outcome for which standardization of technique is required to ensure the accurate measurement of IOL power. Implant power can be calculated by knowing three variables, that is axial length, keratometry, and A constant. In IOL power calculation, K value plays a significant role. Keratometry involves determination of curvature of anterior corneal surface that is expressed in diopters. This is used to estimate the radius of corneal curvature, which is then used with thin lens formula to estimate the dioptric refractive power of the cornea, assuming an average refractive index. Aim of my study is to compare accuracy of implant power calculation by two different types of keratometry, that is automated and the manual keratometry. Inclusion criteria: patients aged between 45 to 60 years with cataract and have a potential for good visual acuity, and patients who are willing to give consent for the study. Patients with any other ocular diseases, any intraoperative complications during surgery who are not willing to give consent, and patients with preoperative astigmatism were excluded from my study. Subjection methods: The study was a comparative analytical study. My sample size is 48 eyes of 48 individuals conducted in Department of Ophthalmology, Ashram Medical College. Study time is from January to August 2021. After selecting patients having cataract based on lens opacity classification, written and informed consent has been obtained from the patients. Corneal curvature readings K1 and K2 values were obtained from automated keratometry and manual keratometry from each eye, and then axial length was measured using A-scan immersion technique. While doing cataract surgery by small incision 6.2 mm triplanar corneal scleral tunnel on steeper meridian, serially the first patient was allotted on group AK and second was on group MK, so on till 24 patients had been operated in each group. For both groups, axial length was measured using immersion A-scan. A constant was 118.2 as the same implant design was used in all cases. For obtaining IOL power, two keratometric values obtained by two devices for both groups are used with two constants, that is A constant and the axial length. Pharma used is SRK2. Postoperatively at 6 weeks, visual acuity and residual spherical errors were recorded and compared for both groups. Statistical analysis. Data was analyzed using SPSS version 28 software. Independent sample t-test was used to compare the value of two techniques. P-value less than 0.05 was considered statistically significant. Coming to results, the study was carried out on 48 patients, 24 males and 24 females. Mean keratometry with automated and manual keratometry were 44.218 plus or minus 1.558 and 45.755 plus or minus 1.78. There was statistically significant correlation between the two techniques. Postoperative visual acuity at the end of 6 weeks during follow-up period was noted. A majority of the patients fell in the group that is between the 6/6 to 6/9 to 6/6. And then postoperative residual spherical errors were noted at the end of 6 weeks. A majority of the patients in both groups fell in the group that is less than plus or minus 0.5. None of the patients fell in the group that is more than plus or minus 1.50 diopters. The independent sample t-test has shown that the difference was found to be statistically insignificant. P-value of is 0.443. We made a precise observation on age, sex, and prevalence of various cataract grades. We compared postoperative visual acuity and the spherical errors. Considering postoperative residual spherical error, we found that MK group 75% of patients had a residual spherical error less than plus or minus 0.5 diopters, and 25% of patients having residual spherical error between more than plus or minus 0.5 to plus or minus 1.5 diopters. None of them have error of more than plus or minus 1.5 diopters. Similarly, in the AK group, 87.5% of patients developed a residual spherical error less than 0.5, and 12.5 patients having residual error between more than 0.5 to 1.5 diopters. With such results, we can say that maximum number of patients had a spherical value less than plus or minus 0.5 diopters at 6 weeks postoperatively. Thus, our study revealed no significant difference between the two groups. Considering postoperative residual spherical error, AK group has a better visual outcome when compared to the MK group. These are the similar studies. Coming to conclusion, in this study, we compared the accuracy of manual keratometry with that of the automated for the calculation of IOL power length. In terms of postoperative residual spherical errors, there was comparatively better visual outcome in AK group when compared to the MK group. In concluding, automated keratometry is more preferable than the manual keratometry. These are my references, sir. Thank you.
Thank you. Any questions from offline or online? Anybody wants? Okay, thank you very much. We move on to next speaker.
Thank you, sir.
Anybody available online for enter segment? Any speaker for posterior segment?
Yes, sir, I'm available. I'm Anamika. May I share this?
Anamika, madam, start your presentation, madam.
Yes, sir. I hope my screen is visible, sir.
Yes, it's very much visible. You can go ahead.
Thank you so much. I thanks the scientific committee of APOS for giving me the opportunity to present our work. Today, I'll be speaking on the ocular toxoplasmosis and immunocompromised, that is HIV patients, their clinical features, management, and visual outcomes. So toxoplasmosis retinochoroiditis is one of the most common infectious posterior pole retinitis, and in which is seen in immunocompetent patient, and in immunocompromised patient after CMV retinitis is one of the most common posterior uveitis presentation. We have studied the retrospective analysis of our of the toxoplasmosis retinochoroiditis only in the HIV positive patients in our hospital who presented between the January 2006 to February 2019. So we had a total of 27 patients who had AC inflammation in about 69% of the patient. We have seen both the unifocal and the multifocal presentation. And along with that, the primary lesion was seen in 80%. By primary lesion, I mean that the presence of a scar was not seen, which is classically seen in immunocompetent patient. If we look into the zones, the zone 1 was only the posterior pole, which was seen in the maximum of the cases, which was about 47% of our patients. So about 69% of the eyes I had mentioned had anterior uveitis presentation. 80% of the retinitis that we saw in our series had a larger, that is more than 1 to 1.5 disc diameter to 2 disc diameter of retinitis seen. It was more of a horizontal spread. 47% of the eyes had zone 1 involvement, and the pre-existing hyperpigmentation was seen only in the 36.1% of the patients. So so far in the world literature, if you look there are only 3 studies which have been done, which have studied the toxoplasma retinitis features in immunocompromised patient. This happened back in 1988, 90, and 1992. So they also have looked into the IgG, serum IgG and IgM ratios in their patient. And what we have seen that 17 patient in our cases, they had IgG positive. But what is unique in our strength or in our study, and I would call it a strength, is that we have looked into the CD4 count in these patients as well. And we saw that about 38% of the patient had more than 250 CD4 cell count. So we have treated our patients both with the oral Bactrim DS, and that means 10 of the patients received adjuvant treatment, that was intravitreal clindamycin. So this is the first study which has explained the efficacy of the trimethoprim and the sulfamethoxazole in the HIV patients suffering with the toxoplasma retinitis. Also, it's unique in the sense that it tells you an idea that the visual acuity at presentation, which was less than 20/200 in about 58% of our patients, did improve to 44.4% in our patients. We saw a very significant association between the CD4 count and the visual acuity as well. The patient who had a CD4 count more than 200 had a visual acuity of 20/20 to 20/100. So that was a significant association. Another interesting find that we have found is that we know that retinochoroiditis, by main term in OCT, if you'll see that there is a retina and the choroid involvement. But in our patient, it was primarily only the retinitis was seen on Swepso's OCT. So this is how our study is different from the other studies which have been done in the past. So I would like to conclude that toxoplasmosis in HIV positive patient, it presents with the large bilateral multifocal retinitis, and they have favorable outcome with antimicrobial therapy when treated and identified on time. Thank you for the patient listening. Thank you, ma'am.
Thank you.
Thank you, judges.
Dr. Namika,
Yes, ma'am.
is only oral or both oral and intravitreal is effective?
Ma'am, we have given oral.
Regarding-
Yes, thank you, ma'am, for the question. So oral treatment was given to all of the cases, but in 10 of the eyes, intravitreal clindamycin also was given in addition to that.
So when will you go to intravitreal?
Well,
Intravitreal?
yes.
Yeah.
Intravitreal clindamycin is indicated in those cases, ma'am, where the patient is not able to take the oral. That means they have a contraindication to that. Or if suppose you see a female who is pregnant and we don't have the alternative for that, in those patients you can offer the intravitreal clindamycin. Or if you see the patient has not responded and if you want an adjuvant response to the treatment, in those cases also intravitreal clindamycin can be given.
Okay. Thank you.
Thank you.
Is anyone is online or offline to
Ma'am,
present?
ma'am, can I present?
Your name? May I-
Jamila, ma'am. Jamila, ma'am. Anterior segment.
Central corneal thickness changes after factor emulsification.
Yes, ma'am. Yes, ma'am.
Okay, go ahead.
Good afternoon, everyone.
Central corneal thickness before and after factor emulsification. My name is Dr. Sheikh Jamila, and my co-author is Dr. T. Pradeep, Professor. Changes in a
Good afternoon, everyone.
Share.
My topic is, ma'am.
Dr. Jamila, we are not able to see.
Ma'am,
Please share your screen.
Ma'am, can you see it now, ma'am?
Yeah. Go ahead.
Okay. Good afternoon, everyone. My paper is changes in the central corneal thickness before and after factor emulsification. My co-author is Dr. P. Pradeep. Coming to the introduction, worldwide, age-related cataract is the leading cause of visual impairment, and the most commonly done procedure is phacoemulsification, which is associated with some insult to the corneal endothelium. And the maintenance of transparency and corneal thickness depends upon the endothelium. Therefore, measuring the thickness of the corneal endothelium postoperatively serves as an important parameter to see the endothelial cell function. In this
Dr.
study,
Jamila, please project your slides full screen, slideshow. You go to slideshow, individual slides.
ma'am, there is recorded version, ma'am.
Recorded version, okay. Okay. Then you can go ahead.
Can I play it, ma'am? Recorded version.
No problem.
changes in the central corneal thickness before and after factor emulsification. My name is Dr. Sheikh Jamila, and my co-author is Dr. T. Pradeep, Professor, Ashram Medical College. Worldwide, age-related cataract is the leading cause of visual impairment, and the most commonly done procedure is phacoemulsification, which is associated with some insult to the corneal endothelium.
Dr. Jamila,
ma'am,
and corneal thickness depends upon the endothelium.
voice is not clear.
Corneal post.
Ma'am,
Mic is not clear. Your voice is not.
Your voice is not audible. Please put the mic close to your.
Okay.
Okay, now you can go ahead.
Coming to the materials and methods, this is an observational study and participants were recruited from the OP Department of Ophthalmology, Ashram Seluru, and informed consent was taken from the participants. And all the participants were divided into three subgroups based on the normal variability in their central corneal thickness, which is measured using the OCT. These are the three groups, and group 1 include 480 to 529 micrometers, group 2 includes 530 to 569, and group 3 includes 570 to 600. micrometers. Next, inclusion criteria. Patients ranging from 40 to 70 years are taken into the study and who's having grade 2 to 3 cataract according to LOCS grading. And exclusion criteria. Corneal pathologies such as corneal degenerations and dystrophies were excluded. Mature and hypermature posterior segment pathologies, dry eye syndromes, and contact lens wear history, ocular surgery, and pseudo-exfoliation syndromes were excluded from the study. And after taking the medical history, and all the patients were subjected to a comprehensive ocular examinations, which include visual acuity, color vision, ancillary grid, slit lamp examination, and grading of the cataract and fundus examination to rule out any posterior pathologies. And Goldman tonometry, gonioscopy, and biometry were done. And the patients were all operated by an experienced surgeon, and preoperatively patient were given local anesthesia using a peribulbar injection, and the phaco missions were identical for all the patients with the same cataract density, and the infusion bottle height was set at 1 meter high, and a direct chop technique was used for phaco emulsification. And after removing the remaining cortex, foldable IOL is implanted in the bag. On the first post-operative day, patients were prescribed topical antibiotics and steroids, and CCT was measured, and all the patients were examined on the 7th day and after 1 month of surgery, and CCT was measured. And coming to the statistical analysis, paired t-test was used to compare the changes in the mean CCT over time, and the p-value less than 0.05 was considered statistically significant. Coming to the results, out of 60 patients which were included in the study, the mean age is 54.8 plus or minus 12 years, and the male to female ratio is 4:3. Preoperative mean central corneal thickness increased by 11.2% on the first post-operative day, which is reduced to 3.9% on the 7th post-operative day, and it was 0.4% on the 30th post-operative day. And central corneal thickness was reduced to a mean value of 546.73 micrometers on the 30th post-operative day, which is 544.51 micrometers preoperatively. And in this graph, we can see the changes preoperatively, day 1, day 7, and 1 month post-op. Here we can see the changes in group 1, group 2, and group 3. These are the there is no statistical significance between the preoperative and the post-op 1 month values, but there is a statistical significant difference between day 1 and day 7 compared to the preoperative values. Coming to the discussion, endothelial cells of the cornea maintain its detergence by pumping fluid out of the stroma, and their function may alter due to trauma or inflammation during surgery, leading to increased corneal thickness. Factors causing corneal endothelium injury during phaco are ultrasound energy, turbulence of the irrigation solution, ricocheting of the nuclear fragments, IOL contact, air bubble, and instrument contact. And decreased pumping action leads to increased CCT, which can be quantified by CCT measurement post-operatively. And this is supported by the Lundberg et al., concluding that the difference in the pachymetry used to assess the effects of phaco on corneal endothelium. And the corneal endothelium recovers over time, and it may vary depending upon factors like general health, age, cell count, trauma, inflammatory response, etc. And the mean rise in the CCT levels in all the groups, whether thin or thick corneas, are similar. And in this study, there is a mean increase in the CCT of 68 micrometers, that is 11.2% at day 1, which is compared to the Wally FS et al. They have 10.2% increase on day 1. And literature reports 2 to 10% increase in the central corneal thickness in the immediate post-operative period. And the transient rise in the CCT may give rise to false IOP spikes in the early post-operative period. So this has to be excluded. These are the similar studies. In Salvi et al. Study, there is a 13.81% increase in the immediate post-operative period, whereas on day 1, they had seen only 6.44% increase. Coming to Bowles et al., they concluded that the post-operative changes return to baseline after 1 week of surgery. Coming to the limitations of my study, there is shorter study time, and there is a lack of information about the endothelial cell count preoperatively measured by the specular microscopy. So we can conclude that after uneventful surgery, central corneal thickness reverts back to the almost baseline levels around 1 month, where caution should be taken while measuring the intraocular pressure to avoid false higher readings of intraocular pressure postoperatively. These are the references. Thank you.
Thank you very much.
Okay, sir.
For your cases, what about the FACO time for all cases?
So, almost similar time, ma'am. There is no significant difference in the time period, ma'am. All surgeries are performed by one surgeon, and no difference in around 15 to it occurred between 15 to 20 minutes, ma'am.
Okay. Thank
So,
you.
as you are telling that there are many factors affecting the central corneal thickness,
Yes,
like
sir.
turbulence of the fluid and viscomaterial, surgeon's expertise, which is the most important factor which alters the corneal thickness, endothelial cell count. Of course, everybody knows.
Excuse me.
Most important factor affecting the corneal thickness in the sense the endothelial cell count.
Endothelial cell count, many factors will affect, sir.
No, that's what I am asking. Which is the most important factor affecting the endothelial cell count?
Ultrasound, coming to phacoemulsification, mostly ultrasound energy, sir.
Okay, it is the surgeon's expertise. Fine.
Yes, sir.
Thank
Okay.
you. Thank you, Jamila. Anyway, we'll
Okay.
go on to the other candidate. If at all somebody is waiting, please can come forward.
Anyone is online? Offline, anybody is there?
So on behalf of APOS 6th conference, we thank everybody for participating in this competitive free papers presentation. And I conclude this session right at 3:30. Thank you, one and all. Thank you for your cooperation. Thank you.
అయిపోయింది. విశ్వనాథం గారు పత్ని సమీర నైనా శ్రీరామ్ సమీర అలాగే కొట్టుకుంటారు పత్నికి చెప్పేసాను సార్, పత్నికి లింక్ పెట్టాలి. సమీర అనిల్ అనిల్ స్టార్ట్ చేస్తే మరి 4 ఇండియన్ ఇద్దరు వచ్చేసారమ్మా, దీప్తి అండ్ తనుజ దీప్తి. बशीर हो गया एक्सेल शीट लिंक उसमें डाल समीर है मैडम मैडम you are competing with your husband. मीटिंग का लिंक भेज दो.
Hello, good afternoon, all of you. First, let me congratulate all the winners in their respective sections. And this will be the final from this session. This is Dr. G.R. Reddy's Best of APOS Competitive Papers. So 2 papers from postgraduates, 1 paper from anterior segment, Dr. Nadandla Vishnuvardhan, best paper. Posterior segment, Nayana, Dr. Sriram C. Rahula's best posterior segment paper. Then 1 paper from the Vengal Rao session, and then 1 paper from the Raghavachar session. So these 6 people, out of these 6 presentations, one best of that 6 papers will be selected, and that will be given as Dr. G.R. Reddy's Best of APOS Competitive Papers. So the importance of this paper is, this paper will be automatically qualified to the AOS, All India Ophthalmic Society. You need not enter again and then wait for selection. This will be a nomination from the APOS. So you can directly present in the next year AOS. So that is the main reason. And then also this will be awarded in the next annual conference during the inauguration. Now let us start. So each presentation will be for 7 minutes, followed by a few questions by the judges. And then one of the criteria is you have to complete within then 7 minutes. So we will judge the paper based on the original content, originality of the work, presentation, preparation of the slides, and then that with completion within the time, and then the communication, and also the response to the answers. So these are the criteria we follow generally for any competitive session. So now let us start. All the best, and please go ahead. The first paper, Madhu will take over.
Dr. Ashok, who is the winner of Dr. Vengal Rao Best Paper, will present first. Please. Start, please.
Sir, I've loaded it on the computer, sir. They'll share from that.
Okay. Recording, is it recorded?
No. I'll present it.
Okay.
No, I have a PowerPoint, so
Okay, right. ఒకసారి వెళ్ళి చెప్పండి.
It's come as half, so.
Screen Bashir. Okay.
I'll go ahead, sir.
Yeah, please go ahead.
Yeah.
All the best.
Good afternoon, everybody. I would like to thank APOS for this opportunity. So I'll be presenting today about COVID-19 associated retinal adverse events, that is vascular occlusions. Next slide, please. Yeah. Despite the large number of doses of vaccine that have been administered worldwide, its adverse systemic events remain uncertain. So what is it that is about COVID-19 vaccination and the retina? There have been anecdotal cases of adverse retinal ischemic events presented at conferences and undoubtedly awaiting publication. Post-adenovirus vaccination, that is manufactured by Johnson & Johnson and AstraZeneca, patients can have potentially life-threatening cerebral venous sinus thrombosis, which have been documented in literature. Next slide, please. So, in contrast to all other vaccines, the coding sequence of SARS-CoV-2 immunogen in the AstraZeneca vaccine has not been modified to stabilize and to mitigate shedding of the expressed S protein. So what this does is, thus it is possible that the expressed S protein in the circulation after AstraZeneca vaccination can induce a pro-inflammatory, pro-coagulant response or direct disturbance of the endothelial cell integrity. Next slide, please. So the purpose of this study was to describe retinal vascular events after receiving COVID-19 vaccination. Next slide, please. So it is an observational case series. The study was conducted at Shankarai Hospital, Guntur from April 2021 to September 2021. Patients who presented with ocular adverse events within 2 months post-vaccination were analyzed. 6 eyes of 6 patients presenting with retinal complaints were included in the study. All the patients received Covishield vaccine. The age of the patients ranged from 45 to 70 years. The visual acuity ranged from 612 to CF 1 meter. 4 patients had branch retinal vein occlusion. 2 patients had central retinal vein occlusion. One of the patients did not have either diabetes or hypertension. Rest of the patients had either of them. Coming to case 1 was a 52-year-old female recently diagnosed diabetic and hypertensive. She has received Covishield vaccine 3 days back. BCVA in the right eye was 618 parts, left eye was 612. On examination, anterior segment was within normal limits. Posterior segment examination of the right eye was within normal limits. Left eye showed CRVO with BRAO, and there was no macular edema on OCT. We advised blood investigations for the patient, which were within normal limits, and the patient was started on steroids as there was no macular edema. Case 2 was a 58-year-old male who presented with complaints of defective vision in left eye since 5 days. He has received COVID-19 vaccine 10 days back. The patient is a known diabetic since 3 years. BCVA in the right eye is 69 parts, left eye was 624 parts. Anterior segment examination was within normal limit in both the eyes. Posterior segment examination of the left eye showed macular BRVO with macular edema. Right eye was within normal limits. The patient was again advised blood investigation, which were within normal limits, and the patient was treated with Avastin as the patient had macular edema. Next slide, please. Now, coming to the third case was a 58-year-old male presented with complaints of again defective vision in the right eye since 10 days. He has received COVID-19 vaccine 2 months back. He is a known diabetic and hypertensive since just 1 year. BCVA in the right eye was 1/60, in the left eye was 6/6. Anterior segment examination showed cortical cataract in both the eyes. Posterior segment examination of the right eye showed STBRVO with macular edema. Left eye was within normal limits. Since this patient also had macular edema, significant macular edema, we have advised Avastin in the right eye, and the patient received the same. Next slide, please. Yeah, fourth case is a 45-year-old female who presented to us with complaints of defective vision in the left eye since 5 days. She is not a known diabetic or hypertensive. She has received COVID-19 vaccine 1 month back. West corrected visual acuity in the right eye is 6/6, left eye was CF 2 meters. The anterior segment was within normal limits. The posterior segment examination of the left eye showed papillophlebitis with CRVO. Right eye was within normal limits. The OCT did not show any macular edema, hence the patient was advised blood investigations and the patient was started on Visalone. Next slide, please. Yeah, the establishment of a causal relationship between the vaccine and an observed pathology will remain challenging and should be guided by scientific medical principles of assessing whether the observation is definitely, probably, possibly unlikely, or it is not related. So if unique aspects such as age, sex, systemic findings, eye findings and other morbidities of the adverse events are noted, then causation should then be suspected. If the pathophysiology of the vaccine response fits with the pathology, then also causation should be suspected. So why did we suspect COVID-19 vaccine as the probable cause in these cases? So we have our previous incidence of retinal vascular occlusions in our institute. Over a period of 6 months, we used to see around 80 to 100 cases. So in this observational period of 6 months, we saw a 15 to 20% spike in retinal vascular occlusions, which coincided with the majority phase where majority vaccinations were being performed. Though we had more number of vascular occlusions than these 6 cases, we choose these cases because of their association with COVID-19 vaccine and presence of peculiar features such as retinal whitening along with a vein occlusion, lack of very overt predisposing factors which could directly correlate to the vascular events. Next slide, please. To conclude, in this case series, the occurrence of retinal vascular complications post COVID-19 vaccination was supported by the presence of atypical presentation and history of COVID-19 vaccination. There is literature evidence that mRNA vaccines can result in vascular events. Hence, when a patient with history of COVID-19 vaccination comes for an eye checkup, a dilated fundus examination needs to be done. But most importantly, a causal relationship cannot be established from the study. Thank you. If there are any questions, I would.
Out of these 6 cases,
yes, sir.
How many had COVID infection?
None of the patients had COVID infection, sir.
So,
it was only they received COVID-19 vaccination.
So everyone is a non-COVID patient.
Yes, sir.
Then have you done any zero antibody investigation?
Sir, antibodies were not of that much because when the literature evidence was not there, sir, and whatever personal or little anecdotal reports are there, even post vaccination, some people are having antibodies, some are not having. On a personal front also, many of our doctors who have had vaccinations being done, when we get our own antibodies being checked, it was so variable. Some people had, some people didn't have. The correlation for it to COVID was also very, nothing was very certain, sir. So we didn't go in those lines of investigating for COVID-19 antibodies.
At least when we are attributing the vaccination to the pathology.
Exactly, sir.
Please listen to my answer completely
sorry, sir,
first.
Sorry.
Attributing to the pathology. What is the evidence of connection? At least that is the only thing which right now is available.
Yes, sir.
At least we should have make an attempt to do what is the status.
Yes, sir.
Like you said, that statement is correct. It is quite variable. Some of the post-vaccination cases, yes, only around 10 micrograms or something like that. Some of them are having 100.
Yes.
But it is variable. Similarly, this may not be related with the COVID vaccine itself. At least to say that it's only an observational study, right? It's okay. But observational study also, the number is very small. When the number is very small, so at least we should make an attempt to analyze. That is the only aspect where we try to link the disease.
Yes, sir.
Then how many of them had the Covishield? How many of them had
Sir, all the patients we specifically asked, they had Covishield vaccine only, sir.
So only Covishield?
Yes, sir.
So Covishield, what is the type of reaction?
Sir, AstraZeneca vaccine, sir, that antigen.
What is the mode of action? Yeah.
Yes, sir. They induce a inflammatory response, sir.
Type 4.
Yes,
it's
sir.
A type 4.
Yes, sir.
Yeah.
They induce that response so that it can result in vascular events.
How many of this, out of this 6, how many
yes,
of them had the diabetes? How many of them had the hypertension?
Sir, in the 6 patients, 4 or 5 patients had either of them, sir, and 1 patient didn't have anybody, hypertension or diabetes, sir. But in all the 4 or 5 cases, it was either recently diagnosed or they were in well controlled, sir. When we asked about their systemic status, they told that this was under control. So what we thought was, since the recent onset, in the sense that either some are recently diagnosed or with very short history of systemic complaints and with very good control. So we thought that removing that factors aside, there is an acute event which has happened in the form of vaccination. So we thought that generally it can happen, sir, but since this is an inciting event and literature was very scant, sir, to be frank. So when we went back and searched, we did get 1 or 2 articles where it told that, because when we asked patients, they told all the patients had Covishield, sir. So we wanted Covishield. So when we went back to the literature and searched, that as you said, sir, that type 4 like inflammatory response and those vaccine, what the complex which was there, it could even directly damage the endothelial cells. That's what was there in anecdotal reports, which has been recently published in AJO, sir, by Lee Jampal et al, sir.
Yeah, now roll.
Sir, and one more thing, sir, I do agree, sir. It is not something which we would like to hammer that this is definitely, it's not a casually, we cannot tell that, yes, this is there. But the intention of the thing was, many things are not known post-COVID-19 vaccination. It's just a lot of things are in learning phase. We just wanted to see if we could get something out of it. And if somebody complains of a condition wherein they had a COVID-19 vaccination, and when we see a condition like this, or if somebody has an ocular complaint, we thought at least it is important to educate people to dilate the fundus and see, and who knows that an evolving thing like this can appear. So that was the main.
Almost 60 to 70% of the population is now vaccinated.
True, sir. Not everybody will develop. So if anybody has an ocular event, so what our intention was to tell that, okay, if you have something, somebody comes
maybe your statement you should little modify. When there is a vascular occlusion, think of the.
Yes, sir. Yes, sir.
That is a better
actually
recommendation.
True,
rather than saying go and observe, examine the fundus for each vaccinated.
Yes, sir. This should be taken
as a reverse way. It should be a better one.
Yes, sir.
Okay. So yeah.
See, you initially told that this vaccine led even to CVT.
Yes, sir.
There are reports of MI also.
Yes, sir.
When particular event had occurred in the eye, was the patient sent for general examination to rule out any systemic, any other vascular areas, whether any inciting events? Was any other, any organ could have been involved.
True, sir.
So a liver function test or a renal function test, everything would have helped you, and that will give more weightage to your study, because that is even more important.
True,
so
sir. Very true.
If, for example, there are cases when you are using a procoagulant effect, S protein, so these are known to cause multiple clots all over the body.
Very true, sir.
So I think that's very important point.
Sir, to add upon this, sir, we generally advised blood investigations in the form of D-dimer levels. Those were advised in all the patients, sir. Those were normal. We did try, though we didn't send it to a physician telling to examine, but in all the patients we did have an effort to write blood investigations, which I did mention in the.
Yeah, at least you should have investigated it. See, the another thing is papillophlebitis is again we cannot explain.
Yes, sir.
So that is, sir, on one side we are saying hypercoagulability, on the other side we are saying inflammatory. So maybe a little confusing here.
Sir, exactly, sir. To be very frank,
I know.
The associations and all, why we were suspecting was this atypical presentation, sir. Right. One of it, they're having a BRVO with a papillophlebitis, with a artery occlusion, with a vein occlusion, where generally in a normal sect of population, in normal cases, we don't see such kind of presentations also, sir. That was one of the things which were led to a thinking of just.
Yeah, two things I'll argue with you. See, one, you said none of them had the COVID. Okay, fine. The second thing, so we have not tested. There may be a chance of subclinical COVID and developing antibodies.
That's what I
or
was
the
saying.
hypercoagulability state that may be causing, or the vaccine may be exciting that. So who knows?
See,
so at least that is basic investigation. One should know before that. The second argument with you is the sudden spot or increase in the number of the vascular occlusions. That is again in favor of, goes towards me. That is, maybe those patients might have had the COVID, and then that was one of the explanation. Vascular occlusion. Yeah. So that is the another thing.
Sir,
So
one
like
thing,
this, there are many things I think.
even before the vaccines have come, they were saying COVID may manifest as a vascular occlusion.
Yes, sir. Yes,
so how do you correlate now?
That's what, sir. We, at least by history taking.
Meaning thereby what he said, subclinical COVID can
Sir,
also have the same problem.
Yes, sir. We did think of antibodies, sir, but that points are actually in the medical fraternity, in the doctors group, what we had, we were seeing post-vaccination and post things, we had a very varied response of antibodies, sir, to be frank. So we did think about this, but we didn't go ahead with that, sir, because of the variability of antibody levels which we found among vaccines. Yes, sir, COVID-19 would have happened, and that in result would have given rise to antibodies. That is definitely a point
already
which we would.
exposed to COVID. Because of your vaccination, the response is multiplied. Because if first dose
Yes,
will
sir.
be less immunity reaction, second dose will have a more reaction.
Yes, sir.
Something like that. After the vaccination, we already exposed to the COVID.
True, sir.
Might have had a higher level of immunogenic response. We do not know.
Thank you, sir. Thank you.
Thank you, Ashok. Next, we have Dr. Arvind Roy, who is the winner of Raghavachar Best Paper. He'll be presenting on spectrum of microbial keratitis during post-COVID convalescence. Go ahead, sir.
So a very good afternoon to all, and thank you for the opportunity to present at the GR Reddy Best of APOS
7 minutes,
session.
sir.
Yes, sir. Thank you. So we do not have any disclosures or conflicts of interest. COVID infection occurs primarily through two receptors, the TMPRS and ACE2, which leads to engulfing of the virus into the live cells, following which there is multiplication and cell rupture. As the COVID sequelae evolve, the long-term sequelae of COVID are coming into fore, and the attributes and predictors of a new entity in medicine that is being reported nowadays is that of long COVID. So this viremia that occurs after ingress of the virus into the cells peaks by 1 to 2 weeks, following which it gradually subsides. But there are long-term sequelae which are seen beyond 4 weeks, where multi-organ systems are affected, and this is perhaps what we were discussing a while ago. And that involves multiple large solid organs. But how this affects the eye is not very well known. Causal association will take some time before we understand that. But we also see several simultaneous infections or inflammations in the different ocular structures. With this background, we decided to go ahead and study the pattern and spectrum of keratitis in patients who have recovered from acute COVID or who are going through a phase of acute COVID. So in this series, we studied the 18 eyes of 16 patients with microbial keratitis during the post-COVID convalescence. 14 patients were having a unilateral affliction, and they presented between 1 to 93 days post-COVID. These patients were either positive for COVID with a RT-PCR or were in close contact with a positive patient who were diagnosed with COVID. The study was approved by the Institutional Review Board. The comorbidities that we noted in these series of patients were that they were having either antecedent diabetes or hypertension chiefly. Many of them were hospitalized. There was history of oxygen administration or the use of systemic steroids. Typically, we saw the distribution of fungus and microsporidia as the chief organisms, which were the causative organisms for keratitis. And all eyes resolved by 1 to 6 weeks of follow-up. Medical management alone helped in 9 eyes, whereas therapeutic keratoplasty was needed in 5 and tissue adhesives in 2 patients. So with this, I will be just sharing the brief clinical scenario of these patients. One was the microsporidia stromal keratitis and keratoconjunctivitis. So we saw both the spectrum. So keratoconjunctivitis was in this 14-year-old female who was not tested for COVID but was cohabiting with their family who was COVID positive a month ago, and with a 1-week history of blurring and redness in both the eyes. As we can see, the right eye has punctate spots, and that yielded on scraping microsporidia, and on a PCR also it yielded microsporidia spores. She resolved well, but there was something very unusual about this case. She also had an anterior uveitis. That is very unusual in microsporidia stromal keratoconjunctivitis. And when we performed a specular, we saw that there were pseudogattate. And this slowly resolved over a 2-week period. The left eye, which was where the cornea was clear, had a relatively normal specular study. The visual acuity improved gradually, and as we can see, after 2 weeks, the visual acuity had improved, and so also was the specular. The other was an interesting case of an elderly gentleman who had a 9-month history of bilateral affliction and was treated elsewhere over multiple medications. So he presented with bilateral infection of the cornea, and there were deep plaques which were suggestive from the clinical course of a microsporidia stromal keratitis. Based on this suspicion, we performed a confocal microscopy which showed linear hyperreflective dots and a corneal biopsy that showed the divergent corneal stromal lamella with debris, and the acid-fast stain showed that there are acid-fast short stout organisms. When we revisited the history, the patient belonged to a region which was a hotspot for COVID in Maharashtra. He had a history of a dip in river water, had symptoms of ocular symptoms 2 to 4 weeks prior, and also had use of a herbal medication. So in this condition, usually we go ahead with a therapeutic keratoplasty, and the patient was apparently doing well, and the buttons also yielded microsporidia stromal keratitis, but there was a suspected recurrence for which fumagillin was added. This was another interesting case of a 71-year-old male who was COVID positive, recovered, was on IV Dexa and remdesivir. The first presenting visit pictures are not available, but there was severe lid excoriation. And as we can see that this was a case of an ophthalmic zoster sign herpes, meaning that the symptoms were only limited to the eye alone. And with the antivirals, they started healing well and the surface recovered, but as we can see there is a punctal stenosis and a ectropion. And this was the case of a young male who had a non-specific redness of eye, and he was treated as conjunctivitis somewhere, and what we saw was that there was an interpalpebral area of a small plaque on the paracentral cornea. This plaque yielded plenty of fungal filaments and he resolved rapidly. Now this is one end of the spectrum. What we are, one more, yes, I'm finishing. What we also saw that this patient resolved very rapidly, and this was another patient where there was bilateral keratitis. So again it was a fungal keratitis, Aspergillus niger, which healed with natamycin but after 4 months of treatment. So this was another patient of a pythium keratitis. As we can see that again this was an interpalpebral lesion, there were tentacle dot-like lesions there, and this yielded pythium, but the load was very low, so the growth was negative on culture. So why do we see this kind of a lesion? As per this report in British Journal of Ophthalmology recently, the corneal sensations are affected in COVID. So this is a normal eye, and this is the acute COVID eye, and this is the long COVID eye. So what's happening here is that there is a significant dropout of the corneal branching nerves and increase in dendritic cells. So our understanding is that long COVID may affect activities of daily living. There may not be a causal association, but there is a temporal association. And the decreased sensation might be the reason why we see such altered sensations and why we see a very abnormal course of microbial keratitis. Thank you very much.
Thank you, Arvind. Questions? So usually microsporidial keratitis, the most common form we see is keratoconjunctivitis, where the epithelium is mostly like this discrete thing.
Yes.
But both the cases you showed were stromal.
The first case was a microsporidia keratoconjunctivitis, but atypical because we also saw a concomitant anterior uveitis.
Correct.
That is very unusual for microsporidia keratoconjunctivitis.
Yes, yes. So, and then you had 2 more cases that were stromal, right?
Stromal keratitis where the patient had a bilateral affliction.
Yeah. So
and an elderly gentleman.
So stromal keratitis, usually in our experience we see in immunocompromised.
Typically it is seen in immunocompromised.
So was that workup done for these cases? Was that workup done for those cases?
So this patient was actually having a history of hospitalization.
Okay.
He had a long-term history of systemic, I would say, medications being given. His son was a physician. He was treating him at home.
Okay.
And multiple drugs were given at different places for 9 months before we could even diagnose that condition.
Yeah, microstromal keratitis very difficult to treat.
Yes,
so you had to go ahead with the TPK.
Yes.
The bilateral case, how did you manage?
So that case, bilateral therapeutic PK needed to be done. So first we confirmed the diagnosis with a corneal biopsy, and when we got the acid fast stain positive, we performed one eye and then the other eye.
Okay.
What is the final message?
Sir,
what is new in this?
In this scenario, what we noted is that there are abnormal corneal sensations in 10 out of 18 eyes in our series. Sensations were abnormal. These were routine cases of keratitis that we also see in normal patients who do not have COVID. But the clinical course is that it is limited to the interpalpebral area. It is seen in the post-COVID convalescence. It has a typical appearance of a neurotrophic keratitis, which could be possibly secondarily infected by any organism. And this was our finding. Yes, a confocal could have perhaps added more data to that, But that apart, I think these type of lesions show that there is a underlying neurotrophic keratitis which predisposes such patients to keratitis, microbial keratitis especially.
But in COVID, basically it's a antigen antibody immunological reaction, then viral reaction.
Correct.
Then that causes the more of a vascular changes.
Yes.
And nowhere it's described that it's going to affect the nerves.
Yes.
Maybe whether the circulation to the nerves affected, then secondarily nerves affected, or how can we attribute that to the nerves?
Yes, I think you are quite right. We are also trying to understand that what could be the reason for such a big nerve dropout, because as we see this article from British Journal, which was just recently published, the acute and the long COVID nerve ratios, the nerve densities have significantly decreased as compared to the healthy cornea. So it's possible that either there is a vascular phenomena that is causing a dropout of these nerves, or the cytokine storm that follows in the recovery of the COVID might be a possible causative factor for such kind of a manifestation.
And one more thing, sir, if you see the spectrum of the pathogens, all of them we usually see in an immunocompromised state. Virus,
Yes.
fungal,
Yes.
pythium.
Yes.
You did not see any bacteria or
No,
this thing.
no, we did not see.
And was the history of steroid use taken into consideration?
Yes, many patients had either a systemic steroid or history of
Because that
hospitalization.
could be one of the contributing factors
Indeed.
for the infection.
Indeed,
Especially the hospitalized patients.
Yes, yes, true.
Some patients recovered very well. Usually neurotropic ulcers, they take a very long time to
Exactly.
recover. So
Yes.
those patients where epithelialization occurred very quickly. And how about 14 patients had unilateral.
Yes.
So how about the sensation, corneal sensation in the other eye?
So it was altered in both the eyes, where it was altered, and where it was intact, it was intact. And the other thing, of course, the series is too small to reach any definitive conclusions, but the patients who
No, but
improved
definitely
well,
the other eye corneal sensation was decreased.
it was decreased. Yes.
It's a very valid question.
Yes.
So to attribute that,
Yes.
the other eye also
Has to
they
be
might have
decreased.
reduced.
Yes.
Then we can say
There's a
we can
possibility.
that link to the pathology,
Yes.
single
Yes.
etiology.
Correct.
But I think next time we should check the other.
Yes. No, that's what I meant. That where we check the
Fortunately or
sense-
unfortunately, if the third wave comes, then keep that as a mind and then do some
let
prospective
us
study.
hope that it does not come. Yeah. No, I was just answering sir's question
Yeah.
that the other eye also had decreased sensations.
Okay.
And sir asked that where they healed, the healing occurred in usually the younger patients, whereas those patients who are in the 69, 71 age group, usually it took a much longer time for the healing to occur.
Yes, sir.
But whether it is due to the nerve pathology or not is a matter of conjecture, because that we cannot
For
definitively
me, I
say.
feel it's more like an immunocompromised thing, seeing at the pathogen spectrum.
Indeed.
Because there everybody has used steroids.
Yes.
And that is one possible cause. Thank you. Thank you for a wonderful presentation.
Thank you so much.
Next, we have Dr. Deepthi, who will present on adjuvant RAM in post-COVID ROCM. She is the winner of T. Sachinarayan Reddy Best PG paper. Congratulations.
Thank
Please
you,
go
sir.
ahead.
Good afternoon, sir. I am Dr. Deepthi from Rangaraya Medical College, presenting a paper on adjuvant RAM in post-COVID ROCM. I have no financial interests. Mucormycosis is an aggressive fungal disease caused by Mucor rhizopus and Apsides species. Occurs through the inhalation of fungal spores, more commonly seen in immunocompromised patients with poorly controlled diabetes. In recent times, sudden surge of cases seen in patients positive for SARS-CoV-2. Mainstay of treatment involves reversal of patient's immunocompromised state, systemic antifungals, and surgical debridement. There are no proper guidelines for management of mucormycosis in the literature, but literature studies showed a unique and potentially globe-sparing approach, that is retrovulvar amphotericin B injection (TRAM). It is usually recommended in preserved vision with focal involvement of orbit, unavailability of amphotericin B for IV use, and following sinus debridement where orbital wall has been breached. This is a prospect.
Good afternoon. I'm Dr. Deepthi from Rangarai Medical College, presenting paper on adjuvant RAM on post-COVID ROCM. Mucormycosis is an aggressive fungal disease caused by Rhizopus absidia and mucor. These four sentinel, they cause spread to the adjacent structure and cause rhino-orbital mucormycosis, seen in immunocompromised patients with poorly controlled diabetes. A mainstay of treatment involves a reversal of patients' immunocompromised state, aggressive treatment with systemic antifungals, and surgical debridement. There are no proper guidelines for management of mucormycosis in literature, but there is a unique and potentially glow-sparing approach, that is TRAM, usually recommended in preserved vision with focal involvement of orbit, unavailability of amphotericin B, and following sinus debridement where orbital valve has been breached. This is a prospective interventional study done in 50 patients admitted in mucor ward after radiological diagnosis in Rangarai Medical College, GGH, Kakinada from June 1st, 2021 to 31st August 21. A patient with radiologically proven ROCM stage 3 and 3B at the time of admission. Patient with history of SARS-CoV-2 are included. Patient with no history of SARS-CoV-2 and patient with history of other immunosuppressive disorders and patient with stage 1 and 2 of diabetes with no orbital involvement are excluded. Patient with history of COVID-19 presenting symptoms of ROCM subjected to RT-PCR test. Detailed history was taken. ENT, dental, ocular examination was done. DNE radiological examination was done. Nasal swab was taken for KYH and culture. Complete ophthalmological evaluation was done. Blood investigations are done, including random blood sugars, blood urea, and serum creatinine. These patients were monitored daily by team of doctors. Coming to procedure of time, patients was asked to lie in supine position based on IOP was noted. Under aseptic condition, 1 ml of diluted liposomal amphotericin B was taken and given as retrobulbar by injection. Any reactions to drug or Foley technique was noted. These were given consecutively for 3 days. Daily monitoring of IOP and alternate monitoring of urea and creatinine was done. They were continued on systemic antifungals and subject to sinus treatment. After 4 weeks, they were discharged and followed up weekly. Response to TRAM complications were noted. The mean age of the patient presented was 50 plus or minus 10 years. Sex incidence, it is more in males compared to females. Average duration between COVID positivity and ROCM is 23 days. Average visual acuity in affected eye is 618. Most of the patients presented in stage 3B of the disease. Outcomes, spread of the disease halted in 42 patients, progressed in 8 patients, complications observed in 7 patients. In patients with progressive orbital disease where FES was delayed, TRAM injections were given. Orbital spread was curtailed in those patients which allowed for growth preservation. This is an endoscopic picture of orbit in patients with ROCM given TRAM showing curtailing of the disease spread. This is a picture of the patient with complete ptosis, chemosis, and external ophthalmoplegia. After TRAM and sinus debridement, chemosis regressed, ptosis and external ophthalmoplegia got improved. Complications occurred in 7 patients. In that, raised intraocular presence seen in 4 patients, tetrabulbar hemorrhage seen in 1 patient. These were managed medically by tablet acetazolamide 250 mg BD for 3 days. Vitritis and yellowish discoloration of conjunctiva seen in 1 patient each. Further progression of disease observed in 8 patients. 7 were managed successfully with IV amphotericin B and FES. Only 1 patient needed orbital exenteration. 1 patient succumbed to death. This is a picture of the patient with orbital exenteration after TRAM. Coming to discussion, mucormycosis is recognized as a rare fulminant life-threatening disease presented in many forms which include rhino-orbital cerebral, pulmonary, cutaneous, gastrointestinal disease. With onset of COVID-19 pandemic, we have seen an alarming rise in the case of ROCM. Background of poorly controlled diabetes is the main reason. Further steroid therapy also leads to the waning immune response. Angioinvasion is the hallmark of invasive mucormycosis. This leads to typical vision loss, premaxillary, and necrosis of underlying bone. With progressive disease on maximum systemic medication, retrobulbar antifungal treatment selected as a non-surgical option. The case reports have been shown that retrobulbar antifungal treatment has been with successful outcome. Sometimes the surgery can be delayed due to logistics like high volume of patients, elevated D-dimers, and uncontrolled blood sugars. TRAM given in these patients showed response in the form of halting the progression of the disease. TRAM injection, it causes a post-injection pro-inflammatory state called orbital compartment syndrome, which can be managed by lateral canthotomy. But we did not encounter any orbital compartment syndrome. And so close monitoring of patients' orbital examination, including IOP, was critical. In our study, 4 patients developed IOP, raised IOP, which was managed medically. Coming to conclusion, it is a fulminant disease leading to fatality within 72 hours. But in case of delay in phase in progressive orbital disease, retrobulbar amphotericin B should be considered as an option prior to exenteration to halt orbital progression. Though it carries its own risks, it can be a successful therapeutic alternative to conventional therapy, which allows for orbit and globe preservation. Thank you.
How many of them did receive the systemic amphotericin treatment of these cases?
All patients are received, sir.
All the patients.
All patients are.
How long?
Every patient who has gone to first.
Before initiation of your treatment?
No, sir, not before initiation of my treatment. After initiation of my treatment, sir. Before going to first, because of unavailability of amphotericin B, we haven't started on amphotericin B initially, sir. All were started on injection posaconazole, stage 3 patients, stage 3A and 3B. From 3C patients, we have given IV amphotericin B from the beginning, sir. So before, after first, they were given IV amphotericin B, sir.
What was the status of the diabetes in all these patients?
All patients are already diabetic, non-diabetic or de novo diabetic during COVID, sir.
Status, whether it's poorly controlled, how many of them are in good control, how many of them are in
At the beginning of the infection, most of them, all of them are poorly controlled, sir. But we have a general physicians team. They made sure that blood sugars are under control, sir. With long-acting insulin, glargine, they kept on insulin, sir. So we controlled it for this surgery, sir. Initially, they were poorly controlled, sir.
Are you aware of the site of injection? Was it given supero?
No, sir. Infromedially we have given, sir, towards the apex. Infromedially. Single site only we have given, sir, for 3 days.
There is an ethical issue in these photographs and all, and have you taken the consent from the patient?
Yes, sir, we have taken.
See, we are putting everything online.
Yes,
and everything is transmitted.
We have taken consent.
You have shown the face completely identifying the patient. You must close either nose and mouth and then forehead, everything you should close it. So otherwise, this becomes an ethical issue. We can't even allow them to publish.
We have taken written consent from each patient, sir.
But you have to cover them. Otherwise, even after going to be published, we won't publish at all. Because it's something which is very, very unethical. We have to maintain what is called privacy of the patient. We have to protect.
Yes, sir, there is an ethics board in SPM department, sir. Yes, sir. My co-author, madam, made sure that. Yes, sir.
From Rangaraya.
Yes, sir. Yes, sir, we can cover her mouth. Okay, sir. Yes, sir. I can. Okay.
Thank you, Deepthi.
Thanks.
Next, we have Dr. Tanuja, who is the runner-up for Dr. T. Satyanarayan Reddy Best Paper. Congratulations. She will present her study on intrastromal voriconazole for recalcitrant fungal keratitis, prospective study. Please go ahead.
Good morning, everyone. Today, my paper presentation is on intrastromal voriconazole for recalcitrant fungal keratitis, a prospective study. My author is Dr. C.S. Sandhya Madam and myself, the presenting author.
Good afternoon, everyone. Today my paper presentation is on intrastromal voriconazole for recalcitrant fungal keratitis, a prospective study. Myself, the presenting author, Dr. Tanuja. Microbial keratitis is a common vision-threatening disease occurring in all parts of the world. In South India, fungal keratitis accounts for 44% of all corneal ulcer. Intrastromal voriconazole proved to be an effective and adjuvant treatment modality in selected patients who are unresponsive to other forms of antifungal therapy, as it delivers high intracorneal drug concentration at the site of infection. Aims to study the effectiveness of intrastromal voriconazole in recalcitrant fungal keratitis, and objectives are to study the demographic profile of fungal keratitis, to study the clinico-microbiological correlation, and to analyze the effectiveness of intrastromal voriconazole in recalcitrant fungal keratitis as an adjuvant to topical drugs, and to study the complications which are associated with intrastromal voriconazole in fungal keratitis. It is a prospective interventional study conducted between November 2019 to October 2020 at SV Medical College, SVRRGGH, Tirupati. Inclusion criteria: all patients with smear or culture positive fungal keratitis of more than 2 mm in size with deep stromal infiltrate or endothelial plaque or presence of clear cornea were included in the study. All patients with fungal keratitis who are not responding to topical antifungal drugs for at least 7 to 14 days, and all patients of fungal keratitis who are willing to participate in the study and who have given written and informed consent were included in the study. Patients with total corneal ulcer and patients with impending corneal perforation and patients with associated endophthalmitis were excluded from the study. Oriconazole is a triazole antifungal agent structurally related to fluconazole with a fluoropyrimidine group. After administering peribulbar or topical anesthesia under aseptic conditions, the preloaded drug should be administered under the operating microscope. With the bevel down position, a 30 gauge needle is inserted obliquely from the uninvolved clear cornea to reach the abscess at midstromal level. The drug is then injected and the hydration of the cornea is used as a guide to assess the level of cornea covered. When the desired amount of the hydration is achieved in the cornea, the plunger is withdrawn slightly so as to ensure the discontinuation of the capillary column and to prevent back leakage of the drug. The drug is given in divided doses around the lesion. The study is included 30 eyes of 30 patients with fungal corneal ulcer with or without hypopyon and endothelial plaque. All in the depth of the corneal involvement was assessed by anterior segment OCT and slit lamp examination. The age of the patients in the study ranged from 25 to 77 years with a mean being of 53 years, and majority of the patients were males. Most of the patients were agricultural laborers, that is 33%, which is followed by farmers and homemakers. Nearly three-fourths of the patients had trauma with vegetative matter, which is followed by chronic topical steroid usage and followed by chronic dacrocystitis and lag of thalamus. More than half of the patients had fungal ulcer in left eye, and almost half of the patients had central corneal ulcer, that is 46%, and paracentral location is seen in 33% of patients. Majority of the patients had hypopyon as a predominant finding, which is followed by endothelial plaque and satellite lesions. Nearly half of the subjects diagnosed microscopically by Fusarium species, that is 50%, which is followed by Aspergillus and other fungi, which included Candidium. The mean size of the ulcer was 10.78 mm square and mean size of the infiltrate was 23 mm square. The mean best corrected visual acuity of the affected eye shows there is improvement after 3 months of intervention. Coming to discussion, our study results were matched with Kalai Selvi et al. Study and Namrata et al. Study according to age and risk factors. In age, in our study, we have mean of 53 years. In Kalai Selvi et al. Study, the mean was 52 years, and in Namrata Sharma studies, it is 47 years. And comparison of risk factors also, we have a majority of patients have vegetative matter as a risk factor, which is comparable to Kalai Selvi et al. Study and Namrata Sharma et al. Study. The microbial diagnosis, that was Fusarium, was the major cause of causative organism in our study, which is comparable to Kalai Selvi et al. Study and Namrata Sharma et al. Study. And the success rate of intrastromal oriconazole in our study is 76%, which is comparable to other Kalai Selvi and Namrata study, that is 72% and 83% respectively. To conclude, the most common isolated pathogen was Fusarium. Most of the patients were agricultural laborers and had a history with vegetative matter. Intrastromal oriconazole has a definitive role in the management of recalcitrant fungal keratitis as an adjuvant to topical therapy with high success rate of 76%. And the most common age group was 4th to 6th decade with male predominance. No procedure related complications were noted in the present study, and the strength of the study was there was good clinical and microbiological correlation of the fungal corneal ulcer. Intrastromal oriconazole was given as an adjuvant to topical therapy, so effectiveness of intrastromal oriconazole per se cannot be assessed in the study. Thank you.
Thank you, Tanuja. We have a few questions. So it was a prospective study. How many? 30 patients?
30 patients.
Why didn't you randomize 15 patients would have got the intrastromal, then the study would have more power? Right?
Yes.
Because you were using your regular antifungal
Topical
therapy. What
along.
is your antifungal therapy?
Natamycin 5% was given as a topical therapy, sir. If not resolved within 7 to 14 days, then we go for intrastromal oriconis.
No, you are telling most of them had endothelial plaques.
Yes.
Hypopion was there. So apart from your natamycin, what was the drugs you are giving? Except for intrastromal oriconazole.
Topically, we have given atropine drops, sir, and 5% natamycin, 1% oriconazole also, and atropine drops and lubricant drops. Along with that, we have given systemic drugs, Diamox tablets, and
Were any
multivitamin drugs.
systemic antifungals used?
No, sir.
Okay.
We excluded endophthalmitis and scleritis and deep corneal ulcers.
Okay.
So there was no indication for
What-
antifungal.
Which oriconazole was used? There are two kinds of oriconazole. in the market.
Lyophilized oriconazole, powdered form was available as 30 mg.
In that itself, you
Yes.
have two. One is the drops form, one is the PF
Powdered
form.
powdered form. We have used.
Both drops and preservative. You have the smaller
Yes,
one,
yes,
PF.
sir. Yes, sir.
That is preservative free. One is the regular drops we get.
Yes, sir.
Which one did you inject?
Preservative free.
PF, the
form.
smaller
Ah,
one.
ah.
Okay. When endothelial plaques were there, will there be a role for intrastromal oriconazole or should we give intracameral?
We have intracameral will be better than
Yeah.
intrastromal.
And then when abscess is there, abscess should be drained first.
Hmm.
There is no use of injecting intrastromal oriconazole into an abscess. So after abscess drainage, maybe you can give oriconazole. So these are some points. And per se for fusarium, oriconazole will not work. Kada? Fusarium only for aspergillus, oriconazole is there. In aspergillus, again oriconazole standalone therapy will not work. It will have a additive effect to natamycin. Okay. Right.
Placebo-controlled trial. So it would have been a better study than simply giving that and then.
No, sir. Few patients got 3 injections. Few patients got 2 injections. Out of 30 patients, 12 got single injections, sir. They resolved with single injection, and 7 patients got 2 injections, and remaining patient got 3 injections. Out of yes, sir. 7 to 14 days.
7 days is too short a period to wait for resolution. Fungal keratitis, you have to wait at least for 2 to 3 weeks and then see for signs of resolution. Okay? And you should do therapeutic debridement regularly. All these things have to be done.
7 patients underwent a therapeutic penetrating catheteroplasty.
No, debridement.
Debridement. Okay.
Debridement for better drug penetration. Okay. Thank you, Tanuja. Thank you. Next, we have Dr. Samira, the winner of Naina Sriram Best Posterior Segment paper. She'll be presenting on sight-threatening intraocular infections in patients with COVID-19 in India. Please go ahead, madam.
Very good evening to all of you. Systemic bacterial co-infection in hospitalized COVID-19 patients has been reported to be 7% and the incidence increased to 14% in presence of ICU admission. Systemic fungal co-infection in hospitalized COVID-19 patients are also not uncommon. There are anecdotal reports on presumed intraocular infections such as endophthalmitis. With this background, we did a study titled Sight-Threatening Intraocular Infection in COVID-19 Patients in India. It was a retrospective chart review of prospectively collected COVID-19 patient data between April 2020 to January 2021 at LV Prasad Eye Institute, Hyderabad and Vijayawada. Laboratory confirmed cases of SARS-CoV-2 patients reported to us for endophthalmitis management within 12 weeks of discharge from the COVID hospital were included in the study. The data included is gender, associated comorbidities, time to onset of COVID-19 symptoms, time to onset of ocular symptoms, history of admission to hospital ICU, complete COVID care, occurrence of sepsis, biochemistry including inflammatory markers, culture report of blood, urine tissue biopsy, and oxygen therapy. A comprehensive eye examination was done for all patients. Endophthalmitis management was done as per institute protocol. Vitreous biopsy was subjected to gram staining and calcofluor white mount. The vitreous biopsy sample was inoculated in different solid media as well as into the different liquid media. The species identification was done using Vitek 2 compact system. PCR for eubacteria, panfungus, herpes virus type 1 and 2 were done whenever possible. Vitreous sample was also subjected to RT-PCR for SARS-CoV-2 virus whenever possible. There were 33 eyes of 24 patients. Cases of endogenous endophthalmitis coincided with a peak of COVID-19 in both the states. Mean interval of COVID-19 systemic symptoms to ophthalmic symptom was 15 days, ranging from 6 to 72 days. Mean age at presentation was 53.6 years, ranging from 5 to 72 years. There were 17 males, 90% had systemic comorbidities, 9 had bilateral affection. Majority had anemia, thrombocytopenia, lymphopenia, neutropenia, along with raised inflammatory biomarkers, C-reactive protein, IL-6, LDH, D-dimer, and serum ferritin. All had received broad-spectrum systemic antibiotic. 21 out of 24 had received systemic corticosteroid in the form of intravenous methylprednisolone with or without oral corticosteroid. The ocular included 32 eyes of endophthalmitis and 1 eye of panophthalmitis. The ocular manifestations ranged from pre-retinal and vitreous exudate to complete vitreous abscess with involvement of ocular cords and orbit. Mean presenting visual acuity was 0.0415. All had presented with pain, redness, blurring of vision. In vitreous biopsy, 11 showed fungi, 2 were bacteria, and 1 was virus. 11 out of 21 subjects had some kind of systemic focus of infection, which included 5 candidemia, 3 bacteremia, 1 aspergillus, and 1 mucormycosis. At a median follow-up of 90 days, 19 patients recovered and 5 patients deceased due to COVID-19 related complications. After a primary vitrectomy, vitreous biopsy, systemic and intravitreal antibiotic, 6 eyes received silicone oil injection, 13 eyes received multiple culture-adjusted intravitreal antibiotic and antifungals as additional treatment. At the last follow-up, 13 eyes of 11 patients had severe visual impairment, 9 eyes of 8 patients had functionally improved vision. This is a 58-year gentleman with right eye involvement showing pre-retinal exudate. The microscopy of vitreous biopsy showed thin fungal filament, that is growth in the culture, blood agar and chocolate agar, and the species was identified to be Candida tropicalis. This is another gentleman with right eye involvement, the V-scan showing exudative retina detachment and thickening of the ocular coat. The microscopy showed sefted fungal filaments in gram stain as well as in calcofluor white, and the SDA showing growth, and the species was identified to be Fusarium equisetae. Another gentleman, 65 years, showing bilateral involvement. The vitreous is showing vitreous abscess. The microscopy of vitreous sample showed septed fungal filaments in gomodimethylamine silver staining as well as in Giemsa staining, and PDS showing growth. And the species was identified to be Aspergillus flavus. The limitation of this study is being tertiary care referral nature of our practice could have skewed some of the clinical presentations. Lack of the denominator of total hospitalized COVID patients and their systemic comorbidities and interventions limit the conclusion drawn in the study. So, endophthalmitis is a rare but not uncommon occurrence in patients even after hospitalized care for COVID-19. It is associated with high mortality and blindness. Ocular infection is correlated with associated comorbidities, hospitalization, ICU admission, systemic therapy with broad spectrum antibiotic, corticosteroid, IL-6 inhibitors, raised inflammatory markers, indwelling catheter. Candida species are the commonest organism in this series. So we recommend the inclusion of a routine eye examination and estimation of vision as part of standard of care for hospitalized patients with COVID-19. Thank you.
Very nice presentation, madam. Incidentally, my thesis topic is endogenous endophthalmitis. I had 21 case series reports in 3 years in Madurai over a period of 3 years, and you presented just 21 cases in 3 months. That's a huge number. And second thing, here in cases where you couldn't get systemic, did you try to analyze, okay, they presented to you or they presented to you very late?
They presented to us for endogenous endophthalmitis management. All were hospitalized patients for COVID-19.
Yeah.
And they
During the hospitalization, whenever endogenous endophthalmitis is suspected, it is always mandatory to check the fluids. It is very mandatory that you check the fluids and IV cannulas, and you have to send them for culture also, because 11 patients you didn't get any systemic infections. So that is one of the most important cause of infection. And Dr. Amod Gupta paper is there from PGI, where he has shown that in North India it is very common among the IV fluids and cannulas. That's how they get endogenous endophthalmitis.
Yes, that's a very important question. Amongst 24 patients, 3 had COVID care at a tertiary level center, like, in a very good ICU. Rest had COVID care in different secondary and primary care level. So routine culture from the bronchoalveolar lavage or IV fluid, IV cannula, and from the urinary catheter were not done for all cases.
All the patients who were admitted, how many are intubated, how many are not intubated? Because
2 had, yes, 2 had ventilator during their COVID care. Two is a very small number to compare, but definitely these 2 patients were very sick and they presented with bilateral involvement, and the visual prognosis was also not good in these 2 patients. The final visual acuity was less than 2400 in the best eye.
Any immunocompromised patients with a high dose of steroids and then diabetics, systemic antifungal and then the endogenous infections are common. So what is new here?
Yes, we compared our own endogenous endophthalmitis data pre-COVID time and this time. So we found that in pre-COVID time, the mean age at presentation was 23.5 years. Here, our mean age is 53.6 years, ranging from 5 years to 72 years. This, if you exclude this one child, 5-year-old, then the mean age will be even higher. So it means the elderly people were affected more in this COVID pandemic. First thing. Second, in our series in pre-COVID time, the systemic infection that we found was only 20 to 30%. 20 to 30, it was 22 point something percent. Whereas here, all had focus of infection systemically and proven in microbiology 11 out of 21. That is second. The third one was vitreous biopsy being positive. So here it is more, and it is 14 out of 19 showed positivity, and there the positivity rate is only 30%. The fourth is Majority had fungal infection here, 11 grew fungus, and in that bacteria is majority followed by fungus. But this data, when we compared with our data, COVID time data with that of other parts of the world pre-COVID, then it was little bit similar. Elderly people, presence of systemic infection, presence of systemic foci of infection with culture positivity, and except this fungi part, except the fungi part, it is similar to other part of the world. And endogenous endophthalmitis series from other part of the world during COVID time, only one has been reported, culture positive, I mean. That is from the Italy group, Bilgic et al. They had reported only 3 cases and all had bacterial endogenous endophthalmitis. And in one of the case, they found SARS-CoV-2 infection inside the vitreous. But when we did, we didn't get a single vitreous biopsy positive for SARS-CoV-2 infection in RT-PCR.
Yeah, the main recommendation is even the ICU and all, we should have a watch on the eye. Okay.
Yes.
Thank you.
The common factor in all these patients is they are exposed to high levels of oxygen. Do you see the source of this fungal force or maybe through the oxygen lines? Is it possible? If so, what is your recommendation?
It could be the source of infection, and definitely routine culture and sensitivity should be done from the oxygen tubes that is being used in ICU.
What you have to recommend, because we are you have not added that.
During COVID care,
Because all these patients are exposed to the high levels of oxygen, whether intubated or not, they are kept on oxygen. So their lines may be contaminated. They may have a contaminated spores and all these things. They can be a source of infection for all these patients because these patients are more vulnerable. They are on high steroids and all these things. So their more vulnerability is there. The chance of getting is very high. So this is should be suspected and should be given a priority of keeping them in absolutely in a good sterile state.
Yes, definitely. They presented after discharge from the hospital. So we didn't get a chance to do the culture of the oxygen tubings. But definitely as ICU protocol, we need to implement those things also.
Thank you.
Fungal being very high. In your
11
series,
grew
fungal,
fungus.
Yeah, fungal being very high. And now a patient who is having congestion, you should suspect endophthalmitis also as one of the diagnoses, because patients are terminally ill and they cannot complain about their visual symptoms. That's the first thing. And second thing, are you planning to suggest any bedside intravitreal injections for these patients? To preserve the eye, but that's the main intention, right?
Yes. So for these patients, definitely we can recommend for a routine eye examination. If there is congestion, definitely a detailed eye examination, including fundoscopy. If we suspect endophthalmitis, if the patient is not ambulatory, then definitely inside the ICU, we can inject intravitreal drugs.
Take a vitreous biopsy at the same time.
Thank you, Dr. Samira. The last presentation is from Dr. Padmini. She is the winner of Dr. Vishnuvardhan Best Anterior Segment paper. Congratulations. Please go ahead with your presentation, madam.
Good afternoon, everyone. I'm Dr. Padmini from Vishaka Eye Hospital. My paper for presentation is on comparison of mean and centroid of surgically induced astigmatism for standard keratometry versus total keratometry after a standard cataract surgery. So as we know that modern cataract surgery does not induce astigmatism due to 2 to 3 mm incision size, but it is essential to accurately predict the surgically induced astigmatism to maximize the visual function and subsequent patient satisfaction, especially in toric IOL implanted eyes. The arithmetic mean calculation is mainly based on the magnitude of astigmatism, but does not include the direction of astigmatism, whereas the centroid of surgical induced astigmatism is determined by both magnitude and direction of astigmatism. Hence, the use of centroid of surgical induced astigmatism is beneficial to grasp the overall SIA trends of cataract surgery. So with this in mind, we retrospectively examined 198 eyes of 198 patients who underwent phacoemulsification cataract surgery through a 2.2 temporal clear corneal incision by a single experienced surgeon. We quantitatively measured the magnitude and axis of corneal astigmatism, both for standard keratometry and total keratometry preoperatively and at 1 month postoperatively using IOL Master 700. We assessed the mean of SIA and as well as a centroid SIA and the double angle plots for display of individual SIA distributions by using the astigmatism double angle plot tool that is available on American Society of Cataract and Refractive Surgery website. So this is the website, this is the tool that is available on that website where we need to enter the incision size, the incision location and the device and enter all the right eyes, that is a preoperative astigmatism corneal readings as well as the postoperative corneal readings to get the analysis of centroid. So the purpose of our study was to compare the mean of surgical induced astigmatism as well as centroid of surgery for standard keratometry versus total keratometry. We also tried evaluating whether there was any effect of posterior corneal astigmatism on SIA. We tried to find whether there was any difference between the SIS between the right and the left eyes. So these are our demographics. Our mean age was 60 years with an equal number of right and left eyes and a mean flat keratometry of 43 and steep of 44 diopters with an axial length mean of 23 mm and posterior corneal astigmatism accounting for 0.2 diopters. So this is the graph showing the double angle plot of surgical induced astigmatism for standard keratometry as well as for total keratometry. If we see, the centroid is only 0.12 diopters at 79 degrees, and on the left where there is a total keratometry, even the centroid was also 0.11. So we tried comparing the standard keratometry and total keratometry. The preoperative astigmatism, there was a statistically significant difference between the standard and total, as well as there was statistically significant difference in postoperative astigmatism as well as mean centroid, mean SIA. But the centroid was same in both the standard and total keratometry. We also showed differences for the right and left eye. We found that the centroid for the right eye was 0.17 diopters, whereas for the left eye it was 0.13 diopters. So when we compared the right and left eye individually, the preoperative astigmatism was almost similar in both the eyes, whereas the postoperative also similar. So there was no statistical significant difference in the right and left eye when we compared the mean as well as the centroid. This is the graph showing using total. We also tried with total keratometry for the right and left eye. We found similar results for the right and left eye when we use total keratometry. So this is a summary table showing the preoperative and postoperative values for standard and total keratometry. So to conclude, our results showed that the magnitude of corneal astigmatism did not change from 1 diopter preoperatively to 0.95 diopters postoperatively, and the mean SIA was only 0.31 diopters. On the other hand, the centroid was only 0.12 diopters at an axis of 79 degrees. Even the magnitude of total corneal astigmatism did not change preoperatively to postoperatively. So we found no significant difference in the preoperative or postoperative astigmatism, as well as the mean SIA between the right and left eyes. So this is a comparative study from with that of the other studies. Kamya and et al. Have used automated keratometer with an incision of 2.8 mm, where they have shown the mean SIA is 0.5 diopters, whereas we have used IOL Master at an incision of 2.2 mm, and our mean SIA has reduced to 0.3 diopters with a centroid value of 0.12. So to conclude, the magnitude of centroid SIA largely decreased to approximately 40% of mean SIA, and the direction of centroid shows a tendency towards with the rule astigmatism. And it should also be noted that mean SIA was considerably different from centroid. Especially, this is very important when we are selecting toric IOL model and power. And we also found that there was no difference in the SIA between standard and total keratometry. So centroid SIA is a new concept that frees us from some oversimplified assumption corneas, both in terms of biomechanism as well as mathematical interpretation. The result, the impact of SIA may be negligible compared to the importance it has been given a few years back. Warren Hill, Douglas Couch, Graham Barrett, and many early adopters have advised that a centroid SIA as low as to have a no effect on overall outcomes of our results. So take-home messages: since modern cataract surgery is deemed to be as one of the most refractive surgeries that aims to correct both spherical and cylindrical errors as much as possible. The centroid SIA instead of the mean SIA should be applied for entering the SIA data in the manufacturer's Tori-Kyle software during preoperative planning. These are my references and thank you.
Thank you, ma'am. Okay. Okay. Yeah. So I think most of the participants have left, but luckily we have the winner in the hall, Dr. Samira. Congratulations for getting the GR Reddy best paper. Sir, madam bet you by 2 points. You are the second best. Congratulations to both of you. Congratulations, madam. Yeah. And your presentation was also very nice, madam. Very nice. Congratulations once again from on behalf of APOS and the GR Reddy session.
Who has won, sir?
You be in the center. Winners should be in.